Okay. Good morning, everybody. Welcome to the third and final day of ISNACC 2022. We have another day filled with interesting lectures. And since we are a few minutes late, let me start right away. Our first session, we have our three chairpersons, Professor V. Badrinarayan, Professor Sapna Sirohia, and Professor Shashi Srivastava. Can I have the slide for Dr. Badrinarayan, please? Good morning, sir. He is the professor in the Department of Neuroanesthesia and Neurocritical Care at NIMHANS, Bengaluru. It is MBBS and both MD from Bengaluru. And next we have Sapna Sirohia. She is a senior consultant in the Department of Anesthesiology, Pain, Perioperative Medicine and Pain at Apollo Gleneagles Hospitals, Kolkata for the last, almost 18 years. Previously, she worked at other places like Anandalok Hospital and BM Birla Heart Research Center. In Apollo, she is mostly concerned with both preoperative and intraoperative and also postoperative treatment of all sorts of neurosurgical patients, including various aneurysms, tumors, and endarterectomies, posterior fossa surgeries, and spinal surgeries. And she is also actively involved in the very successful DNB teaching program that is happening at Apollo Hospitals. Right now, it's Apollo Hospitals, it's no more Gleneagles. And finally, we have Dr. Shashi Srivastava. She is from SGPGIMS Lucknow. And she has been the past president of ISNACC in the year 2018 to 2019. She has delivered the very prestigious Professor Goday Oration at AIMS Delhi in ISNACC 2019. She is the current president of Neurocritical Society of India and also the past president of Lucknow chapter of ISA. She has a very large number of publications, 82 in her name. And her areas of interests are neuroanesthesia and neurocritical care. She has also been awarded an international award, the Best Finalist Award in IARS 2012 in Boston, USA. So with this brief introduction, I would request the chairpersons to please take over and carry forward this session. Thank you. Dr. Sirohia, if you could introduce the first speaker. You need to turn your microphone on.
It's my pleasure to introduce Dr. Tumul Chaudhury to the House. Dr. Tumul is a faculty anesthesiologist at Toronto Western Hospital, University Health Network, Toronto, Canada. He's also the Vice Chair for Neuroanesthesia section at Canadian Anesthesiological Society. And his research interests are various brain perturbation during brain-heart interactions, trigeminal cardiac reflex, and the progression of brain cancer and anesthesia. Today, he'll be speaking on the topic, effect of anesthesia on blood-brain barrier and systemic inflammation. So without wasting any more time, over to Dr. Tumul. Welcome.
Good morning, good afternoon, good evening, everyone. Thank you, organizers, for this kind invitation. I'm very happy to present my talk on effects of anesthesia on blood-brain barrier and systemic inflammation. To start with, I don't have any conflict of interest, but my team is looking at different aspects of anesthesia and blood-brain barrier. With this, I will be presenting this talk on these 4 or 5 outlines. That includes a little bit about blood-brain barrier, its clinical context and relevance, and what are the effects of anesthetics, and what are the effects of anesthetics, as well as the role of these into systemic inflammation. And we will look into future directions related to this talk. We all know about a little bit about blood-brain barrier. We're gonna look into a little bit closely now. And if you look at this side at A, so blood-brain barrier has some components related to blood and brain surfaces that includes capillary, as well as tight junctions. If you look into B, it's a bit more elaborated version in which blood and brain intersurface. That includes fenestrated capillaries, choroid plexus, tight junctions, and ependymal cells. When you look into C, it also includes subdural space, arachnoid cells, tight junctions, pile membranes, and cells into the brain tissue. So blood-brain barrier has different components that depend upon the anatomical location. Those components can be a little bit more or a little bit less. And there are areas in the brain where the blood-brain barrier itself does not present. When we look a little bit more closely about the anatomy of blood-brain barrier and its relation to the physiological context, then we will look into tight junctions because some of the paracellular aqueous pathway goes through the tight junctions. So this is the blood interface and this is the brain interface. And this is something important for us to understand because a lot of toxins, nutrients, medications, antibiotics, antiviral, which will we talk a little later, they pass through it or they don't pass through it. So there are various pathways of these chemicals to go in or go out, depend upon paracellular, transcellular, lipophilic pathway, aqueous pathway, transcytosis. So eventually either chemicals will be going in from blood to brain or from brain to blood. So knowing this blood-brain barrier is important, as I told you initially, but does blood-brain barrier disruption has much more problem or it's boon in disguise? We will be looking into in the later slides, but unfortunately, this blood-brain barrier is so effective at protecting against the passage of foreign substances that it often prevents life-saving drugs from being able to repair the injured or diseased brain. So that is something very, very interesting about blood-brain barrier. Sometimes it becomes enemy of itself. So by knowing the anatomy and a little bit of physiological context of blood-brain barrier, I think it is imperative to understand the clinical context of blood-brain barrier integrity and disruption. So by looking at some of the reviews, I categorize into these 3-4 categories, and unfortunately I cannot discuss each and every one for the sake of time, but I'm going to pick 1 and 2. So blood-brain disruptions can lead to various clinical problems and vice versa. That includes infection, cerebrovascular disease, for example, stroke, subarachnoid hemorrhage, cerebral hemorrhage, neurodegenerative diseases, for example, Alzheimer's disease, neuropsychiatric conditions in which blood-brain disruptions can happen or vice versa. With this, I would urge everyone to go through this interesting article about mechanism of disease, the blood-brain barrier, because this special article from Portland, Oregon, highlights the blood-brain barrier, which plays an active role in normal homeostasis as well as in certain disease processes. This article incorporates almost 300 peer-reviewed publications that discussed normal or abnormal blood-brain barrier function. So looking at it, let's talk about infection. There are several types of infection, but specifically talking about those infections which can impair the blood-brain barrier permeability or it can disrupt at all. This can be depend upon the pathogen. It could be bacterial infection or virus infection. And interestingly, sometimes bacteria does more harm for blood-brain barrier permeability and lead to disruption as opposed to virus. And that is why in some of the neurological conditions related to infection per se, antibiotics, because of the disruption of blood-brain barrier permeability, it enters into the brain tissue more vigorously as opposed to antiviral. That is why some of the antibiotics are very efficacious in some of the brain infection as compared to some of the antiviral, which are less efficacious in some of the brain infections. By knowing the blood-brain barrier permeability and integrity, we can also think about a little bit about the role of corticosteroids. Some of you know that the role of corticosteroids are controversial in some of the infection as well as in traumatic brain injury. It is partly because on one way, corticosteroids are essential to reduce the edema, but that edema also depends upon whether it's a cytotoxic, vasogenic, or any other form of edema. But at the same time, corticosteroids also causes stability in the blood-brain barrier integrity. Remember the biochemistry classes from our medical schooling that corticosteroids acts on to phospholipase A2 and it inhibits so that the cell membrane does not disrupt to phosphates and lipids. So therefore, it maintains the integrity of blood-brain barrier. By maintaining the blood-brain barrier integrity, some of the antibiotics does not cross the blood-brain barrier, and hence their efficacy can decrease. So in one way, corticosteroids are useful, beneficial, but on the other way, sometimes depend upon the type of infection and blood-brain barrier integrity, it causes less efficacy to that particular agent. Looking at the cerebrovascular disease from three different perspectives, ischemic stroke in which capillaries they got altered in their function and anatomy, as opposed to vasculopath, that is systematic vasculopath, including diabetes and hypertension, in which arterioles and artery and physiology got altered. When we look into subarachnoid hemorrhage pathophysiology, the venules get affected and some of the complications related to these individual cerebrovascular conditions lead to different complications. For example, rebleed in subarachnoid hemorrhage. So what we know so far related to blood-brain barrier, that certain physiological conditions, pathological conditions, and surgical conditions that altered for sure blood-brain barrier. But what do we know so far about the impact of anesthesia on blood-brain barrier? We do each day billions and billions of surgery across all over the globe. But do we really pay attention, or do we really dig deeper into delineating the impact of anesthesia on blood-brain barrier? So now look at the effect of anesthetics on blood-brain barrier. It is similar to find out a needle from a haystack. So the majority of the studies are limited to animal experiments, and unfortunately, very, very, very little studies have been done in human models. So from the animal data, I just put it in a very simplified version that effect of anesthetics can be delineated on the basis of two major types of anesthetics that are intravenous and volatile. Intravenous, it generally stabilizes and has less impact on the blood-brain barrier integrity as compared to volatile, which causes more harm to blood-brain barrier, causes disruption, increases permeability, and lead to neurotoxicity. And these are mainly dose dependent. So when we look into the clinical context of anesthetic impact blood-brain barrier, we also need to look into this following diagram that blood-brain barrier Either it can be impacted by anesthetic by increasing the permeability or lead to disruption, which in turn causes some of the changes related to cognitive dysfunction, as well as some other post-operative complication, for example, seizures, rebleed. And this is a very interesting article which is published in PLOS One journal, Dysfunction of Blood-Brain Barrier in Post-Operative Delirium Patients. And they quoted that the pathophysiological hallmark of post-op cognitive dysfunction is maybe related to blood-brain barrier disruption. So by knowing the blood-brain barrier and impact of anesthetic in a very minuscule phase, when we look into the systemic inflammation and role of various type of anesthetic, I came across this interesting article which was published in Surgery Open Science, and it's a very interesting systematic review and meta-analysis, and incorporates almost 60 randomized controlled trials. Here we look into 4 different aspects of post-operative systemic inflammation, either in form of off-labels of IL-6, CRP, post-operative infective complications, and respiratory complications. So we're going to look at the various anesthetics in 2 broader categories. Either these are related to TIVA versus volatile, or epidural versus GA. So when we look into the IL-6 levels, there is not much difference between TIVA and volatile, as well as epidural plus GA versus GA alone. But when we look into the CRP levels following surgery and impact of anesthetics, there is a favorable lower of total intravenous anesthetic and supposed to be significant as compared to volatile. But we will look into the epidural combined GA versus GA alone, then it is not significant. When we look into the infective complications, there is no significance with either of these techniques, whether it's a TIVA versus volatile or epidural plus GA versus GA alone. So by knowing these things, I think it is important to understand that TIVA has a little bit of favorable impact on post-operative systemic inflammation, as well as by looking at the animal experiments, it has some benefit in the integrity, maintaining the integrity of blood-brain barrier, and leads to less blood-brain barrier disruption. So maybe we can conclude with a little caution that TIVA is favorable for majority of the anesthetics until unless it's contraindicated. So look at the future directions. As I told you in the very first slide, that our group is exploring the effect of anesthetics on blood-brain barrier in 2 models. One model is related to healthy animals, and other model is related to diseased or surgical animals and humans. We also need to explore the clinical context of all these things, and we also need to know how long these disruptions persist and why it happens, and when it maximizes the chances of having the blood-brain barrier disruption. This is my last slide, and I wanted to give a little hope for the anesthetic research, because we are not limited to only operating room and post-operative or intensive care unit. Our anesthesia visits can go in a very, very big domains, for example, neuro-oncology. This is an interesting study recently published, and what they look into, they instituted volatile anesthetic and increases the permeability of blood-brain barrier. And after that, they have looked into the effect of chemotherapeutic agents in the glioma treatment. And what they found it's that anesthesia-induced increased permeability actually confer more therapeutic benefit for the chemotherapy in glioma cells. With this, I would like to say thank you for your great attention, and I'm happy to take any questions at this moment. Stay healthy and stay blessed. Thank you again.
Thank you, Tumul, for your presentations. We are running short of time, so we'll take up the questions at the end, I think.
Dr. Srivastava, if you would please introduce
Yeah.
Anirban Homchowdhury.
Yeah, sure. Next speaker of this morning session is Dr. Anirban Homchowdhury. He is Director, Professor and Critical Care Expert, GP Pant Hospital, New Delhi. He has got many publications to his credit and lot of chapters, 16 chapters, 1 patents also. He is assessor of the assessor examiner or expert committee member of the various bodies like NMC, National Board of Examinations, New Delhi, AIMS, New Delhi, Institute of Liver and Biliary Sciences, New Delhi, UGC, New Delhi. He has got several awards to his credit, like very prestigious Sarvapalli Radhakrishnan Distinguished Professor Award in 2021. He has presidential citation also, ISCCM in 2019. He got Award of Excellence of ISA in 2018. Honor of Excellence, ISCCM 2016. He got Delhi Pradesh Bhagirath Samman in 2014. And lastly, he got Asian College of Pharmacology Award in 2013. I welcome Dr. Anirban for delivering your talk, which is on, you can go ahead with your talk, Dr. Anirban.
Dear friends and esteemed faculty, at the very onset, I wish to thank the organizers of ISNACC 2022 for giving me this opportunity to present this talk in this August gathering. And for this matter, my special thanks goes to Dr. Indranil Ghosh. The subject of my talk is neurocognitive dysfunction in critical ill. Let us start with this case. A 28-year-old male, a COVID victim, is admitted in the ICU with respiratory failure, where he undergoes prolonged mechanical ventilation, ultimately leading to percutaneous tract on day 7, weaning successfully off on day 15 from mechanical ventilation and on decannulated on day 21 with a GCS of 13/15. And the patient is discharged for home care on day 24. But after being discharged for home care, he returns back to the hospital after 3 days with fluctuating level of consciousness, poor verbal and motor response, and refusal for feed. So what are the possible reasons for these manifestations? Acute brain dysfunction can occur for a lot of reasons, particularly in patients admitted in the ICU, because of systemic insults that are incurred upon the patients during their ICU stay, either in the form of hypotension, hypoxemia, fever, dysglycemias and dysnatremias or other dyselectrolytemias, superimposing their critical illness depending upon the severity, presence or absence of sepsis, and presence or absence of respiratory failure. This may occur in those who have some risk factors in the form of age, raised blood pressure, and pre-existing cognitive impairment, only to be compounded by the effect of medications like benzodiazepines, anticholinergics, and opioids, all of which are used liberally in the ICUs, and along with the environmental effect of noise, the inability to discriminate between day and night, and the prolonged periods of sleep deprivation. Now, all this causes acute brain dysfunction, and the manifestations may vary from delirium as the most common presentation to altered consciousness, coma, seizures, cerebral edema, etc. The cause also may be various: inflammation, neurotransmitter imbalance, blood-brain barrier dysfunction, microglial activation, and so forth. But what is important is to realize that these forms of acute brain dysfunction in the ICU can cause long-term sequelae, and this may manifest either as delayed neurocognitive impairment or may give rise to depression, or social, professional, or functioning may be hampered, and in some cases, there may be early neurodegenerative changes. So neurocognitive impairment is often a part of post-intensive care syndrome, as it spans across a wide range of dysfunction in the survivors of acute critical illness. Now, some of these dysfunctions may be minor and subtle, while some may progress to major, like coma. So therefore, the incidence may vary widely depending upon the entire spectrum, from 3 to 71% and 4 to 56% among the ARDS survivors. The most frequently impaired domains constitute of memory, attention, verbal fluency, and executive functioning. And off and on, they are associated either in the early stage or in the later part with metabolic abnormalities, hypoxemia, fever, sepsis, use of drugs, organ dysfunctions, and all of this may have variable influence in its subsequent course and recovery. So when we consider the neurocognitive domains in terms of the DSM-5 classification of medical diseases, we include the perceptual motor function, the language, the executive function, the complex attention, social cognition, and learning and free memory. In neurocognitive impairment following critical illness, the most common ones include executive function. In executive function, decision-making, working memory, responding to feedback are predominantly affected. In learning and memory, recognition memory, and semantic and autobiographical long-term memory gets affected. In complex attention and social cognition, also the recognition of emotions and insight gets affected. But however, at times, the visual perception and the visual constructional reasoning may get less severely affected in the early course, but subsequently, they may also step in. So most of the studies which have tried to see which of these domains are affected the most are based on the studies which have inconsistently assessed the neurocognitive domains, because some of the studies focused across a wide range of neurocognitive functioning, while others focused across a narrow range of capacities. So obviously, in those studies which focused on narrow range of capacities, some of the functions or some of the domains did not get adequate representation. However, if we see the studies and find that the most common domains that were affected was memory, followed by executive function, followed by attention and processing speed, and also there were some contributions from the intellectual function and the visual spatial recognizing capacity. So there are certain risk factors which predispose certain groups of patients to suffer from neurocognitive impairments later in the course after recovery from their critical illness, such as advanced age, pre-existing cognitive dysfunction, that is prior to ICU admission, genetic predisposition, because it often runs in families, higher premorbid IQ as a negative risk factor, which means a lower IQ predisposes them to have higher incidence of neurocognitive impairment, occurrence of severe sepsis, particularly during their ICU stay, and of course, lower cognitive reserve. Out of all these risk factors, elderly critically ill patients have reported a prevalence of cognitive impairment varying from 17 to 56% and is considered the foremost contributing factor amongst all the risk factors. Its pathogenesis, though not fully understood, can be because of multiple mechanisms. However, it may represent an accelerated neurodegenerative process that develops in vulnerable patients, who has all the risk factors or some of the risk factors. Severe sepsis in particular can lead to neuroinflammatory response, and this may result in increased level of cytokines in the brain. The elevated cytokines can impair memory and also progress to neuroinflammation, and this neuroinflammation may cause the development of Alzheimer's disease as a part of the accelerated neurodegenerative process. Long-term cognitive impairment may represent a maladaptive version of cytokine-induced release because the inflammation may abate at times and then again occur. So there will be recurrent inflammation, and this recurrent inflammation gives rise to fluctuating release of cytokines, and that produces the maladaptive version of the cytokine-induced disease. However, it can be seen that delirium in the ICU can cause long-term complications, and such long-term complications are frequently may lead to neurocognitive impairment in the later course. If you see this study, which was published in INIGEM in 2013, it clearly spells that patients in medical and surgical ICUs are at high risk for long-term cognitive impairment. And when we see the graphs, the box whisker plot, and it is seen that a longer duration of delirium in the hospital is associated with worse global cognition and executive function scores at as late as 3 and 12 months. There are several hypotheses which have been proposed to explain this development of delirium during and after critical illness. Some hypothesis points out to oxygen deprivation, which causes a reduction in oxidative metabolism, giving rise to brain dysfunction. Another hypothesis points to neurotransmitter hypothesis, which suggests a reduced cholinergic function, dopamine access, and noradrenaline and glutamate release, along with reduced or increased serotonergic activity as the cause of delirium. The neuronal aging hypothesis points out or specifies the elderly to be at greater risk of delirium, probably due to age-related changes in the regulating brain neurotransmitter systems. The inflammatory hypothesis points to the increased brain cytokine release as a result of various physical attacks leading to delirium. The physiological stress hypothesis points to trauma, serious illness, and surgery, among other factors that alters the blood-brain barrier permeability and causes euthyroid 6 syndrome. The signaling hypothesis points to fundamental processes such as intraneuronal signal transduction that causes disturbance affecting neurotransmitter synthesis and release. However, all said and done, most of these hypotheses are based on limited data and there is no validation. Therefore, let us believe that it is because of multiple factors which may occur in the different stages in different severity. Also, it has been seen that in long-term outcomes after critical illness is expansive. From post-intensive care syndrome, it can be expanded to expanded post-intensive care syndrome because of inclusion of so many other factors which are often not considered to be part of PICS, but later on, they are also part of the expanded PICS. And among these factors, the baseline status is very important because this baseline status can also gets aggravated by the ICU related factors. And finally, they manifest during the post-ICU condition and care and affect the post-ICU care. So this not only increases costs, social and family problems, causes readmission to the hospital, and reduced healthcare related quality of life. But importantly, it's certain elements which are often overlapping into neurocognitive impairments, such as functional disabilities, other cognitive disorders, mental disorders. Now, all this can also encompass in some form or the other the expanded post-intensive care syndrome. Therefore, a baseline assessment of cognitive status before the onset of critical illness is useful, although this is found to be lacking, and oftentimes it is difficult to determine because the screening results are not available at the time of patient admission because of lack of the knowledge on them. When we talk in terms of COVID, like in our patient, there are comorbidities or hypoxemia which can add on to the vicious cycle of a relay process in which neurological impairment is can commonly occur. A lung disease giving rise to ARDS, giving rise to prolonged mechanical ventilation, use of sedation, immobilization, critical illness, tracheostomy are all be impinged by comorbidities, hypoxemia, and so on. So this vicious cycle needs to be abated during the patient's stay early in the course in the ICU. Most of the time, there are no changes in the imaging except in MRI, which shows certain changes. Most of them are considered non-specific, but when present, they can point to the diagnosis of cause of cognitive impairment like ischemic and hypoxic hippocampal lesions, brain atrophy, ventricular enlargement, decreased superior frontal lobe and hippocampal volumes. And what important is the loss of gray-white differentiation in the corpus callosum and internal capsule. So some of them may be present at times and some of them may be absent. That if 2 to 3 of these lesions are present in the MRI, probably it supports the clinical diagnosis. The time to improvement of the condition varies from different studies. Improvement towards normal cognitive functioning has been reported to occur as early as 9 months after ICU discharge, but many studies have also shown no improvement from 1 year to up to 5 years of follow-up of recovery from the acute critical illness. Studies have also been unable to identify patients who are at higher risk of cognitive impairment or those patients in whom the restoration to normal baseline activity will not happen based upon the cognitive screening tools at the time of hospital discharge. However, elevated serum IL-6 and CRP are associated with reduced cognition, and they contribute to accelerated functional decline in both elderly and also in post-operative cardiopulmonary bypass patients. So inflammatory biomarkers may be useful, and their monitoring for delirium disease activity and predicting the risk of long-term cognitive impairment may be useful. So the time frame in which the damaging mechanism and the endogenous defense activities are addressed is different in different critical care settings, and that also influences the course of this disease. So early in course, there is an increased number of damaging mechanisms, but this damaging mechanism becomes less with time, with an increase in the endogenous defense activity. But if this endogenous defense activity is not sufficient, then the patient does not return to the basal conditions and it remains elevated, which means that cognitive impairment remains or persists much after the critical illness has fully subsided. So how to do the workup in such a patient? History, physical examination, neurological examination, and mental status examination needs to be performed. So cognitive decline can affect either multiple domains. If yes, we have to look for whether delirium or depression. If there is none of them, then there is a check for the decline in function. If it is yes, then it is dementia. So we have to do the blood tests, imaging studies, and other optional studies as indicated to determine the cause. If the cause is treatable, we give the treatment, otherwise we go for counseling. If the cognitive decline effect does not affect across multiple domains, then there is no dementia, or then we suspected dementia. So again, suspected dementia needs neurophysiological testing, follow-up and re-evaluation to determine the exact cause. And in case of delirium or depression, the management has to go as such. However, this may be inappropriate may not be appropriate in the acute stage of illness in the ICU and may require a recovery up to a certain extent before the patients can be subjected to such a form of workup. Now, mini mental state examination is a good time-tested way of evaluating such patients. It gives a maximum score of 30. And this has been validated both for delirium and also many other forms of neurocognitive impairment. The advantages being that it is relatively quick and easy to perform, requires no additional equipment, and it can provide a method of monitoring this deterioration of the cognition over time. However, it also suffers from some disadvantages, like it may be biased against people with poor education due to elements of language and mathematical testing involved in its figuring out. It can have bias against visually impaired. It may have limited examination of visuospatial cognitive ability, and it may have poor sensitivity at early or mild dementia. It is difficult at times to address to such limitations in ICU setting. There is another test that is repeatable battery for assessment of neuropsychological status. Now, this test was first validated in 1998, and after that, successively, it has been used in various conditions, and in some of the conditions have been found to be very useful. Particularly, its sensitivity has been documented in detecting cognitive impairment in a number of neuropsychiatric conditions, including Alzheimer's disease, where it has been particularly found to be useful. The diagnostic accuracy of Arbans in mild cognitive impairment is again a matter of dubious. There is a lot of debate, and caution should be used when diagnosing in conditions like mild cognitive impairment. Some drugs have role in mitigating neurocognitive dysfunction. Haloperidol has been used for many years. It appears to reduce the length of hospital stay among those who develop delirium, and it is used during the course of ICU stay only. Gabapentin helps in reduction in delirium, appears to be due to the opioid sparing effect. Donepezil is a cholinesterase inhibitor that increases synaptic availability of acetylcholine and thereby improves cognitive function. Dexmedetomidine does not have anticholinergic or GABA stimulating effects, but it has the potential to be a delirium sparing sedative. Cognitive rehabilitation is a very important modality in such patients because it provides specific mechanisms to rehabilitate them by correcting those deficits. It involves the teaching of skills and strategies to target specific problems that the patient suffers from, particularly in perception, memory, thinking, and problem solving, with a goal of improving their function and compensating for the deficits. Predicting who will benefit and how much the benefit will be is a challenging task, but even severely disabled patients have sometimes make dramatic recoveries in their neurocognitive status. These benefits are well known in patients with stroke, anoxia, or traumatic brain injury. However, some benefits do occur across all forms of neurocognitive impairment. So my final take-home message is neurocognitive dysfunction in the ICU survivors is common. At times it is severe and in many cases may be persistent. Its prevalence and temporal trajectory differ depending on the cognitive instruments that are used and also on the etiology of critical illness, particularly whether medical or surgical. The use of screening tests like MMSE may underestimate the true prevalence and the extent of cognitive impairment. And there is a definite need for developing ICU-specific cognitive batteries to allow comprehensive cognitive assessment at appropriate time intervals across different etiologies. This can hold promise for all our future endeavors in mitigating these conditions. Thank you for your patient hearing. And if there is time, I am ready to take a question.
Thank you, Dr. Anirban, for a wonderful talk and really a very recently there are so many this area is well explored now and needs further exploration in future, because this is a very pertinent problem in nowadays in ICU as well as in post-operative cases. So I think we can take up cases after the last talk. So Dr. Badri, you can go ahead with the next speaker.
Can I have a CV?
Please go to the CV slide of Dr. Chitra Venkata.
Good morning, everybody, and I thank the organizing committee for giving me this opportunity. I feel honored to introduce our next speaker, Dr. Chitra Venkat. She is a neurointensivist and stroke neurologist who joined Stanford in 2007. She completed medical school and internal medicine at Coimbatore Medical College in India. She did neurology residency at Stanford. Presently, she is the principal investigator for clinical trials in intracerebral hemorrhage, large hemispheric stroke, and resumption of anticoagulation after ICS. She is keenly interested in the novel technologies in the ICU for delivering cutting-edge neurocritical care and has introduced a number of technologies such as cerebral, pupilometers, intravascular, and esophageal choline catheters in the ICU. He trains anesthesia and critical care fellows at Stanford, and she's expressed a desire to collaborate with Indian neurointensivists in education and clinical care. Morning, ma'am, and welcome you to deliver your lecture, ma'am.
Good morning, everybody. It is a great pleasure to be joining all of you virtually at ISNACC 2022 to talk about autoimmune encephalitis, ICU, and anesthetic management. I am a clinical professor of neurocritical care at Stanford University in California. Autoimmune encephalitis comprises of a group of disorders in which the body's own immune system targets the antigens that are expressed in the central nervous system, primarily on the neuronal surface. These antigens are either key synaptic proteins, they are ion channels or receptors, and therefore when they are targeted, they don't function very well, and it leads to direct modulation of critical physiological processes. This was first described in 2007 by Dalmau in a group of women who had ovarian teratomas and who had antibodies against the NMDA receptors. In one of the projects we had in California, the California Encephalitis Project, it turned out that in patients under 30 years of age who presented with encephalitis, when we analyzed their cerebrospinal fluid and their serum, NMDAR encephalitis turned out to be way more common than any other infectious identifiable cause of encephalitis. In a series from Sri Chitra Neurological Institute in Trivandrum, 39 patients, half of whom had NMDAR encephalitis, was reported in a short time frame of only 4 years. So this is seen throughout the world, including in India. It's common in young adults, in pediatrics, and sometimes in older people. It presents with a wide variety of neuropsychiatric manifestations, several of which land the patient up in the ICU. And the key that I want to emphasize here is that early recognition and treatment can lead to dramatic, remarkable recoveries even after months of ICU stay. So what are some of the clinical clues for the neurointensivist? Patients typically present with the rapid onset of viral illness-like syndrome with neuropsychiatric manifestations, which can be, alterations of mood, psychosis, behavior, catatonia, and so on. They can be confused, they can have amnesia. They either come to the attention of a psychiatrist or a neurologist, and then they start having seizures and progress into encephalopathy and coma over a few days to weeks, so an acute to subacute onset in an otherwise healthy young patient. And this is a very classic story that we see for NMDAR encephalitis. In LGI1 autoimmune encephalitis, patients can present with new onset status epilepticus in the elderly population. So briefly, to summarize, it is a combination of psychiatric, neurological, progress into seizures and encephalopathy. Now, how about the workup? Once you have the clinical syndrome, the next part is a workup using lumbar puncture, which typically shows elevated lymphocytes. Protein can be elevated anywhere from a small elevation to a fairly moderate elevation. There can be presence of oligoclonal bands, and IgG index can be increased. When we send off serum and CSF antibody panels, it's not always that CSF antibodies are present. Sometimes they're present only in the serum. EEG can show either ictal patterns, it can show focal seizures, generalized seizures, focal or diffuse slowing. And there's a very characteristic signature pattern called the extreme delta brush that we see in very severe NMDAR encephalitis. So as it's pointed out here, the arrow that's pointing out, you can see the delta waves, and on top of the delta waves, you have this brush-like pattern. The next set of workup is imaging. Imaging is usually in form of MRI because CT scans are often normal. The imaging with MRI using FLAIR, DWI, and contrast sequences will show typically bilaterally symmetrical temporal lobe abnormalities. Now, this is a key differentiation from herpes encephalitis, which can be unilateral or bilateral. In herpes, you can have hemorrhagic lesions, and in herpes also you have extratemporal areas of signal changes, particularly in the orbitofrontal areas. If we do FDG PET, what we see is hypermetabolism in the medial temporal lobes and the frontal lobes, and hypometabolism in the occipital lobes. And the improvement of hypometabolism in the occipital lobe seems to be a marker for the trajectory of recovery. Then we search for underlying tumor, either ovarian teratoma or testicular teratoma, using pelvic MRI, transvaginal ultrasound, or a whole body PET scan. Now, here are some images on the extreme left showing herpes encephalitis, for example, and on the right, you can see autoimmune encephalitis, where you have bilateral mesial temporal. And in the extreme right, you can see the hypermetabolism in the temporal lobe on PET scans. Now, the key is immunotherapy. It is a mainstay of treatment. Early treatment within 4 weeks of onset is associated with an improved outcome. Tumor removal is also part of the treatment because these tumors harbor NMDAR reactive B cells. First line is high-dose steroids, methylprednisolone 1 gram per day for 3 to 5 days. Usually we follow this with plasma exchange, sometimes with IVIG, and then we have a slow oral steroid taper over months. Second line is started if the patient is not showing improvement within 1 to 2 weeks of the steroid. And the second line treatment typically is rituximab, cyclophosphamide, and less commonly azathioprine or mycophenolate. Third line is bortezomib, which also acts just like rituximab against the peripheral CD20 plus B cells. Now, what is most interesting to us as intensivists is what brings these patients into the ICU. It is usually encephalopathy, seizures, or status epilepticus, severe movement disorders which interfere and compromise the airway, uncontrollable agitation, life-threatening dysautonomia, and I'll talk a bit about this, and then severe electrolyte derangements. The cartoon on the left shows the order of autoimmune encephalitis in decreasing frequency. So NMDAR is by far the most frequent. The second one is LGI1, and third are the GABA receptor encephalitis. Now, before I go on to the symptomatic management of the complications, I do want to say a couple of slides about the anesthetic agents that we use in the ICU and in the operating room and the interaction with the NMDAR receptors. As you all know, the two main receptors that are responsible for the action of general anesthetic agents are the NMDA receptor and the GABA receptor. In the NMDA receptor, you have a glutamate and a glycine binding site, and the NMDAR antibodies are directed against both of these. This causes internalization and destruction and decreased surface density of these receptors, and therefore decreased glutamatergic function. Inhaled anesthetics in general inhibit NMDAR function in a reversible, concentration-dependent, non-competitive manner with half maximal NMDAR inhibitory concentration of around 1.2 MAC, and you have additive effects during acidosis. However, in the presence of other NMDAR antagonists like ketamine and magnesium, the MAC is reduced by up to 30%. Ketamine, xenon, and nitrous oxide, they produce your anesthetic effects directly by modulating the function of the NMDAR receptors, the hippocampus and basolateral amygdala. And so the well-recognized phenomenon of dissociative amnesia, delusions, hallucinations, agitation that we see with ketamine. And this is very similar to what we see in our NMDAR autoimmune encephalitis patients. How about propofol? Propofol primarily acts on the GABA A receptors, and it's thought to have minimal effects on the NMDAR receptors only when it is used in supraclinical concentrations. So the jury is kind of still out on the propofol. I think it is relatively safe. However, we do encourage to avoid supraclinical concentrations to minimize the NMDA inhibition. And we also want to be careful when we're using propofol in patients who have hemodynamic instability. What is safe to use? Benzodiazepines are extremely safe to use. Alpha-2 agonists are safe. Etomidate, rocuronium, succinylcholine, muscle relaxants, and opioids can all be used safely. Now, moving on to symptomatic ICU management, the first topic that brings them into the ICU oftentimes is agitation and psychosis, and sometimes this is a long process while they're in the ICU for weeks to months. As I mentioned earlier, NMDA receptor also shares clinical features with neuroleptic malignant syndrome, and therefore these patients tend to be hypersensitive to neuroleptics, particularly the first generation neuroleptics. And when we use these neuroleptics, patients can develop a neuroleptic malignant syndrome-like condition with hyperthermia, rhabdomyolysis, dysautonomia, QT prolongation, and extrapyramidal symptoms. Now, early immunotherapy helps with all of these symptom management, but oftentimes we do have to use symptomatic treatments. And these include, starting with the most simple one, is presence of family at the bedside. In our ICUs, families in COVID times and even in non-COVID times, some family members are allowed to stay in the patient's room for extended periods of time, and this really helps comfort and calm the patients down. We do sleep cycle regulation with melatonin. We try to reduce a dose of medications such as steroids, which actually cause psychosis. If we have to resort to antipsychotics, we use second generation antipsychotics like quetiapine and olanzapine because they have very little extrapyramidal side effects. They do act on the H1 receptors, and that promotes sedation, which is really what we want in these conditions. And then benzodiazepines can certainly be used, and sometimes we use massive doses of benzodiazepines. Non-selective beta blockers like propranolol, alpha-2 blockers like clonidine and dexmedetomidine can also be used. Diphenhydramine by virtue of working on the H1 receptors. And then finally, you can use anti-epileptic drugs such as valproic acid or lamotrigine. You get additional bang for your buck, so to speak, because it will treat your seizures and it also treats the agitation and psychosis. Let's talk a bit about seizure management. Seizures are very common in patients with autoimmune encephalitis. They are seen in up to 3/4 of patients, can be focal, can be multifocal, can be generalized. We talked about extreme delta brush as an indicator of severity. Patients presenting with new onset status epilepticus or new onset refractory status epilepticus or NORS is common. Unfortunately, these patients stay in the ICU for long. We use a lot of anti-seizure medications, and therefore it is a setup for iatrogenesis. For example, propofol infusion syndrome, as you very well know, is much more common in younger patients. And autoimmune encephalitis tends to happen in younger patients. Gastrointestinal dysmotility, ileus with barbiturates, prolongation of PR interval from lacosamide, a high risk of cutaneous reactions in Stevens-Johnson syndrome from lamotrigine, for example, because that is one of the drugs that is used in treatment of seizures. We prefer using sodium channel blockers in patients who have LGI1 autoimmune encephalitis, such as carbamazepine or lacosamide. And I again want to emphasize that early immunotherapy is way more effective than anti-seizure medications. And so starting immunotherapy early is key. Moving on to movement disorders that are seen in autoimmune encephalitis, it spans the entire spectrum. You can have tremor, you can have dyskinesias, which involve the face and the mouth, limb dyskinesias, myoclonus, chorea, athetosis, stiff person syndrome, and dystonias, which can be focal or generalized. Now, all of these can be aggravated by concurrent infections, metabolic derangements like hypocalcemia, and concomitant use of medications, for example, the first-generation antipsychotics. What is the risk of leaving these movement disorders untreated? They cause musculoskeletal injury, they cause pain, respiratory difficulty, especially in dystonias, and rhabdomyolysis, and hyperthermia because of constant muscle activation. So symptomatic management for these includes beta blockers for tremor. For myoclonus, we can use levetiracetam or brivaracetam. You can use valproic acid and benzodiazepines. For dystonias, we can use anticholinergics like trihexyphenidyl or benzotropine, muscle relaxants like baclofen or tizanidine for dystonia and spasticity. If it's very focal dystonia, we can use Botox. For catatonia, we can use dopamine agonists such as pramipexole or ropinirole or carbidopa. But if it's very severe catatonia, we do electroconvulsive therapy. And finally, if it's uncontrollable movements that is not responding to any medications, we unfortunately have to resort to deep sedation and neuromuscular paralysis. Again, a caution to avoid ketamine because of its interaction with the NMDA receptors. So here's a nice cartoon that shows the symptomatic management of movement disorders. So if the patient is hypokinetic, i.e. they have Parkinsonian-like features, we use levodopa and bromocriptine. In other words, dopamine agonists. If they have hyperkinetic movement disorders, such as tremor or myoclonus, we use anticholinergics, beta blockers, or anti-epileptics. On the other hand, if they have a hyperkinetic movement disorder, such as dystonias, chorea, or dyskinesias, we use anticholinergics, dopamine receptor blockers, dopamine depleters like tetrabenazine, alpha blockers, and benzodiazepines. Now, I do want to spend a few minutes on dysautonomia. Dysautonomia is probably one of the worst complications that these patients can have and a life-threatening complication. Paroxysmal sympathetic hyperactivity is defined by episodes of tachycardia, tachypnea, hyperthermia, sweating, and agitation is not uncommon. You can treat these episodes with opioids like morphine, respond really well, or propranolol. And for prevention, you can use gabapentin. You can use methadone, clonidine, and propranolol. If they have high muscle tone, spasticity, you can use dantrolene, baclofen, and bromocriptine. Arrhythmias, both tachy and brady, are not uncommon. Sinus pauses, cardiac arrest can be seen. I've had patients who have had these that require repeated CPR. As the EKG below shows, you have a patient who has a sinus brady and then has a sinus arrest, followed by an escape beat. Certain things can trigger these sinus pauses, including seizures that cause a lockstep phenomenon. So we aggressively look for and treat seizures. We pre-medicate before suctioning using fentanyl or inhaled lidocaine. We can use atropine glycopyrrolate and low-dose epinephrine for bradycardia. Early tracheostomy to avoid sort of the repeated suctioning and trauma. And then finally, patients may need temporary or permanent pacemakers. For other forms of dysautonomia, such as hemodynamic instability, we do fluid repletion and use compressive stockings and abdominal binders. We can use fludrocortisone, midodrine, and droxidopa. For neurogenic hyperventilation, if it is very detrimental, we really don't have a choice other than sedating the patients deeply. If they have ileus, we use neostigmine or pyridostigmine. If they have severe ileus or diarrhea, we may resort to total parenteral nutrition or TPN. If they have excessive sialorrhea, I have had patients who've had a liter of saliva, every day, we do Botox to the salivary glands. It works after a few days. For insensible volume loss, we do volume repletion because they can have excessive sweating or excessive drooling. And for hyperthermia, we use either internal cooling catheters or external cooling wraps, and then dantrolene can be used. Sleep regulation is important to prevent ICU delirium. Again, melatonin can be used, benzodiazepines, non-benzodiazepines, such as zopiclone for insomnia. During the day, we want to promote wakefulness, so we use modafinil or other stimulants like methylphenidate. However, these need to be used with caution in patients who have seizures. These patients, unfortunately, also have a high rate of infections, all kinds of infections, urinary infections, catheter-associated infections, pneumonias, ventilator-associated pneumonias, because we're using high doses of immunotherapy as well, so they're susceptible to opportunistic infections. So we want to make sure we have adequate prophylaxis for pneumocystis and other bugs. Watchful for DVT and pulmonary embolism, so using subcutaneous heparin or low molecular weight heparin. Early nutrition access with the surgically placed gastrostomy tube is encouraged because the movements may dislodge the nasogastric tubes. They may have interruptions of feeding several times. So in order to ensure smooth nutrition, we use H2 blockers and proton pump inhibitors for preventing GI bleeds, especially when we're using high dose of steroids. Early mobilization to minimize critical illness neuromyopathy. And if the patient, for example, needs bilateral oophorectomy, we do ethics consults because these patients will not be able to have children in the future. A couple of slides about SARS-CoV-2 associated autoimmune encephalitis. About 28 cases have recently been reported in the literature. The majority are adults because that was whom the first wave of SARS-CoV affected. We think it is that the infection, just like herpes infections, triggers the autoimmunity. These patients present fairly typically like an autoimmune encephalitis, but in addition, they also have the ARDS, DIC, and other organ failure that is seen in severe SARS-CoV. Treatment is typically with steroids, IVIG, and plasma exchange, and at least in literature, 2/3 of patients had recovered. So the very last slide, in summary, we need a high index of suspicion for patients who present with neuropsychiatric symptoms and have a rapid or a subacute progression. These three are the most common forms of autoimmune encephalitis that we encounter in the ICU. We can diagnose this using MRI, using lumbar puncture, during serum autoantibody markers. Immunotherapy, early immunotherapy is a must. First line is steroids plus Plex or IVIG. Second line is rituximab or cyclophosphamide. These patients stay sometimes for long periods of time in the ICU because of severe manifestations, including dysautonomia, movement disorders, agitation, psychosis, and of course, seizures and status epilepticus. And the bottom line is the early we treat, particularly within 4 weeks of onset, the better the prognosis is. I will stop here and I'm very happy to take any questions on this.
Dr. Badri, your microphone is muted.
Thank you, Dr. Chitra, for that wonderful presentation. It was a detailed presentation of what we are to be aware of as clinicians in the ICU and what are the common drugs that we use and which are responsible for this. You had made a mention of plasmapheresis as one of the forms of treatment. Recently, they have described immunoadsorption therapy as a form of treatment for encephalitis. What's your opinion about that?
Dr. Badri Narayan, thank you for that question. At our institution and in the majority of the centers in the US, we practice most often plasmapheresis because we have very standardized protocols for it. I personally don't have a lot of experience with immunoadsorption, but the basic way in all of these work is to remove presumably the antibodies that are triggering the encephalitis. But I personally don't have experience with immunoadsorption. I currently have somebody in the ICU that, we have been doing plasmapheresis and IVIG for. But the principle behind which, these technologies are used are exactly the same.
Yeah, we also use plasmapheresis, but we don't have this adsorption therapy available to us. I just thought if you are using it.
I think you would be absolutely fine continuing with the plasma exchange.
Yeah. I have one question for Dr. Anirban. We say this post-op dysfunction for about 3 months following surgery, but why does it take so long, or why is it permanent in critical care patients? We're not able to hear you.
Yes, sir. Are you able to hear me?
Yeah.
Now, the critical care patients have a lot of factors which predispose them to the brain dysfunction, particularly the use of sedation, opioids, the use of vasopressors continuing for long, the environmental factors. So all of these add up to produce a much more additive effect. So that increases the risk.
There is one, Dr. Anirban, there is one question for you regarding the role of melatonin to normalize the sleep wakefulness cycle in these patients. With,
melatonin has a very good role in bringing the circadian rhythm, to restoring the of circadian rhythm in normal patients. But in ICU patients, again, it's difficult choice because the other factors are coming into play. At that time, the role of melatonin becomes, and the melatonin, if you see, the effect occurs only after around 8 to 10 hours. So the peak effect occurs almost after 16 hours. Now that time also becomes very crucial in any ICU patient.
And Dr. Anirban, just one question from my side, that how frequently do you see these patients for these cognitive dysfunction, and how many months or days after they come back to, do they come back to you for such problems in your scenario?
Dysfunction.
Yeah. Means they come with such disorders in the, after some
no, we don't look for coagulative dysfunction unless and until there are specific reasons indicated for that transplant category. There are definite reasons for that, but coagulation disturbances per se, it is not. It is mainly because of the delirium. You know, hyperactive delirium is most common, followed by the mixed delirium. Hyperactive delirium is least common, and elderly patients mostly they have hypoactive delirium. So although earlier people used to use olanzapine and risperidone, but now the current guidelines recommend against using any antipsychotics. So it is mostly the conservative and the non-pharmacological treatment that is being prescribed to follow. Coagulative disorders are in a very specific group of patients. So routinely we don't use coagulative, the panel, we don't check for it.
Since we are running a little late, I think we need to close this session. We'll close this session with the last question to Dr. Tumul Chaudhury, which has been asked by Dr. Amna Goswami. She asks that, are we to assume that the cognitive dysfunction is less with TIVA?
Thank you for the excellent question. And it's not a very simple question to answer, actually. So it's a very complicated question, because as far as the anesthesia goes, and what I talked in my in that systemic inflammation, it seems that TIVA has a little beneficial effect. But in my conclusion, I told that we need to be a little bit cautious when we say it, because even though some of the data suggests that TIVA causes less blood-brain barrier disruption and it stabilizes as compared to volatile, but looking at the systemic inflammation, the chances of cognitive dysfunction or any other systemic inflammation is not substantially low with TIVA as compared to volatile. So until unless we have some randomized controlled trial, and we also need to be cognizant that in which age group, in which type of surgery, at what post-op period, at what follow-up time, we are looking at cognitive dysfunction, and depend upon the cognitive function test also, there could be a lot of variability. So in the lack of homogeneity of the data, it is very difficult for me to interpret that TIVA is better or volatile is worse. So as of now, I can say that it has a little bit edge on volatile, but I cannot quantify for sure.
Thank you, Dr. Chaudhury. I would like to thank all the chairpersons, Professor V. Badrinarayan, Dr. Sapna Sirohia, Professor Sashi Srivastava, for your presence here, taking time out this Sunday morning and making it worthwhile for us. Also, I would like to thank the speakers, Dr. Tumul Chaudhury, Dr. Homchowdhury, and Dr. Chitra Venkat, for their excellent presentations. And at least 2 of you have joined with a significant time difference. I'm not sure the time at your home, but Dr. Chitra and Dr. Tumul, it must be, evening, on a Saturday evening for you. So my thanks to you taking this valuable time out and the time for presentation.
Thank
Dr.
you.
Homchowdhury.
Thank
you.
you, organizers.
Thank you so much.
Thank you to all the organizers.
Thank you. Thank you,
Very
everybody.
happy to be here.
So now we'd like to move to the next session, which is a pro-con debate. I welcome the chairpersons, Professor Girija Roth and Professor Shobha Purohit. Professor Girija Prasad Roth is a professor of neuroanesthesia and critical care at All India Institute of Medical Sciences, Delhi. He is also the executive editor of Journal of Neuroanesthesia and Critical Care and director at large at ISNACC, USA, and part of the board of the directors. He has a large number of publications, more than 2,050, large number of chapters in books, and also edited a couple of books. Received multiple special awards and recognition, ICMR International Fellow in USA, Fellow of Indian College of Anesthesiologists, and Fellow of the International Medical Sciences Academy. Also, he has attended multiple conferences in our country, the National Conference of Anesthesia, RSSPCon, the Pain Conference, as invited faculty and delivered invited lectures. Also in various international conferences, the Neuro, and Asia Neurological Society Neuroanesthesia conferences. Welcome, Professor Girija Roth.
Thank you.
Professor Shobha Purohit. She is a senior professor in the Department of Anesthesiology at SMS Medical College and Hospital, Jaipur. Obviously, the field of interest is neuroanesthesia. She has 30 published papers. She has organized this conference, the ISNACC, in 2014 and organized the neuroanesthesia Oration in 2002. She is a reviewer in the Journal of Neuroanesthesia and Critical Care, delivered lectures in many national and international conferences, and also presented papers. Her paper was adjudged the best paper and the H.K. Gupta Gold Medal. She has received the H.K. Gupta Gold Medal. She is also a contributing author in the Manual of Neuroanesthesia, member of the Technical Advisory Committee in Neuroanesthesia at AIIMS, New Delhi. And she has had many administrative posts in this association. She has been president of the ISA Jaipur City branch and the president of ISNACC in 2017-18 year, and an executive member of ISNACC 10-12. So this is a pro-con session. The topic is GA versus awake craniotomy in surgery around the eloquent cortex. Now I request the chairpersons to please take over. Thank you.
Yeah, good morning, everyone. Good morning, Soha madam, and thanks to us for the kind introduction. So we have the pro-con debate right now, and this is regarding GA or awake, which is better for surgery around eloquent cortex. So to speak about GA is better, we have Dr. Shalvi Mahajan, who is an assistant professor at PGI Chandigarh. Shalvi used to be a bright senior resident when she was doing DM and received a number of awards in national conferences. I'm not enumerating all those things. And to her credit, she has 28 index publications, 3 chapters, and her area of interest include advances in perioperative care for neurosurgical patients, regional blocks in neuroanesthesia and spine surgeries, and postoperative cognitive function. Now, welcome, Dr. Shalvi. You can go ahead with your presentation.
Good morning, everybody. At the outset, I'd like to thank Organizing Committee for providing me an opportunity to be the part of this platform. I'll be discussing general anesthesia is better for the surgery around the eloquent cortex. The word eloquent was used for the first time in the neurosurgery in 1951. Then again, the word was used in 1960s and 70s, but without knowing its exact location and the significance. In 1987, after the period of 35 years, the Spetzler and Martin, who proposed AVM classification, mentioned in their paper that eloquent areas are those areas which speak to the readily identifiable neurological function, and if injured, results in disabling neurological deficit, and they are present in sensory cortex, motor cortex, language area, or the visual cortical areas. Thus, the so-called silent areas of the brain are eloquent to those who know how to listen. And in order to, when it comes for the surgery, the goal of the surgeon is to achieve maximum or total resection with minimum or no post-operative neurological deficit. And in order to achieve these goals, we as neuroanesthetists aim at providing optimum operating condition, maintaining adequate cerebral perfusion pressure and oxygenation, accommodating neurophysiological monitoring, along with the balanced anesthesia. Anesthesia can either be provided in the form of the general anesthesia or the awake anesthesia. But no one can doubt general anesthesia of the modern age in the presence of the best drugs availability, with the excellent monitoring facility and ability to manage intraoperative complications at the earliest. Amongst the drugs, short-acting agents, analgesic agents, amnestic agents, as well as analgesic agents are available. We have short-acting muscle relaxants also, like fentanyl, remifentanil, sevoflurane, desflurane, atracurium, rocuronium, and the propofol. Then when it comes for the monitoring, ASA standard monitoring is available. We can even monitor the depth of anesthesia, and using target control infusion pump, we can even achieve desired concentration of the drug at the target level during the surgical procedure, where the stimulus, where the requirement of this anesthetic agent varies with the surgical stimuli, with the different surgical steps. Also, nowadays, there is facility that the analgesic action can also be monitored, like with the help of using the monitors such as Knox monitor. In order to minimize the neurological deficit and ensure maximum resection, that physiological changes which occur during the surgery in eloquent area of nervous system can also be monitored using SSCP monitoring, direct electrical stimulation monitoring, or MEP monitors. And currently, the combination of single stimulus or short train by strip electrode and the intraoperative MEPs and SSCP monitoring has been recommended for applying the direct electrical stimulation under general anesthesia. In 2021, in the Journal of Neurosurgery, the clinical burns and the methods of intraoperative motor mapping article was there, and where it has listed the various studies where under general anesthesia that tumor motor mapping was done involving the area which involved the motor area, and they found that under general anesthesia it is possible to use these monitoring. None of the neurosurgical procedure is immune to the intraoperative complications, such as venous air embolism is one of the well-known dreaded complication. And this complication can easily be diagnosed if the patient is under anesthesia using different gadgets, like which is routinely used gadgets like end-tidal carbon dioxide monitoring. And even the transesophageal echocardiography can help us in diagnosing venous air embolism at earliest. Whenever there is torrential bleed is there, if the patient's airway is secured, patient is under anesthesia, it is easy to control it is easy to control and handle the situation. When there is intraoperative seizures, it can be monitored under the general anesthesia if we are simultaneously using EEG. And here, when we are using EEG under general anesthesia, we can avoid the muscular part, that is the muscular effect of the intraoperative seizures can be avoided. And if the patient is in awake state, then this can cause injury to the patient. The motor component of the seizures can cause injury to the patient in the form of chances of the aspiration, tongue bite, cervical spine injury, or the chance of the tight brain. And if the right brain can be present in the general anesthesia or under the awake system, awake craniotomy, but under general anesthesia, it is easy to manage because we can manipulate carbon dioxide levels through the ventilatory settings, and along with that, we can also administer the drugs which have propensity to cause decrease in the cerebral metabolic rate. After all these things, thus, my point is that once the patient has received general anesthesia, he is half resuscitated as the airway is already in situ. Advanced airway is already in situ. Now, let's have a look at the published literature, what it has to say about the general anesthesia approach for the eloquent area surgery. This was the first study from the India. It was published in Clinical Neurology and Neurosurgery in 2007, done in the AIMS, New Delhi. And here, it was a prospective randomized control study, and the mean operating time blood loss was found to be less in the patients who received general anesthesia. And moreover, the better cytoreduction neurological improvement was seen. Then motor improvement in 35.7% and speech improvement in 62.5% for patients were seen. This study was done in almost around 53 patients. Then in 2009, another study which came from the Egypt, it was published in Neurosciences Journal, and here none of the patients it was also prospective randomized control study, and none of the patients who received general anesthesia had any complications, but the patients who received awake craniotomy had intraoperative agitation. 5 of them were oversedated. And at the 6 months follow-up, there was no difference in the neurological outcome in both the groups. However, in the immediate post-operative period, 90% of the patient in the awake group have better outcome as compared to the GA group. In 2017, another study came in the neurosurgery literature, and it was a type of retrospective analysis where perioperative complication extent of resection was compared in the 2 techniques in the patients who underwent periroladic glioma surgeries. And it was also a retrospective analysis. And in this case, the patients were categorized into 2 groups, one who received awake craniotomy technique and one who had received general anesthesia. And in both the cases, the operating time, stimulation-induced in seizures were similar in both the groups. And moreover, the extent of tumor resection were also similar. In 2018, another study came up in the neurological research. And they also suggested, it was also a type of retrospective study. And here also authors suggested that survival was similar between the 2 groups with 100% 1 and 2 year survival in grade less than 4 year groups. Thus, here the authors have mentioned in conclusion that since awake craniotomy is more challenging for the patient and for his caregiver after the surgery, this finding has an implication for the clinical decision making. Then in 2020, another study is done in the patients who had recurrent glioma tumor in the eloquent cortex. And they also found that the extent of resection and the degree of resection were similar in awake group as well as in the general anesthesia group. However, the early neurological deficit was slightly higher in the general anesthesia group, but late neurological deficit at 3 months were similar. In 2001, the Dr. Tumul Chaudhury et al. Also conducted one multi-centric retrospective cohort study, which was published in Journal of Neurosurgery Anesthesiology. They studied the brain cancer progression in the patients who received either awake craniotomy or the general anesthesia, and they found that there was no difference in the progression-free survival period and the overall survival in the patients who received either awake craniotomy with minimum sedation or the general anesthesia. After these studies, I will like to discuss one systematic review or the meta-analysis, what this has to tell to us. The systematic review and the meta-analysis, which sits at the apex of the pyramid of evidence, also suggested that there was no difference in the intraoperative conditions like blood loss, operating period, intraoperative seizures, extent of resection, and worst neurological outcome in both the groups. And they have also suggested that there was no difference in the follow-up KPS scores. After going through this literature, which has suggested that there is no harm in administration of the general anesthesia, is there any possibility of the failure of general anesthesia? No, I don't think it's possible. There is failure of the general anesthesia. Yes, surely the awake craniotomy or the awake technique can fail due to the technical errors or the patient-related errors, or even due to the drug-related errors. In the retrospective analysis of the 424 patients, which was published in Journal of Neurosurgery, they have suggested that awake craniotomy failed in 27 cases, that is 6.4% of cases, and the main cause for them is the lack of intraoperative communication and intraoperative seizures, and this will never be going to occur in the general anesthesia. And also, there was a study which has suggested that the post-operative psychological sequelae which resemble post-traumatic stress disorder is also possible in the awake craniotomy. Now, another thing, what about all these patients? The general anesthesia is only the approach in the children or in mentally retarded patients, or the patients where they have preoperative neurological deficits like motor impairment, hemiplegias, or have aphasia, dysphasias, or those who are unable to communicate, or their high level of anxiousness is present, or inability to lie down, in addition to the patients who are have difficult airway or have morbid obesity, may not be the candidates for the awake craniotomy. Thus, to conclude, general anesthesia is better for surgery around the eloquent cortex in terms that their airway is protected and ventilation is controlled. There is controlled titration of hemodynamics possible. Intraoperative neuromonitoring is feasible and is currently in vogue. And the early detection and immediate management of complications are possible. We can easily alter the depth of anesthesia depending upon the steps of the surgery, and greater familiarity with the general anesthesia technique and the less challenging for the anesthetists, for the patient as well as for the surgeon. And to conclude, at the end, I will like to say that the debate and the divergence of the views can only enrich our history and culture. There are always two sides of the coin. Now, Dr. Srilata will enlighten us with the second part of the coin.
Thank you, Dr. Shalvi, for the nice presentation. I will just add one point here. The study which you mentioned, the first study from India, that is the comparative study. In fact, that is, if you go through the world literature, that is the initial study which compared GA with awake. And that was a negative study. And let us see what Dr. Srilata will say about it. Now, over to you, madam, to introduce the next speaker.
Thank you, Girija. At the outset, I congratulate organizers for such a beautiful conference, and also I thank you all for giving me this opportunity to chair the session. And I'm very happy to see my friends, conference friends, though virtually, and it's very nice. So we have my friend, Dr. Srilata from Nizam Institute of Medical Sciences. She is additional professor. She's going to speak against the general anesthesia for surgeries on the eloquent areas. She is in favor of awake craniotomies. She has authored many research publications in national and international conference series, and authored chapters for neuroanesthesia, reviewed articles, and presented papers in the conferences, and she has delivered lectures in national and state level conferences, and she has many membership of the society like ISA, ISNACC, RSACP, and Neurocritical Care. So over to Dr. Srilata.
A very good morning to everyone, and a very happy new year, and nice to see everyone on this conference. And thanks to the organizing committee to give this opportunity to present on this platform. My topic is pro-con, and then on the con, that is the awake craniotomy in surgeries around eloquent cortex, against the pro, that is the general anesthesia. General anesthesia, they have placed, the pro person has placed points very nicely in favor of general anesthesia. Right now, it's my turn to place my positive points for the awake craniotomy in patients undergoing surgery around the eloquent cortex. We all are aware of the indications for awake craniotomy. The most common procedures which usually undergone are the parieto-occipital glioma and the frontoparietal glioma. And counseling. Counseling is the most important part of awake craniotomy. If counseling is done properly, it takes care of most of the intraoperative anticipated problems. So what are the most salient points we need to consider in counseling is need to make the patient aware of the importance of awake craniotomy. Make them aware of the surgical lesion, the site of the surgical lesion near that eloquent area. And at the same time, we need to make them aware of the different steps of awake craniotomy, how you're going to do it, and what are the problems the patient is going to face. That is mainly the pain from the administration of the scalp block, pain due to the surgical pains and the incision and the bone drilling. So for these steps, like how we are going to manage also needs to be taken care of. Like you need to give a proper reassurance to the patients that you're going to provide good analgesia and sedation at the time of these painful procedures. And again, these surgeries usually take an average duration of around 3 to 6 hours. So a proper good cooperation is required for the prolonged intraoperative position for the surgery with fixed head. Better to give them a visual picture of the position so that the cooperation is more better. And also the requirement of intraoperative cortical mapping, how you're going to do it, how you're going to perform it, and what cooperation is needed from their side for these tests. And also, last but not the least, anticipated intraoperative complications like discomfort and seizures, and how you're going to deal with these conditions. Okay. Next comes the OT preparation. We need to have minimal personnel inside the operation theatre and amicable surrounding conditions inside the OT. Better always to avoid loud sounds as far as possible, and preferably light music, whatever the patient prefers, like if the patient is comfortable. Once my patient is taken inside the operation theatre, I place the basic monitors attached and place an IV cannula and make things are ready for the catheterization, mainly the three things: arterial catheterization, scalp block, and urinary catheterization. Start Dexam 1 mg per kg bolus dose, followed by the maintenance. Injection fentanyl, I give around 0.25 to 0.5 mg per kg depending upon the body characteristics of the patient. Glyco is optional. Propofol is kept ready, and once I start giving propofol in intermittent bolus doses, all these three procedures are done simultaneously. Triple-amen, if required, is an optional procedure done. After the block is given, you can see my patient, they're quite comfortable. This is a patient where we have given the video showing how the pins were inserted, and see the cooperation of the patient and the comfortable level of the patient. So we can check it out. titrate or decrease your dexam doses and titrate to see the response of the patient during the insertion of the pins. Next is monitoring. As for any craniotomy patient, monitoring is done for all the patients. This is the draping, how it is done in our institute. Okay, this is then the steps of the surgical procedures. It is surgical skin incision and the flap elevation, and followed by before going for the dural incision, you can place a gauze soap with local anesthetic over it for a better analgesia for the dural incision, and then elevation of the dura. Then the most important thing is the intraoperative neurophysiologic monitoring, and this is done for either for motor area or sensory area or for the language of the speech area. This is the video which shows how
upper lip. Chest pike lepo. Chest pike lepo. No, is not able to. Chest pike lepo. Sir, more. Please stop. Please stop. Pitching are done. Pitching are stop. So your map area. So show me the area. This one. The photo show me.
Next.
రెండు కాళ్ళు ముడుచుకోండి. ఎడమ కాలు ముడుచుకోండి. పిడికిలు బిగించి వదలండి.
Main we do subcortical stimulation to identify thalamocortical somatosensory pathways. They have dysthesias.
రెండు కాళ్ళు ముడుచుకోండి.
Main we do subcortical stimulation to identify thalamocortical somatosensory pathways.
Next is the post-operative care. Once the surgical excision is done, proper hemostasis followed by a good post-operative care is very important for the good outcome of these patients. So I've already shown you practical experience of how we do awake craniotomy, and MA supported by enough of this scientific evidence. We'll go through some of this. This is a study, is a systematic review. It is metastasis, which was undergone in the year 2018. I think within the last 5 years, and they have done for the awake craniotomy for resection of brain mets, and they have reviewed around 7 studies between 2001 and 2017. 104 patients who underwent 107 awake craniotomies. And we can see the gross total resection was around 61%, a good percentage, with supramarginal resection around 32% and subtotal resection of around 7%. So what is seen good about in this study is that so in the long term, 96% of those with post-operative worsening of the function experience improvements in the neurologic function. This is a very important. Means only 4% had decreased permanent deficits. And the other thing is that the 73% experience no change or improvement in neurologic outcomes. So it shows a very good review of awake craniotomy. The other one is published around 2014 in European Association of Neuro-Oncology magazine. It was done for awake craniotomy in glioma surgery. It is also a review and a meta-analysis. They have done it on 43 retrospective studies over 2 decades. And you can see they have done on 32 high-grade gliomas and 11 low-grade gliomas. In 32 high-grade gliomas, 5 were done with volumetric MRI analysis. And one had enhanced survival and 3 had survival benefit of more than of around 2 to 8 months. And 11 low-grade gliomas, 3 with volumetric MRI analysis was done. And the outcome was, in all studies, there was increased overall survival with maximal resection. And because of this increased extent of resection, there was decreased incidence of malignant transformation. This has also shown a positive outcome in this for awake craniotomy. The other one is again a meta-analysis which got published in 2012 in the Journal of Clinical Oncology, and even they have seen that the impact of intraoperative stimulation with brain mapping on glioma surgery outcome, and they have shown that the late severe neurologic deficits were observed in 3.4% of patients after resection with mapping, and in 8.2%, comparatively it is high in 8.2% patients after resection without mapping. And the percentage of radiologically confirmed gross total resections were around 75% with mapping and only 58% without mapping. So the other one is that Eloquent locations were involved in 99.9% of resections with mapping and 95.8% of resections without mapping. So this has also shown an important positive outcome for the awake craniotomy patients. This is again a very important study which has shown regarding the psychological satisfaction or the patient satisfaction with awake craniotomy. And here the patients have shown that had a very positive experience with awake craniotomy, and the patient satisfaction with outpatient surgery was high, and patients understood the rationale behind the awake surgery, and patients were surprised that brain surgery can be done on an outpatient basis. So this is a very good qualitative study which has been undertaken in 2010. So, and the other one is the predictors of stimulation-induced seizures during peri-Rolandic glioma resection using intraoperative mapping techniques. So we are always worried about the intraoperative problems like seizures which may occur during awake craniotomy. So this again shows that awake craniotomy with intraoperative mapping can be done safely for peri-Rolandic gliomas with lower but statistically non-significant incidence of intraoperative seizures, and this could be attributed to statistically significant lower stimulation intensity is required for mapping. So the intensity which is required for mapping is a very important predictor for the intraoperative seizures. So it should always start with a lower intensity. The preoperative multiple AEDs and low-grade gliomas are significant predictors for intraoperative seizures. The other one is the time course of neurological deficits after surgery for primary brain tumors. And here in this study, it's a recent one published in 2020. That's why I just want to bring it into notice. That postoperative neurological deficits occurred in 41% and remained in 6% of patients. So permanent deficiency was only seen in 6%. And most of these deficits which remained were in patients with preoperative neurological deficits and with high-grade tumors in the Eloquent location. So Eloquent location is found to be is found to be a predictor of neurological deterioration and preoperative neurological deficits of remaining deficits. The other recent article which got published is awake craniotomy for tumor dissection, the safety and feasibility of a simple technique, which got published in 2021 in the journal Interdisciplinary Neurosurgery, Advanced Techniques and Case Management. Again, here they have shown that awake craniotomy is better than general anesthesia. So I would like to rest my case the slide, the image in the slide speaks for itself and with enough of the scientific evidence. So thank you. I would like to rest my case that awake craniotomy is the ideal for surgeries around the eloquent cortex. Again, thank you very much for the patient hearing.
Thank you, Dr.
Dr.
Srilata. Yeah.
For a very elaborative talk on. I want to ask you, what is your experience, personal experience in awake craniotomies? And do you always
Hello,
use
good morning.
propofol in these patients?
Good morning, madam. Very nice to see everyone in the conference. Initially, we used to use only scalp block, like awake. But I saw that most of the patients were like very uncomfortable when we are giving scalp block. So then I shifted myself to like with low levels of sedation with Dexter, along with titrated doses of propofol while giving the block and while placing the urinary catheter, because that's the most painful period and the most discomfort period for the patient. So we have started doing this, and we see that patients are more comfortable and more cooperative when we are giving in a titrated doses, and we try to evaluate again at the end of the scalp block, and by trying to place the pins, we make the patient awake. We see the pain response of the patient, and we all know the scalp block, whatever is that, it's almost equivalent to a blind block. Either you give a peripheral nerve block filling the artery, or you give a ring block. It's almost a blind block. So that's why we have gone for this titrated doses of sedation and with propofol, intermittent doses, mainly while placing the scalp block and the catheter place.
So you really favor awake craniotomy these patients on
Madam,
surgery on relevant areas?
one thing we have to be very clear that surgeon prefers whatever, like usually the selection of the patient is mainly with the surgeon. So we have to understand that, yeah, if the grossly the patient is like GCS is low, or the tumor size is very large, we can discuss with the patient, with the surgeon, that okay, maybe this patient is not fit for awake. Otherwise, like other contraindications we see, relative and absolute contraindications, whatever. For those patients, we don't go for it. But other than that, I think surgeon is the one who selects the patient and gets it.
Yeah, it's very challenging for the patient, surgeon, and anesthesiologist.
Yeah.
That's what, if the surgeon is comfortable with the anesthetist.
I think this has been very interesting topic. You know, awake craniotomy is a fascinating topic, no doubt, but we have a limitation of time, and we have used up our allotted
Dr.
quota.
Palas, can we have a couple of questions before we wrap up the session?
Yeah, please be brief with both the questions and answers. Thank you.
There is no question in the chat box. So, Dr. Srilata, do you think after this magnetoencephalography and functional imaging, still you feel there is requirement of awake craniotomy? Do you think that reduces the incidence of performing awake craniotomies, and there is a reduced interest among the neurosurgeons going for awake craniotomy in these patients?
Mainly, I think now because of those coming up, already come up INM for mainly for the motor wave potentials for the eloquent areas like near the motor cortex. So if tumors around the motor cortex, maybe I think we can avoid awake craniotomy as far as possible. But if the tumor is around eloquent areas like speech and language areas, I think better to go for it and try to avoid the neurological deficits as far as possible. Like
Okay.
Last 2 days also have listened about those topics. I think that's what I got. Thank you.
Yeah, Dr. Shalvi, there are many times you will find your neurosurgeons, they prefer also to operate in the non-eloquent area of cortex. They prefer awake craniotomy. So there is some sort of fancy in that, means nowadays people are preferring that thing. So this is basically based on reduction in oxidative stress in awake craniotomy cases. And you tell us one indication where awake craniotomy will definitely go for awake craniotomy.
At present, I think the involvement of the speech or the language area is the one where the surgeons prefer to go for the awake craniotomy. But under general anesthesia, language monitoring is also coming up nowadays. Like there was an article which was published in Journal of Neurosurgical Anesthesiology 2020, and where it was the article from published from Switzerland, and the authors have demonstrated that phonological processing is possible under general anesthesia. So that can give us the clue that we can go for general anesthesia, but at present, this is the one of the main definitive indication that we have to go for the awake craniotomy.
Thank you so much. Over to you, Dr. Palash.
Thank you. Our chairpersons, Professor Girija Roth and Professor Shobha Purohit, for your time and your effort. And I would also like to thank the presenters, Dr. Srilata and Dr. Shalvi, who have prepared really well and prepared compelling reasons for each of these techniques. So I'm sure people who have been listening in have been, have got most of their doubts cleared, and if people are venturing, help them to take a decision. So from this pro-con session, we move on to our next session, which is also a pro-con session. Now, that debate is going on for a longer time than this debate about awake versus craniotomy under awake versus general anesthesia. This topic is prone versus sitting position for posterior fossa surgery. It's an old topic and old debate, and like most debates, the reasons keep on tilting from this side to the other. So to moderate this session, I welcome Dr. Ratan Chelani and Dr. Saikat Sengupta. Dr. Ratan Chelani is a senior consultant at PD Hinduja National Hospital and Medical Research Center in Mumbai. He's also an ex-lecturer at Grant Medical College and JJ Group of Hospitals in Mumbai, and has presented many papers and publications. Welcome, Dr. Chelani. I also welcome Dr. Saikat Sengupta, who has been personally known to me for a very long time, been a teacher and mentor for me. He has got a large number of publications, 64 peer-reviewed journals and chapters in 18, and he has been pretty kind to me and put forward a very small CV. And we're going to only mention the special awards that he has received: Professor Srilin Chatterjee Oration 2019 and Harigopal Bharat Oration 2013. These are two prestigious orations organized by the Indian Society of Anesthesiology West Bengal chapter. He has also received the Gapio Clinical Excellence Award in 2019, Mrs. Rukmini Pandit Award 2006, which is given by the ISNACC National Conference, and also COPS Award in 2003, and Sarojini Devi Award in 2003. And he has won the gold medal anti-angel fellowship in 1907 when he was a postgraduate student, and HM Desai Award in both the years 96 and 97. These are given out by the State Society of ISA Gujarat State Society. Now I ask Dr. Sengupta and Dr. Chelani to please conduct this session. Thank you.
Thank you, Palash.
Thank you. Thank you very much. And good morning and welcome to this session pro-con on the topic prone versus sitting position. So first of all, I should congratulate for great going of ISNACC 2022, and I am thankful to organizing committee for giving me a chance to be chairing this session. So to start with, first of all, we invite Dr. Saurabh Suman. He will be the first speaker, and he'll be talking on prone position is better for the posterior surgeries. Dr. Saurabh is working as an assistant professor in Rajendra Institute of Medical Science since 2019. Before that, he has served as in AIMS as senior resident from 2016 to 2018. He has completed postdoctoral certificate course in neuroanesthesia from Institute of Medical Sciences, Banaras Hindu University in 2015-16. He did his MD from Banaras Hindu University, Institute of Medical Sciences. He has various publications in the reputed journals. So I'm honored and privileged we are honored and privileged to have Dr. Suman to start his lecture. Please, Dr. Saurabh, you can start here.
Thank you, sir. Very good morning to one and all here. I am Dr. Saurabh Suman, Assistant Professor RIMS Ranchi. I am really feeling honored and thankful to organizing committee that they gave me a chance to speak on this prestigious platform. Today my topic of presentation is prone position is better in posterior fossa surgery as a part of debate between prone versus sitting position In posterior fossa surgery, at the bottom of a slide, I have shown my institute, that is Rajendra Institute of Medical Sciences. Why posterior fossa surgery is so important? Because it contains very important structure like brainstem, cerebellum, and lower cranial nerves. An injury to these structures could be devastating and life. What should be intraoperative goals of anesthesiologist? Obviously, we have to choose that position which facilitate better surgical access, minimize nervous tissue trauma, and maintain respiratory and cardiovascular stability. And maintaining all these criteria, prone position is better than sitting position for posterior fossa surgery. Intraoperative positioning. Posterior fossa surgery can be carried out in various positions like supine position, prone position, sitting position, lateral position, and park bench position. Out of these positions, most commonly used positions are supine position and prone position. This is park bench position as shown in image. In this position, head is flexed, allowing a gap of 2 finger breadth or 2.5 centimeter between chin and sternum. Head is turned contralaterally to the lesion, allowing to increase the angle between atlas and foramen magnum. In park bench position, there is a risk of brachial plexus injury because of excessive neck rotation and stretching of arm, and that's why it is not very commonly used position for posterior fossa surgery. This is how prone positioning is done in our institute. This is being used for posterior fossa lesion, fourth and third ventricle lesion, and or pineal lesion. It can also be used for posterior approaches to the cervical spine, thoracic spine, or lumbar spine. This is how prone positioning should be done. First, the patient is induced in supine position, and then it is turned on the operating table in the prone position with a minimum gap of detachment of all the monitors. Head is immobilized using Mayfield pin. Head is flexed with a minimum gap of 2 finger breadth or 2.5 centimeter between chin and sternum. Hand should be adducted. Proper strapping should be done. All pressure points should be well padded. Drawers should be placed at the upper thorax and below the pelvis to make abdomen free. And one drawer is placed below the shin and knees are slightly flexed. In the prone position, oxygenation improves since there is improvement in the matching of ventilation and perfusion because of evenly distributed pulmonary blood flow. Previously, atelectatic dorsal zones of lung may open. It is used in severe refractory ARDS as we witnessed in the second wave of COVID-19. Why prone position is preferred over sitting position? Because there is less incidence of complications that are associated with the sitting position, like venous air embolism, paradoxical air embolism, macroglossia, quadriplegia, sciatic and peroneal nerve injury, and pneumocephalus. And that's why prone position is preferred over the sitting position. In further slides, we will elaborate complication of sitting position. The first complication which I would elaborate is venous air embolism. It is potentially a life-threatening complication which is more commonly associated with posterior fossa surgery in the sitting position. The cited incidence of venous air embolism varies from 25% to 75%. In the sitting position, the site of surgery is above the level of heart. That results in negative venous pressure at the level of surgical wound. Open veins thus drain atmospheric air into the circulation. That results in venous air embolism. But entrainment through head pains has also been reported. Dehydration further exacerbates the lower venous pressure at the level of surgical wound. So increases the risk of venous air embolism. Hence, normal volume should be maintained if we are planning for sitting position. In pediatric population, there is a slightly increased venous pressure. So there is a decreased risk of venous air embolism as compared to adult population. The most common or most sensitive monitors intraoperatively to detect venous air embolism are transesophageal echo and precordial Doppler. Precordial Doppler is a non-invasive method, while transesophageal echocardiography is an invasive method. For each 1.25 centimeter movement of head above the heart level, the local arterial pressure is reduced by 1 mm of Hg. So as we increase the head above the heart, there is an increased risk of venous air embolism. It usually occurs through diploic vein and open venous sinuses because both are unable to collapse. Clinical features of venous air embolism depend on rate and volume of air entrained. Hence, if rate is faster, then clinical features will develop earlier. If volume of air entrained is higher, then clinical features will develop earlier. It includes cardiovascular, respiratory, and neurological changes. In cardiovascular system, symptoms includes hypertension, tachycardia, bradycardia, and other arrhythmias or decrease in stroke volume or stroke index. In respiratory, symptoms include wheeze, crepitation, sudden decrease in end-tidal CO2. And in neurological changes, there will be cerebral hypoperfusion as a result of shock and a stroke. But a decrease in EtCO2 or arterial oxygen saturation occurs prior to hemodynamic changes. This air emboli causes elevated right atrial pressure that further results in decreased venous return and causes hypertension, shock, tachycardia, and myocardial ischemia may ensue. Now coming to paradoxical air embolism. Here, patent foramen ovale is present in 10% to 25% of the population that facilitate passage of air into the arterial circulation. Air emboli passes into pulmonary circulation, causes increase in pulmonary vascular resistance and pulmonary hypertension that causes further elevated right heart pressure and increases the risk of paradoxical air embolism. In paradoxical air embolism, there is a chances of a stroke and coronary occlusion because air emboli doesn't get filtered at the level of pulmonary capillaries. So preoperative echo is advised if we are planning for posterior fossa surgery in sitting position. Pneumocephalus. It is a recognized complication of surgery in the sitting position. During surgery, various techniques may be used to reduce the volume of brain, which encourages air to enter the intracranial space. And when the intracranial cavity is closed, the brain expands and the air is compressed, causing a mass effect with elevated ICP. And in some cases, even a burr is made or EVD is placed to decrease the ICP. The condition is worsened with the use of nitrous oxide, but avoiding nitrous doesn't eliminate the problem. It can present after surgery as delayed recovery, neurological deficit, headache, confusion, hesitation, or convulsion. Untreated tension pneumocephalus can result in brain herniation and cardiac arrest. Macroglossia. It can occur as a result of obstruction to the venous and lymphatic drainage of the tongue because of a flexed neck during prolonged surgery in the sitting position. It may cause postoperative respiratory obstruction, particularly in children because they have a large tongue. Quadriplegia is a rare but potentially disastrous complication caused by prolonged focal pressure on the spinal cord, secondary to acute flexion of the head in the sitting position. It can also occur when regional spinal cord blood flow is compromised, particularly during an episode of significant hypotension that result in ischemic damage of the spinal cord. Contraindications for sitting position. Absolute contraindications. It include ventriculoatrial shunt, right to left heart shunt. Relative contraindications. It include patent foramen novale, uncontrolled hypertension, extremes of age, severe autonomic neuropathy. Now I would like to conclude. Prone position avoids or minimizes complication like venous air embolism, paradoxical air embolism, pneumocephalus, quadriplegia, and macroglossia. Sitting position is more associated with sciatic nerve and peroneal nerve palsy. During surgical procedure, hypotension is increasingly associated with sitting position because of pulling of blood in the legs. Hemodynamic reserve is better maintained in prone position. Pulmonary function is also superior in prone position when compared to supine sitting or lateral decubitus position. These are my references. Thank you for listening.
Thank you, Dr. Saurabh, for your nice presentation. And over to Dr. Sen Gupta to introduce the next speaker, and then we'll take the question at the end of the both pro-con lectures. Yeah, over to Dr. Sen Gupta.
Thank you, Dr. Chelani, and thank you, Indranil and Polash, for asking me to be a part of this very wonderful virtual meeting. And we heard Dr. Saurabh speak about why he prefers the prone position while doing posterior fossa surgery. Now we need to see the other side of the story, and we'll hear from Dr. Neeraj as to what he prefers and which is his ideal position, which is possibly sitting. Dr. Neeraj is an assistant professor for trauma and emergency at the All India Institute of Medical Sciences, Patna, with his areas of interest in critical care and neurocritical care and trauma critical care. And as is evident, he's been a clinical coordinator for COVID-19, a nodal officer. He's been an editorial board member of several journals, as well as a reviewer on many of them. And if I need to narrate the awards that he has received, I think we will be cutting short into his time that he has to debate for the sitting position. Several publications in very visible journals, which is well elaborated by the kind of citation indexes that he has and with very high impact factor journals. So we'll be waiting eagerly to hear from Dr. Neeraj as to why he prefers the prone position for posterior fossa surgery. And I would request people who are listening to kindly put in their questions or queries and comments in the chat box, which we will take after Dr. Neeraj's deliberations. Over to you, Dr. Neeraj.
Good morning, all of you, and greetings from AIIMS Patna. First of all, I would like to thank the organizing committee of 23rd Annual National Conference of Neuroanesthesiology and Critical Care. And I'm really very thankful to the organizers for giving me a chance to participate in this debate, the prone position versus sitting position in posterior fossa surgery. Although I will be speaking on sitting position is better in posterior fossa surgery. So before I start my presentation, I will few things about
We can't hear you.
I think can the support people just look into it? This the slides are not moving and it's not audible.
Was performed by D. Martel in 1913 for posterior fossa tumor under local anesthesia. After that, Frazier and Gardner were first reported the use of sitting position for surgery on Gasserian ganglion in the USA in 1928. So this sitting position is way back been used in history also. And a recent national survey has demonstrated that the sitting position is still utilized for posterior fossa surgery in about half of the practices in US. So it's still very commonly adopted practicing. So you can see that there are various modifications of the sitting position as well. The first sitting or Fowler position is it is a very standard sitting position in which patient is seated in an upright sitting position to around 45 to 60 degrees. The knee is either bent or straight. The second one is a semi-sitting position in which the head is elevated to around 30 to 45 degrees and the foot of the bed is raised at the knee of the bent legs. And the third one is your modified sitting position where the patient is given a position in a steep Trendelberg position. The back end is bit elevated and Mayfield clamp is fixed at the back section of the table. Now these are the various pictures of the various sitting positions pictures. Some are modified ones, some are showing a steep Trendelberg position. Coming to the difference between this classical sitting position as well as modified semi-recumbent sitting position. Although this modified semi-recumbent position has been more favorable position. Why so? Because the blood drains out and away from the operative site, which allows the easy access to the bleeding points. Yes, it can provide a clear surgical field and it provide an unobstructed view of the patient face also. It can provide a better intraoperative and neurophysiological monitoring. But in hemodynamics, when you'll compare with his classical sitting position, what you will get that the postural hypotension is seen in about 1/3 of the patient, but in 2 to 5% of the patient have a severe hypotension. But in modified sitting recumbent position, you can have a better venous return and lesser hemodynamic instability. Why so? Because the venous drainage via internal jugular vein is improved, which will result in further decreasing the ICP. The jugular veins may also collapse in sitting position. Now coming to the ventilation. So ventilation part, either in classical sitting position or in modified semi-recumbent position, both has a beneficial effect. Why? Because in sitting position, the ventilation is always improved because of the downward displacement of the diaphragm, and it improves the ventilation in various dependent zones of the lung as well. It decreases the VQ or ventilation perfusion mismatch. So these modified semi-recumbent position, as I have already discussed, mostly used for supracerebral infratentorial approach to the pineal region. And this semi-sitting position minimizes the amount of cerebral retraction needed to gain the access to deeper structure as well. Now coming to the facts about this sitting position. So this sitting position provides the optimum surgical exposure for posterior fossa surgery. It can reduce the tissue retraction and decreases the risk of cranial nerve damage as well. It improves the cerebral venous drainage. So the risk for the bleeding will be less. So, and the patient airway is better accessible to the anesthesiologist. It improves the access to the tracheal tubes, face, chest wall, and arms, and it can provide the better ventilation. Till yet, no evidence of increased mortality rate has been found, and there are studies which shows a better neurological outcome and lesser blood loss after operating in the sitting position. So a study that was published way back in 1988 in anesthesiology, where the Black et al. Reported that intraoperative blood loss and volume of the blood transfused were significantly less in patient undergoing posterior fossa craniotomy in sitting position as compared to those that are operated in supine position. And the risk for lower cranial nerve functions were preserved better in sitting position. Now coming to the specific physiological changes, I will discuss its risk only with positioning for neurological. So you will see this chart where the sitting position has been compared with a supine position, and you will see that the various systemic systems has been given. Here the cardiovascular system, in it you will see that compared to supine position, the venous return is reduced, stroke volume is reduced, and cardiac output is reduced. But when you'll focus on respiratory component, the total lung capacity as well as functional residual capacity is increased. The reason is obvious. And on central nervous system, the jugular venous flow as well as the jugular venous flow is decreased, but jugular venous resistance is increased. Simultaneously, the heart rate will increase a bit. The systemic vascular resistance and pulmonary vascular resistance or peripheral vascular resistance will increase. The shunt fraction will reduce and the ICP will reduce in CNS. And when you will see the hemodynamics like systolic blood pressure, it can go either increase, normal, or decrease. The map is like that. It decrease, normal, or increase. And in anesthetized patient, these venous return are further reduced, stroke volume is reduced, and cardiac output is also reduced. The heart rate is increased, the stroke or systemic vascular resistance will increase, the peripheral vascular resistance will increase, and systolic blood pressure and MAP is reduced in anesthetized patient. But you see that there is a lesser atelectasis in the lung and good cerebral venous CSF drainage. So overall, the benefit would be optimal approach to the posterior fossa, lower ICP, and it will minimal the bleeding as compared to prone position, and it can provide access to anesthesia. Now, during craniotomy in the sitting position, the effect of gravity, it facilitates the drainage of the cerebrospinal fluid away from the surgical field. So it is responsible for lowering the intracanal pressure more than any other position. It has already been published in Journal of Clinical Neurosciences in 2000. And during craniotomy in the sitting position, this cerebral venous drainage is also improved, thereby draining blood away from the surgical field. So what it will do, it will result in decreased blood loss. It will reduce the need for blood transfusion as well, and it can provide an optimal surgical exposure. So overall, the shorter length of surgery as compared to various other positions. Even this, the patient that has been operated in sitting position can be returned to supine position rapidly for giving a resuscitation measure in case of acute cardiovascular collapse. So it is another benefit of using this. Now, you can have a direct surgical access to the superficial and some of the deeper structures of the posterior canal fossa. And this exposure result in less tissue retraction and reduced risk of cranial nerve damage as compared to various other positions. Compared to the prone position, the sitting position offers a better access to the patient airway as well. So apart from that, what it will do, it will decrease your intrathoracic pressure, it will optimize the respiratory mechanics, and it will allow the improved ventilation. Compared to the craniotomy in the sitting position, the prone position is associated with the increased intraocular pressure, and which will ultimately lead to increased risk of post-operative blindness, either post-operative vision loss like AON or PON, means anterior ischemic optic neuropathy, or posterior ischemic optic neuropathy. Apart from that, the sitting position may provide the proper establishment of hemostasis of all tumor bed by the surgeons after the completion of the intracanal surgery. So now, again, this is a very important benefit of using this sitting position. Why so? Because as the venous channels are either under low or negative pressure in the sitting position, you can have a continuous blood pressure monitoring. You can give a gentle irrigation to the tumor bed with using some salines. You can have a Valsalva maneuver. All these lead to establishment of hemostasis earlier in all those tumor beds by these surgeons. Coming to the most common procedure that is performed in the sitting position in the United States is an insertion of deep brain stimulator. So still, it has not been firmly established that neurosurgical procedures in the lateral or in prone position are safer than in sitting position, although the incidence of air embolism is higher in sitting position compared with the prone position. I'm sure that my colleague will be telling more on these parts, the risk of air embolism as well as risk of paradoxical air embolism, the risk of profound hypotension, some macroglossia and difficult airways, like all those parts need to be discussed by my colleague. But so the debate is on that only. But the recent studies have failed to demonstrate the differences among the mortality and morbidity. Now, the risk to benefit ratio of these neurosurgical procedures in the sitting position has been considerably debated. That's why the debate is still on whether to opt for a sitting position or go for a other position like lateral or sit or supine position, or you can say that prone position. So many experts have recently argued that the fear of catastrophic complication related to the sitting position seems unwarranted. And with an experienced neurosurgical and neuroanesthesia team, these surgery in sitting position can be done safely, and it may have several advantages over the other position. Now, in the year 2001, a retrospective study was published on 85 pediatric patients undergoing craniotomy for posterior fossa tumor, either in sitting or in prone position. So what they have found? They found that the patient in the sitting position experienced a fewer intraoperative and postoperative complication and shorter intensive care as well as hospital stay. So it was published in Pediatric Anesthesia in 2001. And most importantly, when craniotomy is done in the sitting position, the communication between surgical and the anesthesia team is paramount, especially with regard to the early detection of VAE. So our main aim is to reduce the risk of VAE or PAE, that is paradoxical air embolism. And because of these catastrophic complications, still the neurosurgeon is not been opting for the sitting position, although I have discussed all those advantages related or all those benefits related to this sitting position as well. And to conclude, this ideal patient positioning involves the balancing surgical comfort against the risk related to the patient. And the sitting position offers many benefits. However, we should be aware of the physiological changes that what I have discussed and complications that may occur during, not only during this positioning, but also during the various other positioning apart from that sitting position. So a thorough risk-benefit ratio based on the patient physical status and surgical implication need to be discussed among the team members and the patient. And yes, we can, with a thorough pre-operative anesthetic evaluation, use of advanced intraoperative monitoring, meticulous surgical techniques, this sitting position is having several advantages in our modern operating theaters. And I'm sure that most of the surgeons are still practicing this sitting position for performing posterior fossa surgery. So I would like to thank the ISNACC for giving me this opportunity. Thank you so much.
Yeah, thank you, Dr. Neeraj, and thank you, Dr. Saurabh, for a lovely debate. And I think what is wonderful is this topic keeps on being a topic for debate, even when we were residents, and even it is today. So I think the jury is still not out on this. I don't see any questions on the chat box. So maybe a quick line or two as a rebuttal, initially from Dr. Saurabh and then from Dr. Neeraj.
Yes, a sitting position is obviously associated with more complication like venous air embolism, paradoxical air embolism, microglossia, quadriplegia, and hence it is of less preference by the surgeon. And obviously we have to follow them only. Thank you, sir.
Okay, Dr. Neeraj, quick 2 lines of rebuttal from your side.
First of all, I'm very thankful to you, sir, Saket sir, and Ratan Chelani sir. You are here and you are listening our presentation, and the sound was a bit lower. I don't know, some glitches were there. But what Saurabh has said about this prone position, I just want to add in my part, like sitting position, that I was just studying. A study was published in Journal of Neurology, and what they have done a very large retrospective study in 310 populations, and out of which these 310 populations, what they have studied, all those patients for posterior fossa surgeries were done in sitting position, and what they have found, they have initially omitted all those paradoxical air embolism types, and they detected that only 0.6% rate was there for that venous air embolism. So you can understand the situation that only the catastrophic event related to the sitting position is your venous air embolism. So this is one of the most important factors. But none of the studies have really gone through that this because of this VAE, because if you have to consider a risk like PAE or VAE, apart from that, most of the other positions related to the sitting positions are advantageous, because the surgical exposure, the approach to the tumor, because all those deep-seated posterior fossa tumors can be very easily approached through that. And the most important part that what I should highlight is the anesthesiologist perspective, because when you will see that all those airways, and it should be you can communicate, you can have a airway access every time, you can see those parts when you are performing those surgeries in the sitting position. So I think this is one of the enormous advantages. And lastly, as we have already a T in our place, and we have a transthoracic echo and T, so we can easily rule out all those PA initially in preoperative evaluation. Yes, thank you, sir.
Can I ask you, both of you, one question, that in this era of COVID, what you will prefer, prone or sitting? Because like T and all is not disposable, like, you know, so what you will prefer, whether you prefer prone or the sitting position?
You are very right, Arvind Chaudhury sir. Namaste, sir. And I think, sir, you are very right, because right now the COVID has changed all those perspectives. You can say that all those clinical perspectives, many other literatures and all, because now if you will talk about this posterior fossa in context to COVID-19, yes, the patient is lying supine, the patient is lying prone, and all those aerosols is going just not affecting the patient as well as the doctors or the team directly. But I'm still not sure, because it's still not much literatures are here who has compared this prone with supine in COVID patients. So I'm still not sure about it, sir.
We are doing more of prone now, because sitting, we used to do always sitting, but nowadays we are doing more of the prone.
Yes.
Other question is, I have been reading in the literature and all, there is something called inflatable neck tunique. Have you come across this? Has anybody used? Which I'm in search of it actually, to prevent the venous embolism. Have you heard or have you used inflatable neck tunique to prevent the air embolism?
No, sir.
I have not used. I don't know whether Saurabh has used or not.
No, sir. I have also not used. I think it will increase ICP, or there is increased chances of bleeding.
No, when the air embolism occurring, that time suppose you're pressing the neck, that time there is chance of leads of this facial nerve coming out. You're putting the hand here. If you are already put the tunic in the neck, when it is needed, that time only you don't have to continuously. But I have not used. I'm in search of it. Once I had told surgeon, he said, yeah, get me, but I am not able to get it still.
So it's only when it is the embolism is going on.
Yeah, that time. That time.
And so at the same time, you are taking measures to control or correct the effect of embolism. So that is that we used to have, you can have hand pressure on the venous side. You can do that for temporarily. So same thing is, but I think you press it with the hands also will be equally effective, and you can know how much pressure you are doing. So that is a few seconds.
I'm very sorry to discussion that is happening, but we have
yes.
Unfortunately, in the truest tradition of a debate, we cannot take a raise of hands since it's a virtual meet and see which side won. But anyway, my decision is that the debate will continue. So, हमको दूसरा तारीख मिलेगा to settle this debate. Thank you, Dr. Ratan Chelani, Dr. Saikat Sengupta, Dr. Neeraj, and Dr. Saurabh. Your excellent presentations and deliberations.
Yeah, thank you, Speaker, and Dr. Sengupta and Organizing Committee.
Thank you, sir. Thank you so much, sir. Thank you so much.
Okay, so now we will move on to the next session, which is the oration, which is a very important part of this conference. And I request Dr. Indranil Ghosh to take over the conduction of that session. Thank you.
Thank you, Dr. Polash. Very good morning to everybody at their respective places. I hope, on behalf of the organizing committee, I hope that all of you must be enjoying the academic feast which we have been able to gather in this background of this raging pandemic. So I'm now going to start the third oration of the ISNACC meet, which is in the name of Professor Goday. And I welcome the three doyens of neuroanesthesiology and neurocritical care in India. All three have been my teachers, our teachers, and they have transformed us from being just a person who is a postgraduate in anesthesiology to somebody who does, loves, and teaches neuroanesthesia and neurointensive care. So I welcome Professor Harihara Das, Professor Parmod Bithal, and Professor Arvind Chaturvedi. Next slide, please. Professor Harihara Das requires no introduction. He's an emeritus professor of anesthesiology and pain medicine at Fortis Memorial Research Institute, Gurgaon. Sir has held an academic position from 1978 till 2012 at All India Institute of Medical Sciences. He was a professor and head of neuroanesthesiology in 1993 till 2012 and chief of Neurosciences Center, AIMS, from 2006 till 2012. He has received a WHO Fellowship in Neuroanesthesiology from USA and Canada in 1993. He has been bestowed with many international awards. Out of them, the 2010 Teacher of the Year Award by the International Society of Neurosciences in Anesthesiology and Critical Care, held at San Diego. Professor Das is the founder president of ISNACC, that is the Indian Society of Neuroanesthesiology and Critical Care, and the immediate past president of Asian Society of Neuroanesthesiology and Critical Care. Next slide. Professor Pramod Bithal is editor-in-chief of Journal of Anesthesiology and Critical Care. He was a former head of the Department of Neuroanesthesiology and Critical Care at AIMS and former head section of Neuroanesthesiology, Department of Anesthesiology and Perioperative Medicine, Kingdom of Saudi Arabia. Good morning, sir. Next slide. Professor Arvind Chaturvedi is a present professor and head Neuroanesthesiology and Neurocritical Care at Neurosciences Center, AIMS, New Delhi. He has got many publications and his special interest being neuroanesthesia, neurocritical care, management of traumatic brain and cervical spine injury, cerebral aneurysm and subarachnoid hemorrhage, pituitary tumor surgery, interventional pain management of head, neck, and spine, particularly of trigeminal neuralgia. So now I will welcome Professor Venkatesh Kesavan to deliver the lecture. First, I will welcome Professor Das to share a few words in memory of Professor G.R. Goday. Over to you, Dr. Das.
Thank you, Dr. Indranil, for those nice words. Good morning to you all. And this is a momentous occasion particularly for the All India Institute alumni. To start with, I'll recite the famous sloka. Guru Brahma, Guru Vishnu, Guru Deva Maheswara, Guru Sakshat Param Brahma, Tasmai Sri Gurube Namah. Professor G.R. Goday was not only my teacher, he was also teacher of Professor Parmod Bithal and Dr. Arvind Chaturvedi. I'll share few slides about Professor Goday. Professor Goday's name is Govind Ramachandra Goday. Just a minute, please. Is it visible?
Yes, sir, visible. It is visible, sir.
On kar sir.
Visible, sir, visible.
Yes, just. Aage chalo. Can you move the slide? Just. Thank you. He graduated from Agra Medical College, and after graduation he joined JJ Hospital, Bombay at that time, nowadays Mumbai, for his post-graduation, which he successfully did. And after that he left for England to carry on his fellowship in anesthesiology under the legendary Professor Cecil Gray. I think everybody knows he was a neuromuscular scientist, and he had written that book, famous book, Anesthesia. And after doing his FFA-CA, he came back and joined All India Institute Medical Sciences as a faculty in 1966. He was promoted to associate professor in 1970, and after the retirement of Professor G.C. Tandon, he took over as the head of the Department of Anesthesiology at All India Institute of Medical Sciences. He was the first person to organize the international conference under the aegis of ISA in Delhi, that was Asian Australasian Congress in 1977. And he was, thoroughly involved in the rabies encephalitis research, how to salvage these patients through intensive care management. And his publication was well known, and it was a renowned publication which was published in Lancet. Because of his dedication in the clinical research, he was appointed as the emeritus scientist in ICMR soon after his retirement in 1988, after serving the institute for more than 22 years. And as ill luck would have it, after 2 years of his retirement, he had a massive heart attack in his bathroom and he succumbed. And we, all of us, we pray for the noble soul to remain in peace and in heaven. Now I request my friend, my junior colleague, ex-junior colleague, Dr. Parmod Bittal, to introduce the speaker. Thank you, Dr. Parmod and Dr. Arvind.
Thank you, sir. Good morning, everybody. Dr. Venkatesh needs no introduction. He is very well known in the Neuroanesthesia Society. Dr. Venkatesh is consultant in Apollo Hospital, Bangalore. However, presently he is on sabbatical and is working in Apollo Hospital, Ministry of Health in Muscat and Muscat, Sultanate of Oman. He is Director of Neurocritical Care and Fellowship in Apollo Hospital, Bangalore. He is past president of ISNACC in 2019 and 2020. He graduated from Manipal in 1991. Following his graduation, he served in NIMHANS for 16 years as a consultant and senior resident, and later on in BGS Hospital and Apollo Hospital in Bangalore. He has delivered so many lectures in various international and national conferences, and he has published many papers, scientific papers in renowned Indian and international scientific journals. He served as treasurer of ISNACC for 9 years, and his past secretary and president of ISA Bengaluru City and Karnataka State Branch. He was organizing secretary of National Conference of Neuroanesthesiology and Critical Care in 2016 and Bengaluru. He is instructor for CTLS and ENLS. His main area of interest are pediatric neuroanesthesia, neurotrauma, and neurocritical care. Now I request Dr. Venkatesh to deliver his oration. Dr. Venkatesh.
Thank you, sir. I'll just share my screen. Good morning, and thank you, respected chairpersons, for the kind introduction. And I bring greetings from Kala Hospital, Muscat, Oman. It's indeed a privilege for me to deliver this past president oration in the honor of Professor Goday. Professor Goday was a renowned neuroanesthesiologist who has rendered service in critical case of treating rabies, which has been internationally appreciated. My pronouns to him, and I move on. Biomarkers is not new to us. We have biomarkers of various clinical situations like in cardiac and oncosurgery. Biomarkers is defined as a characteristic that is objectively measured and evaluated as an indicator of normal biological process, pathogenic process, or pharmacological responses to a therapeutic intervention. We see a lot of, we come across these, and cardiologists, oncologists, oncosurgeons basically plan or diagnose the disease, plan their treatment, and also able to see the progress of the disease and how the person or patient is getting better, the progress. And also they are able to prognosticate based on the level of these antigens which is being isolated from these patients. Do we have such a biomarker with respect to neurosciences? We do have some, but many of them still in the process of clinical validation. There are a number of biomarkers which has been isolated over the last 3 decades. Initially, there was many biomarkers like S100B was the one which has been extensively studied for the last 3 decades. But however, many biomarkers have been released into the blood, and because of the technology which was not available in those days, or even for the minute increase in the serum levels, could not be isolated. However, with the improvement in technology, even levels of femtoliters per liter of these markers can be isolated, can be measured with respect to single molecule array process. So today I'd just like to share what is actually the clinical utility, how it has been clinical validated, and what is the current status of these markers that is as of today in use in neurocritical care. We normally come across situations when the patient is admitted into intensive care unit, the patient's family members, first thing they ask is, how is the patient? We always tell most of the time is that patient is still critical. And the patient, the next questions, subsequent questions will be, is he going to get better? And what is the problems and how will be after a few days or few months? And will he get back to work for the next few years? He may be only the earning member, so that is their concern. Are we able to give clearly all these, able to answer these questions at that point of time? Probably none of us will be able to do it. So we have many of these markers, like biomarkers, like in the form of neuroimaging, in the form of clinical scales, and of also electrophysiology, which gives us a fair idea about prognostication and how they recover. But
excuse me, Dr. Venkatesh.
Yes?
Venkatesh sir, the slides are not moving.
No, I'm not. Okay.
Slides are not moving. Slides.
So you will have to move the slides, Venkatesh, yeah, or you tell the organization to move it for you.
Should I close again?
No,
Yeah,
you continue.
Stuff can help.
You continue from your 4th or 5th slides, I think.
Is it moving now?
Yes, again. It is moving now.
Yes, sir. Yes, sir.
Now it is okay.
So we come to a situation where we have to answer these family members, but unfortunately, we do not have a marker which can tell us about how these patients is progressing over a period of time in the intensive care unit, as well as how these patients do after their discharge from the hospital. And the most concerning is whether to get back to work, and what are the issues which we come across or which the patients can experience following discharge. And this is the complex structure in the brain, where we can see a lot of things which can happen. And whenever there is an injury, these are the source of these biomarkers, and multiple biomarkers in multiple sites. So from this, we'll be able to see what is the nature of injury and the severity of the injury when these patients, when these markers are being estimated in the blood. The markers are actually basically are estimated whether in the cerebrospinal fluid or in the blood, based on the release into the system. Whenever there is an injury, the serum levels in initial phase actually increases and reaches the peak based on the nature of injury, and declines over a period of time when the injury starts healing. However, there can be a situation where the injury continues to progress and can have and severity of injury, so that the markers continue to increase over a period of time. During the decline, when we see any secondary peaks, it only suggests that there is secondary injury during that period of time. And based on their kinetics, we can be able to estimate the levels of these markers at different points of time, which will tell us how this patient is progressing and also how these patients can be prognosticated. These are various clinical scenarios we come across in the intensive care unit. And if you look at this, the complexity of the markers of the neuronal injury, which happens at the time of injury. At the time of injury, there is necrosis, the nephron injury, and later on it can go on to the inflammatory status. And the progression of the disease can be demyelination, which basically looks at the chronic state of the disease. So it's not just at that point of time injury which happens, or the reaction or responses, but also it's a dynamic process wherein can be up to acute, subacute, chronic inflammatory responses from the system. So we need to have a certain marker which will tell us how these patients do, how can we prognosticate, and there are any indicators which can tell us how we can minimize certain investigations or imaging techniques in these situations. The TRACK TBI study, that is transforming the research and clinical knowledge, is a continuous collection of data with respect to clinical presentation and neuroimaging, biomarkers, and outcome studies. And about 196 patients were evaluated in one of the subgroup analysis. They looked at these two markers, rare fibrillary acidic protein and ubiquitinous carboxyl terminal hydrolase light chain, which are released following the injury. And what they could see, this has been approved by the FDA for point of care test. The results which comes within 15 minutes, something like similar to our blood gas analysis or the troponin T with respect to cardiac issues. What they noticed was there was an increase in within first 1 hour of surgery after injury, and they clearly correlated with respect to moderate and severe injury and also mild injury. And both these markers were significantly elevated, and it also the level of these markers with respect to the severity of the injury. It could also differentiate the patients with CT scans, or positive scan or negative scan with mild traumatic brain injury patients, and also could predict the outcome. And with both these parameters included, has significantly good prediction of the outcome of these patients. So we have something which can tell us that these patients at the time of admission, they have a mild injury or a severe injury, and also prognosticate based on these levels. However, these are all small studies which needs being revalidated at larger group of patients. Again, another 325 patients were evaluated with UCHL and GFAP markers. They could clearly differentiate with mild and control with respect to the moderate and severe injuries. So it was directly proportional to correlating with the severity of the injury. And what they could clearly see was, if at admission, the levels were significantly higher in severe injured patients, and then it gradually comes from the end of 7 days. Any increase at any point of time is suggestive of secondary injury. Depending on the nature of injury and severity, they could also relate to the outcomes. This one study showed that based on the levels of markers like S100B, GFAP, and UCH, the markers which are released into the bloodstream following injury, they could clearly differentiate between the mild and severe injuries, whereas the levels was much lower in mild group compared to the patients who had a severe injury. So it is related to the GCS scoring. This could also prognosticate the survivors and poor outcome in mortality based on the levels of these markers. So we have something to complement the already in the imaging and also electrophysiological and monitoring modalities, clinical scales to predict outcome in these patients. Again, from the track TBI investigators, about 200 patients were evaluated with respect to the phosphorylated tau proteins, which is from the axonal injury. They could clearly show that the total tau proteins were significantly elevated in all forms of nature of injury when compared to control, and the ratio of phosphorylated tau and the total tau proteins was significantly higher in patients with head injury, whether mild, moderate, or severe, compared to that of controls. They could also prognosticate based on the levels. The higher levels had poor outcome compared to patients who had lower levels of these markers. Even in patients with chronic traumatic brain injury, where the patients were in the rehabilitation phase, and the median of about 45 days following injury, even there, they could clearly show the tau proteins were much higher in patients with chronic trauma compared to the controls. S100B has been extensively studied, which is released from the glial cells. And what we need is the prognostication and also prediction of the progress of the disease. Now, mainly we were looking at mild traumatic brain injury patients who come into the emergency department or into the intensive care unit. The need for them to be predicting or prognosticate how these patients do, because most of them are discharged with very minimal instructions. And they could see that association of S100B at admission with high levels of S100B had poor prognosis. And what is most important at the breakthrough which has been seen here is patients who had levels of less than 0.05 micrograms per liter at admission could clinically correlate with the CD findings and also MRI findings, wherein the MRI findings are much more clear when compared to CT. And levels of 0.1 micrograms per liter could actually determine the differentiate with the need for the CT in these mild head injury patients. In fact, this has been included in the Scandinavian neurotrauma guidelines, where they clearly define that patients who have markers of less than S100B of less than 0.1 micrograms per liter need not undergo CT scan. And one of the major the quantification of this is important, is 0.7 micrograms per liter. Patients who have more than 0.7 had 100% mortality. So we have a marker which says that to tell that the patient prognosticate and also decide about these patients regarding or clearly define how these patients progress over a period of time. So this is the Scandinavian guidelines, which clearly says that with mild traumatic brain injury with no risk factors or mild risk factors, if it is less than 0.1 microgram, these patients do not undergo any CT scan and they are discharged with the instructions. Whereas anything more than 0.1 requires CT and move on. Yes, again, S100B and relation to transcranial Doppler studies, pulsatility index, they could clearly show that increased levels of admission within 24 hours, and they could see that over the period of time, to 4 days, the persistent elevation of S100B is prognosticating of outcome. The patients who had higher levels had a poor outcome, and there's increased mortality. Coming to Gosling pulsatility index, they clearly shown that patients who had severe injury had a higher pulsatility index, suggesting low blood flow. And they also could differentiate that the pulsatility index of more than 1.15 was predictive of increased mortality, about 83% mortality. And patients who had a pulsatility index of more than 2.15 had 100% mortality in this group of patients. So it also tells, a combination of these tells us about how we can prognosticate based on the bedside monitoring and these markers. When it comes to mild traumatic brain injury, we always come across certain situations where the patient's family members come back to us after the discharge that these patients are very anxious, they are having they're inattentive, and they are not able to concentrate. So these are the problems which normally see following mild traumatic brain injury, and which is considered as post-concussion syndrome, which is more seen in patients with sports injuries, and these patients, when they evaluated looking at serum 100-week constant levels, any patients who had more than 0.15 micrograms could quantify that the patient had indicating of delayed return to work. So we could clearly tell that these are the patients who have the high risk of these patients to post-concussion syndrome. And in fact, when identifying these patients at risk, we be able to rehabilitate early and improve their outcomes, and also to get back to work early. And spectrin in N-terminal filament and spectrin neurofilament was also increased, and it was significantly correlated with cognitive impairment. Apart from that, post-concussion syndrome the duration was correlated with tau proteins, which was estimated within 1 hour of injury. And these also were elevated in patients who had repeated concussions. And these were the ones who had decreased memory or psychomotor performance. This becomes very important in mild head injury patients for rehabilitation, counseling, and also to ensure that these patients are intervened early, much before, to ensure they get back to work or play faster. Neurofilament is a key filament in neurons and synapses, and it's a marker of neuroaxonal injury. It's got a good correlation with CT, and now the neurofilament was looked at even at the end of 2 years. They could see the increased level of neurofilament in CSF, which is suggestive of ongoing axonal degeneration. These are the patients where we can see that because of this ongoing degeneration, these patients continue to be in a poor outcome or a dependent state. This also correlated with functional outcome, MRI brainotropy, and which is seen in traumatic axonal injury, TIPS, and concussion injury. MicroRNA expression, extensive studies has been being done in this area in the last 2 years. They have identified more than 300 forms of microRNAs, and one of them, few of them have been correlated with the outcomes. However, this need to be still being validated, and the quantification is being done based on the outcome studies. Stroke is the next important disease which has a high morbidity and mortality, and we do not have something similar to the myocardial markers. And time is brain, we know that, and the patients who require interventions of thrombolysis within 3 hours or 4.5 hours need to have a clear time with clear history whether these patients have when these patients had a stroke. So diagnosis of that is important. We also want to look at the response to therapy, whether these patients are progressing, whether the patient is getting better, and also to can prognosticate. Now, one of the limitations of these is the patients of wake-up strokes. These are the patients where wake-up strokes are considered as out-of-window stroke, and these patients are never offered thrombolysis, and probably they go for conservative management. So we do not have, even though patient has had a stroke within the last 1 hour just before waking up, there's no marker which says that, or CT scan does not show as that this patient had a recent stroke. So one of the studies clearly shows that this was a patient with 4,500 patients was studied, and they grouped into 1,100 patients in each group, where in less than 2 hours, 2 to 3 hours, 3 to 4.5 hours, and more than 4.5 hours. And what they could clearly see that excitotoxic marker like glutamate and inflammatory marker which manifest much later after first few hours of interleukin-6. What they could clearly see was the patients who had increased levels of glutamate and low levels of interleukin-6, which was indicative of the occurrence of the stroke with less than 2 hours. The levels of more than 150 micromoles of glutamate and less than 19 picograms of interleukin-6 was suggestive of acute onset, that is less than 2 hours. And these are the patients probably benefit with thrombolysis, because the wake-up stroke can be missed in these patients, and the beneficial effect can be seen. Co-15, other aspect is to differentiate between transient ischemic attack and ischemic stroke. Co-15 in about 1,100 patients study, they looked at levels of co-15 in these two different groups. They saw the clear difference between patients with ischemic stroke and TIA. Increased levels of co-15 was seen in patients with ischemic stroke. This would also differentiate between cardioembolic stroke and non-cardioembolic stroke. And co-15 was significantly elevated in cardioembolic stroke. This will also tell us about the recurrent vascular events and also occurrence of death. But again, identifying the source has always been difficult. And once we have a certain marker which tells us about the source of origin of this stroke, with the interventions and aggressive management can be instituted. Other factor is about the outcomes in large vessel occlusions. Insulin like growth factor and lymphatic vessel endothelial proteins are the ones which is required for the angiogenesis and vascular remodeling. And thrombospondin, which is potent regulator of angiogenesis and endothelial migration. So these levels were evaluated in patients with acute ischemic stroke due to large vessel occlusions. And they could clearly see that levels of these were significantly higher in patients with stroke respect to large vessel occlusions. They could also see that the patients who had a stroke with good collaterals and stroke with poor collaterals had a poor outcome as expected. And the levels of GFT and LV1 and thrombospondin was indicative of good collaterals and good outcome. And this was one of the markers which is being used in patients following large vessel occlusion strokes. Concerns after the stroke thrombolysis or thrombectomy is about occurrence of hemorrhage or occurrence of infarct and edema. They could see that vascular cell adhesion molecules was significantly elevated in the thrombectomy patients at the time of thrombectomy. They could see at from the clot on the intracranial part and also serum. Increased elevation of these was suggestive of developing in the increase in the infarct volume and also developing edema. This again guide us to intervene early, and then probably these patients can have aggressive management of anti-edema measures and also, if required, decompressive venectomy when there is a risk of increased malignant stroke or malignant edema in these patients. Conversion of the hemorrhagic conversion following thrombolysis. Most of the time we only look at the clinical part, and then we need to get the imaging studies done. However, there was a study which clearly shows that plasma metalloproteinase 9 concentration at admission, and these are all at admission times, and 3 hours, 6 hours, and 12, 24 hours. They could clearly show that patients who had hemorrhagic transformation of the infarct had a higher level of metalloproteinase 9 in these patients. Again, in 2013, they could clearly show that not only the symptomatic IH was developed, but also they could see the outcome of these patients where increased level of these has a hemorrhagic transformation and also the poor outcome and poor recovery status following stroke. When it comes to outcome studies, brain-derived neurotropic factor, which plays a role in neurogenesis and plasticity, they could see that the relationship with low levels of these at 90 days had poor outcome and also increased dependence compared to patients who had higher levels of BDNF. We suggest that there is increased neuron survival in these patients and also increased neurogenesis, which improves the survival. Other factor which has been looked at is the success of decanalization and following RTPA, which usually is done as an imaging procedure, and patient need to go through the imaging process after RTPA. They looked at platelet microparticles which is released following thrombolysis, and increased levels of platelet microparticles in the blood was was considered as successful recanalization compared to patients who had lower levels of microparticles. Again, this is being investigated in a large group of patients. One of the factors which the treatment part comes to is stroke is how to differentiate the ischemic and hemorrhagic stroke. Patients with who needs the thrombolysis in these patients. Now it's only the imaging modality which is available. If we have something like a point of care biomarker which includes RBP4, NT-proBNP, and GFAP, they have shown that they could clearly differentiate the patients with ischemic stroke from ICH, from hemorrhagic strokes. So this may be a marker for initiating treatment at the site when somebody is having diagnosed with stroke. So differentiation to ensure that patients with ischemic stroke gets early intervention compared during this process. There are other marker with other studies which show that with the use of serum biomarkers based approach along with the clinical conditions, clinical assessment, and they could differentiate between mild ischemic stroke and TAA. And Bayes et al. Did an extensive meta-analysis study to show that what biomarkers and how these biomarkers manifest in different states and different situations. And they proposed it's not one single biomarker which is which is expressed, but the multiple biomarkers. They proposed a combination of these biomarkers, different biomarkers based on the nature of the disease. And this is being investigated and being studied in large group of patients. The intracerebral hematomas following hypertensive bleed or following AVM bleed. The expansion of hematoma of these is always a concern, which every time there is an increase in the hematoma size volume, there is increase in the morbidity and mortality. Few biomarkers have shown some promising results about predicting the expansion. MMP9, 1 milligram fracture variant, and IL-6 and fibronectin has been found to predict hematoma expansion in these patients. However, these are all the small group of study which just done, and probably needs further validation. Coming to subarachnoid hemorrhage, one of the major issues with subarachnoid hemorrhage they have, in spite of improved technology and interventions and understanding of this, still they have a significant morbidity and mortality. And currently, the clinical grading and neuroimaging and multimodality monitoring are used to determine the progress and also to prognosticate. So we need a marker which can tell us as a dynamic one which happens over the course of time. One of the major complications was the vasospasm, and Hong et al. Did extensive review about the outcome predictors in subarachnoid hemorrhage. They listed a number of biomarkers, whereas that was the time when they could not quantify it. Now, with that progress, seen that with microdialysis, one of the things which is done in intensive care unit, and they could see the taurine amino acid was increased in the levels, which is correlating with edema and also with development of delayed cerebral infarction. So taurine levels in the microdialysis assessment estimation can give us a clue about the occurrence of this. More than 35,000 micromoles per liter of levels of taurine has been associated with definite occurrence of PCI. The need for the biomarkers to predict the delayed cerebral ischemia or vasospasm. Here they looked at the CSF analysis and the serum IL-6 inflammatory markers, because they have seen that inflammation is one of the causes for the occurrence of vasospasm, and the levels in CSF was correlating with the occurrence of the vasospasm between 4 and 14 days, whereas serum levels was clinically negligible. So CSF analysis gives us much better clue about the occurrence of these DSI much before the clinical manifestations. And they could also show that increased levels had a correlation with the development of infarction compared to levels who did not have infarction or no DCI. Comparing with assessment with transcranial Doppler with flow velocities, it was seen that 1 milligram factor had significantly elevated levels in patients who developed vasospasm compared to who did not develop vasospasm. This was correlated with transcranial Doppler studies. So we have some markers which can tell us about development of vasospasm, which can predict vasospasm, and these again need to be validated with large multicenter trials. This particular global proteomic analysis of entire spectrum of intracranial aneurysm was done. This was done at PGH Chandigarh. Dr. Sharma et al. And Hemant Bhagat, one of our people, was part of this this particular study. And they evaluated multiple, about 980 samples where tissue samples were collected. It's a very complex methodology design, which I'm not able to explain, and which is difficult to explain with a short period of time. But what finally they did was the 4 groups. One is control, second one was one with unruptured aneurysm. T2 groups was ruptured aneurysm without vasospasm, and T3 was ruptured aneurysm with vasospasm. Amongst the multiple parameters, amongst the multiple markers which was isolated, they could clearly define the ORIM, the glycosylated protein, was significantly elevated in unruptured aneurysm. This forms the basis for clinical evaluation in high-risk patients. And MMP9 was upregulated in patients who had vasospasm with ruptured aneurysm. So these are the 2 clinical clear findings about this particular. They have multiple markers was also studied with respect to A100, S100, A8, A9, CRP, thrombospondin, and various other markers was also evaluated in this particular study, which they are being taken into this aspect in larger group of studies. MicroRNA again is being looked at for predicting complications, also how these manifest in various situations, and also can they be a factor which can give us a clue about occurrence of these spasm, vasospasm, and prognosis. Coming to seizure disorders, we do have patients who have intractable epilepsy, or patients who has convulsions and status epilepticus state. And many studies have demonstrated that it's an immune-mediated, can be immune-mediated, and significant inflammatory factors plays a role. And we can see here many factors play a role in neuroinflammation. And finally, final common pathways, patients having seizures. So we need a marker which can tell us about the response to therapy, can tell us about something which can predict these patients can have drug-resistant seizures. High mobility index can have a significant role to play immune-mediated reaction, and it was seen that increased levels was seen in drug-resistant epilepsy. So this becomes a prognostic biomarker. The levels of these can suggest that these patients can have a drug-resistant seizures, and thereby guide us to change the plan of the management of these patients. Programs cell death protein levels was significantly elevated with intractable epilepsy, and it could clearly differentiate between the normal and the partial seizures, epilepsy seizures. This becomes a very important aspect for in the neurocritical care, because patients many a times we see non-convulsive state epilepticus. If these levels are significantly elevated, when bedside EEG may not be available in all kind of point of time, this can be bedside estimation of to detect that they have intractable epilepsy in these situations. The neuromuscular diseases wherein the biomarkers have any play role, acute inflammatory polyneuropathy and chronic based on the duration. Chronic usually is a progressive disease, and they can still present with acute deterioration, acute phase, and it becomes difficult to differentiate between this and the GBS, because they have a similar neurophysiological parameters and representation. And what they did was they looked at the CSF of IL-8 because it's inflammatory marker, And they could clearly differentiate that patients who had IL-8 of more than 70 picograms per ml, the patients had acute demyelinating polyneuropathy compared to chronic patients. So this particular marker is going to be an useful marker to say that these patients have a chronic acute on phase of a chronic polyneuropathy or it's an acute neuropathy. Presently, myasthenia gravis is being diagnosed based on clinical parameters and also on nerve conduction studies, and of course the markers like antibodies for acetylcholine receptors. However, they can have variants which can result in difficulty in diagnosis and prognostication. Metabolomics, which means that there are metabolites in the are released into the system, and which in specific diseases. So they're looking at the metabolomics of these, and various metabolites have been isolated with respect to diagnosing of variants of myasthenia gravis and also diagnostic prognostication. Delirium in neurocritical care is always a problem because many patients have a lot of factors, which are risk factors in the intensive care critical neuro ICU. Not only infection and long duration of ventilation, sedation, and the neural injury itself. So increased duration of delirium has high morbidity and mortality. And what they're trying to look at is because it's an inflammatory mark, inflammation was one of the key factors in the occurrence of delirium. They looked at S100B and interleukin 6 and 8, which were significantly elevated in these patients who had delirium. It could also look at severity of the duration. However, there can be confounding factors with respect to this, and it needs further validation and further quantification of these levels compared to patients who develop delirium and who do not develop delirium. Because this will actually help us to actually plan this for intervention at some point of time so that these patients have good outcome at the time of discharge from the ICU. Coma and brain death, the patients, we're looking at the patients who had out of hospital cardiac arrest and admitting into the ICU. There's a need to prognosticate these patients. And what they looked at was, they had three, this is from the targeted temperature management data. They analyzed this. They looked at clinical variables only and their outcome assessment, and clinical variables along with clinically accessible biomarkers like neuron-specific enolase, S100B, troponin T, BNP, and PCT. And the third group was these two, and also research-grade biomarkers like neurofilament and copeptine and interleukin and tau and other markers. They could clearly show that neurofilament light chain has persistently higher levels in all 3 days of following resuscitation and admission to the intensive care unit, and has got a very low risk of false positive prediction. So they could clearly show that these patients who had higher levels of NFL had poor outcome in these patients. So we have futures with respect to POC test. GFP is already FDA approved, and it's been evaluated with tracked GBI studies. And biomarkers like S100B is also seen in saliva and urine. And urine, this merino-bifidobacterium, which is inflammatory marker, which is increased in patients with concussive injuries, like in sports injuries, and it's detected up to 3 weeks of injury. So this, and also it also correlated with the cognitive function. So these are the markers which can be of use in the future, which have been evaluated and worked upon. So to conclude, we have newer technology developed and is with better understanding and take us very close to reality of rapid diagnosis, interpretation, and initiate treatment at the site. And we probably in the hope that we achieve that troponin of the brain can be estimated and can be isolated, and biomarkers should be considered as a potential additional tool rather than taken in isolation, and with also with clinical tools has to be looked at for these. These are the, so what is the clinical utility? These are the markers which has definitely got a clinical utility and is going to be one of the point of care panel, which has already been slowly started off with S100B and GFAP and also neurofilaments. And slowly these are the ones which be included in the point of care panel for rapid estimation and evaluation of these patients. So before I conclude, this is an important development in biomarkers which tells us predict, diagnose, and prognosticate, and also tell us about pharmacodynamics and pharmacological issue with respect to efficacy of therapeutic agents. Before I conclude, my pronouns to all my teachers who have been guiding me all these years, and also my colleagues who have been very supportive, and finally to my family, my wife and daughter who has been unconditionally supporting me all these years. Thank you so much. It's my privilege to have delivered this oration, and I thank ISNACC and the organizers for giving this opportunity to deliver this oration. Thank you so much.
Thank you, Dr. Venkatesh. Am I audible, sir?
Yes, yes.
Yes, sir, you're audible, sir.
It's a great privilege for me to honor and thank Dr. Venkatesh for his excellent presentation on the utility of biomarker in neurocritical care in this prestigious Dr. Goday's oration in ISNACC 2022. All of us know that Dr. Goday was one of the founder, faculty member, and head of the Department of Anesthesia in AIIMS, and his great contribution in starting and growth of the Anesthesia Department in AIIMS and Anesthesia specialty in India will always be remembered. On behalf of the Department of Neuroanesthesiology AIIMS and the whole ISNACC family, I thank Dr. Venkatesh once again for his wonderful talk and updating our knowledge in this very important and newer aspect of neurocritical care. I would like to congratulate and thank all the organizing committee members of ISNACC 2022, especially Madam Vibhu Kalyani Das and Dr. Indranil for working hard in this COVID time and organizing this great conference. I am grateful to both of my teachers, Professor Dash and Professor Vittal, for chairing this prestigious oration and remembering their great experiences with Professor Goday. I would like to thank all the office bearers of ISNACC Society, guest faculties, delegates, residents, and other staff members for participating in this oration. Lastly, once again, I would like to thank Dr. Venkatesh for his excellent presentation. And now I request the organizers to felicitate Dr. Venkatesh with memento and certificate as a token of our appreciation. Organizer, please felicitate.
Thank you all for joining us in this oration. And I thank Dr. Venkatesh for an excellent deliberation covering this new aspect of neurointensive care. And this is our small token for this excellent oration. Please accept it. Venkatesh sir, thank you.
Thank you so much. And thank you, Professor Dash, Dr. Vittal, and Dr. Chaudhury. And they have always been my guide, mentor many of the times. And Professor Dash, I can't forget, he has been always supportive.
Thank you, everybody.
Thank you, sir. Thank you.
Stay safe, stay blessed.
Thank you, Dr. Venkatesh. Thank you, everyone.
Thank you, Indranil.
Yes, sir.
Thank you, Dr. Vittal and Arvind, and of course, Venkatesh.
Thank you all, sir. So we are closing this session and we are moving on to the next session, which will be moderated by Dr. Sujata Ghosh.
Thank you.
Thank you.
Good morning, everybody. And now we move on to the next promising session. And this session will be chaired by Professor Smita Sharma, Professor Jayanto Bhattacharya, and Professor Manikandan. Next slide. Dr. Smita Sharma is the consultant neurologist from Bombay Hospital and the treasurer of ANCC Mumbai, and the co-organizing secretary of ISNACC 2018 and the past EC member of ISNACC. She is also the past president of the Association of Medical Consultants, Mumbai. Next. Dr. Jayanto Bhattacharya.
Yes, I am here.
And welcome, Dr. Jayanto Bhattacharya.
Thank you, thank you.
He is the past president of Indian Society of Anesthesiologists, West Bengal, and he has multiple national and international publications, and he's a professor and HOD of Queen's in anesthesiology. Next. And our third chairperson is Dr. S. Manikandan, who is the professor and head division of neuroanesthesia and critical care, Sri Chitra, Tirunal Institute of Medical Sciences and Technology. And his area of expertise is in neurocardiology, neuromonitoring, medical device development, patient safety, neuroanesthesia. He has 72 peer-reviewed publications, 4 books, and he has trained over 25 DM neuroanesthesia residents. And we have 3 lovely topics here today. The first topic is perioperative evaluation and management of epilepsy surgery. And I request Dr. Smita Sharma to introduce our first speaker, Dr. Priyanka Khurana.
So Dr. Smita Sharma has requested me because she's held up in the DC meeting. So I would like to proudly, I would like to proudly introduce Dr. Priyanka Khurana, so who is at present working as Associate Professor at Neuroanesthesia Unit at Department of Anesthesiology in GB Pant Institute of Postgraduate Medical Education and Research, JIPMED, New Delhi. Her area of special interest is into neuromonitoring, epilepsy surgery, neurocritical care management of subarachnoid hemorrhage. So I'd like to point out epilepsy surgeries are considered to be very precise surgeries, similar to atrial septal defect closure, where just Dr. Smita Sharma just joined, I think. Okay, they are very precise surgery. We expect 0 complication rate following surgery because they are very elective and planned procedures. In my experience, we sometimes get into trouble in the post-operative period is these patients. They may develop status and complications, which is not acceptable in the literature. So I would expect Priyanka Khurana to have a very lucid lecture on how to manage this in a more efficient way to produce 0 complications in these kind of high patients, high-risk patients. Over to you, Dr. Priyanka.
Good morning, everyone. I will be discussing about the perioperative evaluation and management of epilepsy surgery. Epilepsy is the second most common neurological disorder with huge global burden. Around 30% epilepsy patients develop intractable epilepsy, and these are the most commonly encountered patients at any epilepsy center. According to International League Against Epilepsy, drug-resistant epilepsy is defined as failure of adequate trials of 2 appropriately chosen anti-epileptic drugs. So now the international consensus is that any patient who develops drug-resistant epilepsy or intractable epilepsy should be referred to an epilepsy center. At any epilepsy center, the possibility of inappropriate treatment is ruled out and comprehensive assessment is done to find the suitable surgical candidates. Now, why epilepsy surgery has a role in refractory epilepsy? Though epilepsy surgery is being performed for more than over a century, evidence for its better outcome was gathered fairly recently. Just 3 RCTs have been done till now to compare medical versus surgical outcome. And it was found that there was significantly better seizure-free outcome when epilepsy surgery was performed in refractory epilepsy patients. Also, it has been seen that longer the delay between the onset of drug-resistant epilepsy and surgery, lower is the chance of post-operative seizure freedom and improved psychosocial outcome. At any epilepsy center, epilepsy team comprises of battery of specialists, right from neurologist, neurosurgeon, neuroradiologist, neuroanesthetist, electrophysiologist to experts for psychosocial rehabilitation, including clinical psychologists, speech therapists, and social workers. At our center, we hold monthly clinico-radiological meetings and discuss management plan for the scheduled epilepsy surgery patients. Now, the major goal of pre-surgical evaluation is basically to localize the epileptogenic zone, which is defined as the minimum amount of cortex
that must be resected to produce seizure freedom. This also means that the success of surgery depends on the accurate localization and resection of epileptogenic zone. Apart from epileptogenic zone, other zones as described by Loder are ictal onset zone. It is from where the seizures start. Epileptogenic lesions, which includes the structural cause of seizure. The irritative zone from where you get the interictal discharges and also cause physical manifestations of this seizure. The other goals of the pre-surgical evaluation are to decide for the invasive testing in case of discordant lesions and to determine if there is any functional damage which can occur after the surgery. The diagnostic assessment is usually multimodal and concordant findings from different diagnostic modalities are basically looked for. The localization of epileptogenic zone is usually done by neurophysiological studies like scalp EEG, video EEG, intracranial EEG, and structural and functional imaging. EEG has relatively low sensitivity in epilepsy, ranging between 25 to 56%. Although specificity is better, but again variable. Video EEG is simultaneous recording of patient's seizure semiology with EEG. Anti-epileptic drug dosage needs to be reduced before this monitoring. This is the video EEG lab of our institute, where you can see the neurophysiologist is at the console and monitoring the EEG, and a camera is positioned in the patient's room, which captures the sequence of physical manifestation of the seizures. Invasive EEG is required when epileptogenic zone is not delineated with video EEG and structural imaging. It can be carried out with subdural electrodes that are implanted on the surface of the brain, or else with stereotactically implanted depth electrodes, or for the detection of seizure foci in deeper structures such as insula, amygdala, or hippocampus. If we look at the structural imaging, then 3 Tesla MRI is considered better than 1.5 Tesla. The recommended MRI epilepsy protocol includes T1 weighted sequences in oblique coronal view, orthogonal to hippocampal axis with 1 mm slices. T2 weighted images again in oblique coronal view, perpendicular to hippocampal axis, which is important, with 2 to 3 mm slice thickness. And apart from that, axial T2 weighted images of the whole brain with 3 mm slice thickness. DTI may also be required to identify important fiber tracts that should be preserved. Functional imaging is useful if structural imaging studies have not revealed any epileptic lesion or if multiple lesions are present. PET, SPECT, and subtraction techniques are used for this purpose. Functional MRI is used for identifying the eloquent brain areas. WADA's test is mostly performed to identify cerebral hemispheric dominance if the lesion is near the eloquent cortex. Traditionally, sodium amobarbital was used, but due to its non-availability now, propofol is being used. Functional MRI has mostly taken over its role of WADA's test these days. This is in short the various modalities used to localize epileptogenic zone. This varies from all the imaging techniques, which includes CT and MRI, to the functional imaging techniques, to the electrophysiological studies, to the advanced tests like WADA's test and the functional MRI tests. So if you look at the pre-surgical evaluation, most of the patients just require epilepsy protocol, MRI, and video EEG to localize epileptogenic zone. In case of discordant lesions, findings or no structural imaging, invasive testing in the form of PET, MRI, SPECT, etc. is required. If multiple lesions are found, then we may have to go for palliative procedures like neurostimulation techniques. So once the epileptogenic zone is localized, then neurophysiological tests are performed on all patients for the assessment of IQ and memory. A thorough psychiatric assessment is also performed as psychiatric disorders are commonly prevalent in epilepsy patients. So what is the rationale of performing epilepsy surgery? The rationale is to have complete resection of the epileptogenic zone. Basically, there are three types of epilepsy surgery: resective, disconnective, and neurostimulation. In resective surgery, as already discussed, the offending lesion is removed. Anterior temporal lobectomy with or without amygdalohypocampectomy is the most commonly performed epilepsy surgery, which has the cure rate of up to 90%, especially in patients with seizure foci localized to mesotemporal sclerosis. Disconnection procedures are performed when multiple seizure foci are present or if the lesion is near the eloquent area and is non-resectable. These kind of procedures decrease seizure onset frequency and limit its propagation. It includes hemispherectomy, corpus callosotomy, and multiple subpial transactions. Patients who cannot undergo surgery may require palliative procedure like vagal nerve stimulation. Here you can see the procedure aimed at resecting epileptogenic foci. These are the disconnection procedures, surgeries to reduce seizure frequency and propagation. And these are the procedures aimed at reducing the seizure frequency via neuromodulation. Now, once the patient has been scheduled for surgery, anesthetic management needs to be planned. The major anesthetic goals include preoperative assessment of the patient's neurological condition, comorbidities, and anti-seizure medications. Intraoperatively, maintenance of appropriate cerebral perfusion with control of brain bulk is important. Most importantly, right environment needs to be provided for ECOG monitoring by selection of appropriate anesthetic agents. Sometimes even seizure induction is also desired. Postoperatively, rapid emergence from anesthesia for postoperative neurological evaluation is aimed, and postoperative seizure control might be necessary. If you look at the anesthetic considerations, then these patients are at risk of perioperative seizures. Pediatric patients may require special considerations related to airway and fluid management. These patients may have associated comorbidities, and prolonged use of anti-epileptic drugs may cause certain systemic effects. These patients also undergo different types of surgery at different anesthetizing locations like CT MRI suite, neuroradiology suite. Anesthetic management also can vary from awake craniotomy to craniotomy under general anesthesia. Intraoperative electrocorticography is an important consideration which may require pharmacoactivation of the epileptic focus. There might be associated complications related to the procedure. So once the patient has been scheduled for surgery, a thorough preoperative evaluation and assessment is important. A detailed knowledge of patient's seizure pattern should be there. Evaluation should be done for associated comorbidities and its optimization should be done. Also, adverse effects of chronic anticonvulsant therapy should be looked for, and any associated disorders with epilepsy should also be assessed. These are the possible disorders associated with epilepsy, which should be evaluated. It includes von Recklinghausen's disease and tuberous sclerosis. Systemic effects of anti-epileptic drugs should be looked for and optimized before taking up the patient for procedure. Chronic use of phenytoin and carbamazepine may cause resistance to non-depolarizing muscle relaxants and elevation in liver enzymes. Carbamazepine may also cause depressed hematopoietic system with decreased blood counts. Topiramate may cause non-anion gap acidosis, and valproate may cause thrombocytopenia. So now the anesthetic management may be required for varied type of procedures, which include diagnostic surgical procedures like placement of intracranial electrodes, to resection of epileptogenic brain lesions, which may be performed under either general anesthesia or awake craniotomy, to palliative procedures like disconnection surgeries or stimulation surgeries. If you look at the anesthetic management of diagnostic surgical procedures, these procedures include subdural grid electrode placement, stereotactic EEG, wherein depth electrodes are inserted, and epidural electrode insertion, which requires multiple burr holes and is a lengthy procedure. General anesthetic considerations for craniotomy are usually followed in such procedures. If we see the anesthetic management of resection of epileptogenic brain region, this is usually done under the guidance of electrocorticography. Anesthetic agents have variable effects on electrocorticography, which is why the dose of these agents need to be decreased during the period when electrocorticography is being performed, and this can cause awareness. So let's first have a look at the effect of anesthetic agents on cerebral electrical activity. Barbiturates have anticonvulsive properties. Benzodiazepines in low dose can be given while performing electrocorticography. Propofol has variable effects. At low doses, it causes spike activation and myoclonic movements. At high doses, it may depress electrocorticographic readings. Etomidate and methotrexate can activate seizures and may assist activation of ictal foci during electrocorticography. Ketamine induces non-specific activation of interictal epileptic discharges and is thus not useful in epilepsy surgery patients. Opioids like morphine and hydromorphone do not have any significant effect. Although remifentanil and elfentanil at bolus dose cause stimulation of spike waves. In fact, world over, elfentanil is the most commonly used drug for pharmacoactivation. Fentanyl has minimal effects on epileptiform electrical activity. If we look at the literature on propofol, most of the studies were done in late 90s and have shown variable effects on EEG and electrocorticography. Only in recent past, Snyder et al. In 2011 also found no effect of propofol on ECOG when studied on patients undergoing video ECOG. If we see the effect of inhalational agents, nitrous oxide is usually inert. Isoflurane has good safety record in epilepsy patients. Enflurane can generate myoclonus and epileptiform activity, and with sevoflurane can cause widespread neuroexcitatory activity which may hinder seizure focus localization. Watts et al. Compared sevoflurane and isoflurane in patients with refractory epilepsy and found that neurostimulation with inhalation agent occurs at around 1.5 times MAC value, which means that neurostimulation with inhalation agents is mostly dose dependent. At low doses, these inhalation agents do not have much effect on ECOG or on the cerebral electrical activity, but at high doses, that is around 1.5 times the MAC value, it can cause neurostimulation. So we can see that majority of anesthetic agents interfere with intraoperative electrocorticography and thus require reduction in doses during the period of ECOG. An ideal agent should be one which should minimally alter the ECOG without requiring reduction in its doses. This would enable smooth and steady anesthesia that doesn't cause awareness while maintaining hemodynamic stability and promoting early recovery. So Dexmed is a short-acting alpha-2 agonist which, due to its favorable pharmacokinetic and pharmacodynamic profiles, has become an important adjunct in epilepsy surgery. So though it is common fact that Dexmed has minimal effect on EEG, but if you dig into literature, only very few studies have been conducted, that too on small series of patients undergoing awake craniotomy or video EEG, where it was shown to have no effect on EEG. In fact, there are only a couple of RCTs related to dexmedetomidine, out of which Oda et al. In 2003 used Dexmed with sevoflurane during ECOG and found no effect on the spike frequency in his trial. Recently, Chaitanya in 2015 found an enhancement in spikes during intraoperative ECOG after Dexmed bolus was given. So we at our institute recently conducted an RCT wherein we compared the effect of dexmedetomidine in combination with iso or propofol on electrocorticography. We compared the mean ECOG score grade before and after giving Dexmed in both propofol and isoflurane group and found that Dexmed marginally augmented the ECOG readings when added to isoflurane group. Time to emergence was also slightly higher with iso Dexmed group. Thus, dexmedetomidine as anesthesia adjunct was effective in preventing intraoperative awareness, maintaining hemodynamic stability, and resulting in early patient recovery from anesthesia. So for the anesthetic management of surgery for resection of epileptogenic area, preoperative dose of anti-epileptic drugs should be given in discussion with the neurologist and or the surgeon. Every institute has its own protocol. We at our center usually continue with the morning dose. At induction, benzodiazepine pre-medication may be avoided as it might be avoided. Induction with thio or propofol can be done. Proconvulsive drugs should be used with caution. IV lidocaine and barbiturate should be avoided later during the anesthesia. During maintenance, before electrocorticography, both IV and inhaled drugs are to be weaned down or stopped, and low-dose opioid infusion or dexmedetomidine may be continued. During ECOG, low concentration of inhalational agents is permissible with muscle relaxants. Pharmacoactivation may be needed for enhancement of interictal discharges. The best agent is bolus dose of alfentanil, followed by etomidate and methoxetal. Any intraoperative seizure has to be dealt by cold saline irrigation or by propofol or midazolam boluses. However, once such drugs are administered, one should be mindful that they may interfere with the electrocorticography. Severe bradycardia has also been reported during amygdalo-hippocampectomy, which may be due to surgical limbic system stimulation resulting in enhanced neural vagal activity. When seizure foci are diffuse, then it requires removal of substantial portion of cerebral hemisphere. This procedure is called cerebral hemispherectomy. It is usually performed in children and is associated with significant morbidity and mortality. Complications include massive blood loss, electrolyte and metabolic disturbances, coagulopathy, cerebral hemorrhage, seizures, hypothermia, and metabolic acidosis. Even neurogenic pulmonary edema can also happen. Vasopressors and inotropes should always be kept ready in this procedure. It is also associated with significant postoperative complications. Now, awake craniotomy is usually performed in those patients where epileptogenic zone is near the eloquent cortex and there is high risk of functional deficit. It can be performed under MAC or asleep, awake, asleep, or under asleep, awake techniques. So vagal nerve stimulation is a palliative procedure where the stimulator emits electrical pulses from a generator through an implanted wire to an electrode which is wrapped around the left vagus nerve to modulate cerebral neuronal excitation. It has been demonstrated to reduce the seizure frequency. The perioperative complications during this procedure includes seizures, bradycardia, vocal cord palsy, complete AV block, and ventricular asystole can also occur while performing this procedure. So coming to the emergence from anesthesia and postoperative management. Postoperative management requires rapid emergence from anesthesia for early neurological assessment. However, prolonged anti-epileptic drug use may cause slower recovery. Anesthesiologists should also be vigilant for the onset of seizure. Seizures anytime in the postoperative period. Also, analgesia should be maintained with longer-acting drugs. Complications after epilepsy surgery in postoperative period usually includes functional deficits, cerebral edema, onset of seizures, or later complications include CSF leak. So in summary, success of epilepsy surgery depends on the precise localization of the epileptogenic foci and its complete removal. Surgery for epilepsy may be diagnostic or therapeutic. Anesthetic management of patients undergoing surgery for epilepsy pose significant challenge for the anesthesiologist, and all the agents usually affect intraoperative electrocorticography in a variable manner. The quest for ideal anesthetic regime for epilepsy surgery that cause no or minimal interference to electrocorticography reading still continues. Thank you.
Thank you, Dr. Priyanka. It was very wonderful lecture. I hope we will have the questions at the end.
Hello, I am Dr. Jayanta Bhattacharya. Our next session will be presented by Dr. Ajay Prasad Rishi. He is at present the Associate Professor in the Department of Neuroanesthesia and Critical Care in Sri Chitra Tumul Institute for Medical Sciences and Technology in Trivandrum. He has several honors awards and also over 40 presentations in the national and international conferences and over 60 publications in national and international journals. So may I request Dr. Rishi to proceed.
Thank you, sir. First of all, warm greetings from Sri Chitra Institute, Trivandrum. I would like to thank Dr. Vibhu Kalyanidas ma'am and Dr. Indranil for organizing such a wonderful conference. So coming straight to the topic, I'll be talking on transesophageal echocardiography in neuroanesthesia and neurocritical care settings. Now, the brief overview of what I'll be dealing with today, I'll be just telling about the basic views which are essential for us in neuroanesthesia and critical care practice, and also a few interesting pathological conditions which we might encounter in these settings. So a brief probology. As we know, T-probe is a semi-invasive procedure. So the probe we insert through the mouth after keeping a bite block. We have to ensure that the patient does not bite on it when he or she is awake. Under anesthesia, especially if it's on a lighter plane, there's a chance that the probe might get damaged or injure the teeth or the tongue. And the few terminologies which we use is when we insert it, we call it advancing, and when we pull out, it's called withdrawal, as well as we do rotate it clockwise as well as counterclockwise. Usually we rotate towards the right side to visualize more of the right-sided structures of the heart, as well as to the left, similarly to visualize the left-side structures. Also, as you know, the two different knobs here. As you can see, the bigger wheel is for the anti-flexion as well as the retroflexion of the tip, and the smaller wheel is for the lateral flexion to the right as well as to the left. And there's two buttons here, as you can see. That's for the angle of insonation for the T ultrasonic waves. Now, coming to the first view, usually what we encounter as soon as we put is in the upper esophageal, we'll be seeing the aorta and the arch, but I'll not be talking about that. So the first cardiac structure which we will be encountering is the 5-chamber view, as you can see here. And it's at 0 degree. We don't need to manipulate the buttons at all. So the angle of insonation remains 0 degrees. And usually it's mid-esophagus is around 25 to 35 centimeters from the incisors in Indian population. So that's the depth at which we are going to get this image. And the nearest structure, as you can see from the esophagus, is always the left atrium. So here you can see the left atrium, the left ventricle, and the right atrium and the right ventricle, as well as the aortic opening. So slowly, from this view, if we slightly retroflex, we get the 4-chamber view, which is of great importance to us in the perioperative period. So in this view, we can make out the LA, LV, RA, RV quite nicely, because we have taken out the aortic opening from here. And this view is important, starting from if it's a patient who is coming with trauma to the chest or anything. It's a multi-trauma patient. We can rule out any effusions or any tamponade. As you can see, this is the pericardial reflection here. And you can see there's a hypoechogenic zone. That is essentially the blood or effusion there. And you can see that LV and the cardiac has been compressed to one side, and this can be a major cause for hypotension in these set of patients, and it's very important we diagnose it. Next, coming to the other uses of this view, it's mainly the septal defects. As you can see here, you can make out the atrial septal defect between the left atrium and the right atrium here. And also you can make out the ventricular septal defects between the two ventricles. And also, it's very important that we can make out any stenosis of any valves. Essentially, the two main valves which we visualize here is a tricuspid valve and the mitral valve here. And you can see the calcified mitral valve here causing severe mitral stenosis and stasis of the blood here in the left atrium. We do encounter these kind of patients, especially with rheumatic heart disease and atrial fibrillation, and these patients do throw up embolisms and can present as a stroke patient, embolic stroke, as well as because of the underlying anticoagulant therapy, they can even present with ICH. Also, we can make out any mitral regurgitation if it's there or not in these kind of these subset of patients. Next, from the four-chamber view, if we increase the angle of inclination to around 80 to 100 degrees without changing the depth, as well as if we do not rotate, we do get the mid-esophageal two-chamber view. And sometimes, especially our neurosurgical patients are not exactly supine, so they might be tilted slightly to the right or the left for the positioning ease during the intraoperative period. And we do need to compensate in such scenarios by giving an additional left-sided rotation on the throat to get a better view. So in this view, the structures of significance for us is the left atrium, the mitral valve, the left ventricle, and the left atrial appendage, as you can see here. And this view is important to us because any clots in the left side of the heart is easily visualized in this view. Also, in patients who are having atrial fibrillation, like I said before, these patients do develop clots because of the stasis of the blood in the left atrium, and usually the blood tends to have stasis, long-term stasis of blood, and if they are not on anticoagulation, can have left atrial appendage clots. So it's very essential we look at this corner here to pick up any clots in such group of patients, as these clots can embolize during the intraoperative period and can cause another embolic stroke, or it can even cause an MI if it gets embolized to the coronary circulation. Next, this view is also good to evaluate the systolic function of the heart, both qualitatively as well as quantitatively. So as you can see, the left ventricle here, it's we divide it into different zones of interest. So the basal, mid, as well as apical. So this is the basal here. The mid is here, mid ventricular section, and this is the apical. So based on this, as well as the circulation, so as you can see, the coronary territories of the coronary circulation is based on the walls. The different walls of the heart is supplied by different coronary vessels. So here here we have the anterolateral wall, which is essentially supplied by the left circumflex or the left anterior descending artery, and usually the interseptal wall is supplied by the RCA territory here, and the inferior as well. So if there is any regional wall motion abnormality, you can make out and you can easily diagnose which coronaries is having flow deficiency. Also, it's of very importance to us, especially in patients who are having subarachnoid hemorrhage, and they're quite, if they present at quite young age without any baseline echo or as an emergency procedure getting done for coiling as well as for clipping. These subset of patients, even though they have been functionally normal pre SAH, post SAH, they can develop cardiomyopathy, wherein which they'll have an apical stomach, so wherein which only the basal and the mid zones contract, thereby resulting in an apical ballooning, as you can see here. And this can lead to cardiogenic shock in the perioperative period, and it's very important we diagnose this so that we can treat it appropriately. Next, coming to the Subjectively, how we do with the Simpson's technique is the same two-chamber view, just like how we do in a thoracic sector. We can use the Simpson's method, and we can get the ejection fraction, the end systolic volume, and also the fractional area structure. Next, from the mid-esophageal two-chamber view, if we increase the angle of insonation, as you can see here, to around 135, that is between 120 to 140 range, we can now visualize the LVOT, that is the left ventricular outflow tract, as well as the aortic valve here, as well as the takeoff of the aorta here. So this view is quite useful in case of HOCMs or in patients who have had an MI resulting in systolic anterior motion SAM scenario, where in which the anterior mitral leaflet, as you can see here, during the systole, it goes and occludes the LVOT, thereby causing an obstruction to the left ventricular outflow tract, thereby causing hypotension in this scenario. So any amount of inotropism or vasopressors are not going to function, but essentially we need to reduce the heart rate in this scenario to actually improve the blood pressure. Next, this view is quite often encountered, as well as it's of interest to most of the neuroanesthesiologists. So this is the mid-esophageal bicaval view. And this view from the mid-esophageal four-chamber view, if we increase angulation to around 90 to 100 degrees, and if we rotate the probe towards the right side, we get the mid-esophageal bicaval view, as you can see here. So this is the SVC, this is the RA, and this is the LA, and this is the interatrial septum. This view is quite beneficial for us in neurosurgical setting, as we can make out any air embolism which happens in the intraoperative period. Few bubbles are noted during the skin incision as well as during the muscle dissection. However, if there is a gross air embolism, we do grade it using a TE based on the following grading. And also, it's quite useful to position the center line as well as to see your guide wires here. So, and this structure here is the Crista terminalis. That is a landmark which we use to position the central venous catheter in case we need to aspirate for air embolism. And coming to the saline contrast study. So if we have to see for any of patent foramen ovale that is visualized here, either we can use a color Doppler, or it's always better to do saline contrast study. So we you can use an agitated saline here, and we give it through the central line or any peripheral line, which is apparently a cubital vein or something. And in which case you can see an air shower happening in the right atrium here, with no bubbles coming into the left atrium. If more than 3 bubbles are visualized in the left atrium, that shows that there is a patent foramen ovale, and these patients are at higher risk for paradoxical air embolism in the perioperative period. Next, another thing, as we are neuroanesthesiologists, we might tend to use mannitol in the perioperative period. So what we should know that is mannitol crystals do look like air bubbles in the when picked up by the TE. So we should not get alarmed by seeing the shower when you're using mannitol. It's quite normal, because the mannitol crystals do tend to cause this, and it's quite a normal phenomenon. Now coming to the other uses of this view, as I told before, we can use it to position ventricular atrial shunts, or as well as we can use the same view for positioning central venous catheters, especially in patients who are having ventricular atrial catheter already in place, ventricular atrial shunts in place. So as I told, the Crista terminalis is the landmark for this, and this is how we position, we help the surgeons position the VA catheter. Next, also another additional importance of this view is we can identify the SVC collapsibility index. That is one of the good dynamic indices for predicting volume responsiveness, especially in patients who come in whom volume therapy is very essential, such as in aneurysmal subarachnoid hemorrhage. So in this view, essentially we put M mode across the SVC, and you can get the M mode tracings, and we see the maximum SVC diameter and the minimum SVC diameter for 3 respiratory cycles. And we take the average of 3 cycles, and we, using the formula, we can calculate the SVC collapsibility index. And if anything more than 38%, these patients are volume responding, and they contribute a quite good marker with almost 98% sensitivity and specificity. Next, coming to the other view, so mid-esophageal AV short axis view is one of the views which might be helpful if any patients with congenital heart disease do come for us, especially tetralogy of Fallot, who come for like brain abscess surgeries. So in this view, as you can see, there is the left atrium, there's the right atrium, there's the tricuspid valve, there's the right ventricle, and here is the pulmonary outflow tract. And this is a normal patient, and here you can see the hypertrophied right ventricle, the right ventricular obstruction happening here. The last one of the last views which is of benefit to us in the intraoperative period or in the ICU is the transgastric short axis view. And in this view, as you can visualize here, this we get to see the left ventricle as well as the right ventricle in the short axis. And again, we can achieve this the 3 views, that's the mid, papillary, as well as the apical view by adjusting the depth and by advancing or slightly withdrawing the probe. So the advantage of these views are we can make out the regional wall motion abnormalities here based on the coronary perfusion. So this is the lateral wall, here is the anterior, this is the inferior wall, and this is the septal wall. So this view, we get to see all the walls of the left ventricle, as well as we can grade if any hypokinesia or dyskinesia is there, we can mark it accordingly, and we can know which territory, whether it's the coronaries or the circumflex or the anterior descending, which is causing the hypoperfusion to the myocardium. Now, like I said, this view is good for assessing the left ventricular function, and also the famous kissing papillary sign is obtained in this view, that is in patients who are hypovolemic. And as you can see, that the anterior lateral papillary leaflet as well as the posterior medial, both the papillary muscles are coming in quite close approximation, which is an indication that this patient is hypovolemic. Now, again, the same view can be used in M mode to get the systolic function. And here we can get this the fractional shortening in addition to the EF. So which is quite beneficial in case to rule out any global hypokinesia or not. So the common indications of T in our perioperative and ICU practice is, again, like I said, venous air embolism, to interrogate any hemodynamic instability, and to identify any underlying cardiac dysfunction is there, especially when the patients do come in for emergency surgeries like stroke, SAH, or ICH. And also to assist the surgeon in positioning ventricular atrial shunts, as well as to guide us to put RA catheters. And like I said, if there is a intraoperative hypotension, if you have a TE, especially when there's a craniotomy happening, but if the surgeon hits the sinus, we don't know whether it's due to the air embolism or whether it's due to the loss of blood causing hypovolemia. And whether when there is an intraoperative MI, which can give rise to systolic anterior motion defect. So all these things we can diagnose with the help of intraoperative T. So T is not a luxury in neuroanesthesia practice. It is now more and more becoming a necessity. So that's the message I want to give. Thank you again. And I'm quite honored to present this in front of my mentor and teacher, Dr. Dr. Professor Manikandan, who also happens to be my head of department at Sri Chitra Institute. Thank you.
Thank you, Dr. Rishi, for the lovely presentation. Since the questionnaire will be taken at the end of the session, I will like Dr. Manikandan to take over the responsibility of introducing the next speaker.
Thank you, Dr. Jayanta. It is one of my fascinating topic of current recent year. Like as you must be seeing, a lot of interest has been shown on frailty. I always wonder, we get a lot of patients who are very frail, who come for repeated surgery following malignancies, following stroke and various conditions. When I looked at the dictionary, I was looking at what is meant by actual frailty. Frailty means you feel brittle or weak. And if you go to actual definition of frailty, means you are quite weak, you are not able to perform your daily activities. See, most of the neurological ill patients, because of the condition itself, they are not able to move because of paralysis and various other reasons. So how do you actually differentiate your frailty in a patient otherwise was well preserved or not? Again, I always wondering what this kind of, when you are going to a PAC, pre-anesthetic assessment, what kind of grade you have to put, ASA grade, whether is there any separate conditions for these kind of patients. So we have a lot of issues which we face in and out daily, but we generally not aware of most of the things, how to manage these kind of patients. To give a more insight into how to manage frailty in neurosurgical patients, I would like to welcome Dr. Rajesh Srinivasaya. He is a faculty in consultant neuroanesthesia and perioperative medicine at Walton Center in Liverpool, UK. His clinical interests include functional neurosurgery, clinical outcomes in elderly, and quality improvement. He was also a PI for Arctic 1 study. Over to you, Dr. Rajesh.
Hello, greetings from Liverpool. Today I'm going to talk about importance of frailty in neurosurgical patients. First of all, I would like to thank organizers for giving me an opportunity to speak in this conference, and also to share our experience of implementing frailty management in our hospital. So in this talk, I'll be talking about background and introduction of frailty and importance of frailty in neurosurgery, and how we can assess the frailty, and what we can do if we diagnose frailty, and our experience of implementing the program. And I'll be concluding at the end of the talk. Old age is often associated with frailty, but not always. You have a 100-year-old marathon runner or a 90-year-old yoga instructor. They are not frail. They are very fit people. There are many definitions of frailty available, and I have chosen a WHO definition, which states frailty is a progressive age-related decline in physiological systems that results in decreased reserves of intrinsic capacity, which confers extreme vulnerability to stressors and increases the risk of adverse health outcomes. Features common to most definitions of frailty include reduced muscle strength, unintentional weight loss, tiredness or fatigue, low physical activity, and slow walking. As the result of all this, frailty results in increased mortality, decline in functional status, increased falls, hospitalization, and admission to long-term care facilities like nursing home and care homes. Coming to the prevalence of frailty, the worldwide population aged 65 years and over is predicted to reach more than 1.5 billion by 2050. In a study published from America, the prevalence of frailty in the community was found to be 1 in 25 in the age group of 65 to 69. And as the age progresses, it increases. And 1 in 4 people aged above 85 were found to be frail. What's the frailty scenario in India? It's important to note that population aging occurs at different rates in varying geographic regions of the world. In the Indian context, people who are aged 60 and above were considered as elderly. And it was nearly 14 crores in 2021 and expected to reach 20 crore by 2031. That's nearly a 40% increase in a decade. According to the World Bank data, the current life expectancy in India is close to 70 years. And as a result of this, we're going to get more and more elderly patients coming to neurosurgery. The various studies from India have reported the prevalence of frailty ranging from 11 to 58%, and they have used various different frailty measurement tools, and there was no standardization. Coming to the importance of frailty in neurosurgery, elderly patients presenting for neurosurgery have multiple coexisting chronic diseases with associated disabilities, as well as reduced physiological and neurological results. Prevalence of degenerative spine disease increases with old age. These patients may come for complex spine surgeries. The chronic subdural hematoma is largely a disease of the elderly with a rising incidence due to an aging population prone to trips and falls and high rates of anticoagulant usage due to their cardiovascular diseases. Looking at the evidence of literature, what's the effect of frailty in traumatic brain injury patients? The authors looked at more than 2,300 patients with the TBI, and they divided into non-frail and frail group of patients. And frailty was measured by modified frailty index. What they found was frailty was associated with increased rate of discharge to unfavorable locations and increased odds of postoperative complications like acute kidney injury and other unplanned events. And Agarwal and his colleagues looked at the impact of frailty on outcomes in spinal surgery patients. It was a prospective study conducted over a period of 2 years in 668 patients. And they measured the frailty by risk analysis index. And what they found out was mortality rate was 4 times higher in the frailty group than the non-frail group. And there was an increase in length of stay in the hospital, and readmission rate at 90 days was higher as well. Sharistani and his colleagues looked at the role of frailty in patients undergoing craniotomy for primary brain tumors. It was a retrospective cohort study with a propensity-matched frail and non-frail patients conducted over 8 years period, and more than 6,000 patients in each group. What they found out was frail geriatric patients undergoing intracranial neurosurgery had increased odds of developing postoperative complications like anemia, acute infection, acute kidney injury, postoperative cerebral infarction, increased length of hospital stay, and death. So this is a paper published from India in patients undergoing surgery for glioblastoma. The authors found that the complication rates between frail and non-frail patients was 4 times more, and they also found the in-hospital mortality between the frail patients and non-frail patients was quite significant. If you look at the non-frail patients, the mortality rate, in-hospital mortality rate was 1.3% compared to 18.2% in frail patients. So what's the role of anesthesiologist in management of frailty? It's important to recognize frailty in preoperative period, as frailty is a modifiable risk factor. Anesthesiologists as a perioperative physicians are well placed to coordinate a multidisciplinary team to modify frailty, right from screening for frailty to overseeing interventions for frailty and assessing its impact prior to the surgery. So what screening tools are available to measure the frailty? The most important models are known as phenotype model and cumulative deficit model. However, they were subjective and it was difficult to measure. As a result of that, clinical frailty scale was developed from Rockwood model and Edmonton frailty scale, and nowadays modified frailty index scale is becoming more popular. Clinical frailty scale was introduced as a way to summarize the overall level of fitness of frailty of an older adult, which was modified from Rockwood Frailty Index. It is simple to use. It's got a scale of 1 to 9, 1 being a fit patient to 9 being a terminally ill patient. It's widely used in NHS practice with suggested actions for different levels of frailty. And in 2020, there was a further revision of the original scale, but it's only minor changes. So this is the example of the clinical frailty scale used in the NHS practice. And on the left side, there is a frailty scale. On the right side, it's the actions that we need to take for different frailty groups. So 1 being a very fit patient, 2, 6 being a moderately frail patient. It's very important to know it's the patients who falls between clinical frailty scale of 4 to 7. The interventions are very critical. That will help in improving the outcomes in these group of patients. And this is the second page of the same clinical frailty scale. And it shows severely frail patients, very severely frail and terminally ill in number 9. So the last 3 groups, the mortality and morbidity are higher. And as a result, we have to ensure the surgeons don't do extravagant surgeries for them. So this is the latest version of a clinical frailty scale. There's only very few changes in the terminology. Otherwise, the content remains the same. Modified frailty index was developed by Velenovich and his groups, and they analyzed the elective surgical population using the NESQIP dataset. And they collected data from about nearly 1 million patients in all surgical specialties, including neurosurgery. And they identified the overlapping data set between CSHA and NESQIP, and they found 11 data points which were important, and they called it as a modified frailty index. A score of 0 means no frailty, and a score of 11 is maximum frailty. And what they found was there was a stepwise increase in morbidity and mortality as the frailty index increased. Another important highlight from this study was frailty is not confined to older individuals, and perhaps with an increasingly inactive population, frailty may even become more prevalent in the younger age group. So these are the 11 factors that they identified for modified frailty index. I'm sure these can be found in not only in the older age group, we can also see this in middle-aged patient group. History of diabetes mellitus, COPD, congestive heart failure, myocardial infarction, history of percutaneous coronary intervention, hypertension, peripheral vascular disease, impaired sensorium, TIA, or CVA, a cerebrovascular accident with deficit and non-independent functional status. So what they found was, as the frailty increases, the mortality rate increased. And similarly, the morbidity rate also increased with the raised frailty index. So this slide shows the role of frailty in recovery from surgery. As you can see, the red line, a more fit patient, when they have surgery, they recover their functional ability soon after the surgery. If you look at the example B in the gray line, after undergoing surgery, patient takes a little bit more time to recover from surgery. And while recovering, they had a secondary insult in the form of chest infection, which actually results in them being more dependent, and they take more time to recover from the surgery, and they don't reach the baseline level. And in the third example, the more frail patient in blue line, having the same surgery, will recover and takes long time for recovery and may not reach the baseline level. Our experience of managing frailty, it's still in a work in progress. We started managing frailty in 2017 when we signed up to perioperative quality improvement program run by Royal College of Anesthetists. So frailty was identified as one of the 5 components of PICWIP. We used a clinical frailty scale for screening frailty and followed the action card that comes with it. Last year, we started using a commercial pre-op software called MyPreop, which actually quantifies frailty, and our specialist pre-op nurses go through the questionnaire and then they follow the action card. The Center of Perioperative Care was published frailty pathway in December 2021. So this was a recommendation from the Royal College of Anesthetists, and we are actually in the process of changing our current pathway. So what interventions we do for frailty in our hospital? So we do clinical assessment of patients' comorbidities, and we optimize their medical conditions wherever possible. And we also review the polypharmacy and rationalize the medication that they are on. We also screen for serum albumin for all the patients above 65 years. And if it's on lower side, then we refer them to dietitian, and they do nutritional status assessment and give supplements where if it is necessary. And old age is often associated with anemia because of the chronic illness, and we do screen for anemia and correct anemia if there is any correctable factors. We also offer lifestyle modification advice regarding exercise and also smoking cessation and alcohol intake. So I have put exercise training and physiotherapy in asterisks because it's still a work in progress. We're not offering this to all the patients, but we aspire to offer this service to all the patients. Old age is often associated with depression and loneliness, and mental health assessment is a very important aspect of managing frailty. We also do pre-op risk assessment, and we use American College of Surgeons risk calculator to tell the patients about mortality and morbidity associated with a particular surgery. And also we take this opportunity to do care planning and document if the patients have any advanced directive regarding their postoperative care and DNA CPR. Drug therapy, at the moment, we are not offering this service. There is an evidence available that anabolic steroids and growth hormones and other treatment can modify frailty. because we don't have a geriatrician in our team, it's very difficult to monitor the progress. So once we have a geriatrician, we would like to offer this service as well. So this is the frailty pathway published by Center of Perioperative Care, which is part of Royal College of Anesthetists. It was published in December 2021. And it includes all the factors that we are already modifying, but in a more streamlined way. And one thing that we are taking into consideration here is emergency patients. So it starts from right from when the decision was made to operate on the patient and discharge into the community. So this is I would like to give an example of how we managed a patient in the initial days of our frailty management. There was this 78-year-old lady who was admitted with a fractured metalwork from her previous spinal deformity correction surgery. She had a post-medical history of Parkinson's disease, history of repeated falls and hallucinations, hypertension, and weight loss since undergoing spinal deformity correction surgery, and iron deficiency anemia. So we had a multidisciplinary approach, and we corrected all the modifiable things, and she underwent surgery successfully, and she's still alive after 2 years. So what about the future care model? So in 2020, Journal of Neurosurgery, in the editorial, the authors actually looked at the unfolding of new subspecialty, that's the geriatric neurosurgery, where they looked at the current model on the top and proposed new model in the bottom, where there is going to be a multidisciplinary involvement and the involvement of a geriatrician and a nurse practitioner right from the beginning to modify the risk factors of frailty, and then which continues straight into the postoperative period and discharge into community. The benefits of frailty intervention are it reduces further progression, reduces dependence, and improves quality of life, and reduces costs. To conclude, frailty is not confined to older age groups. It can be present in inactive younger age group. Frailty is an independent predictor of adverse surgical outcome in neurosurgical patients. We should try to identify risk factors at preoperative assessment and optimize modifiable risk factors, which will improve the outcomes in frail neurosurgical patients. Optimal care of a frail patient requires a multidisciplinary approach before, during, and after the surgical procedure. Thank you for your kind attention. I'd like to thank my colleagues, Dr. Bamber and Dr. Mahajan.
Thank you. Thank you, Dr. Rajesh. Can you hear me?
Oh, yes, I can hear you. Thank you. Thank you, ma'am.
Thank you, Dr. Rajesh. I think this topic is so interesting. You know, none of us, we look at the patient and we feel this patient is not that good, but we don't actually, give the label of frail. Now, I want to ask you a question. How sensitive and accepting are surgeons about frail? Because in our setup, hemoglobin is okay, creatinine is okay, 2D echo is good. Why do you say that this patient is not going to do well,
Yeah, because
sensitivity, yeah.
I mean, our surgeon actually, most of our surgeons actually buy into this concept of frailty. In fact, we were fortunate that, they are very supportive in our, mission to implement this frailty management program. Because we have done some educational sessions, and we have actually showed them what's the literature evidence. And as a result of that, they have bought this, and it's easy for us once we involve the surgeons in the decision making.
Yeah, it's easy for you, but in a private setup it becomes difficult.
I agree. I agree.
Why should you discourage me from operating upon this patient? So we as anesthetists need to become more and more scientific about it, like you said, show them evidence-based literature and sensitize them. Finally, finally nobody likes to have a long recovery and possible mortality at the end of the surgery. So
yes, and the other. That's right. And the other thing is also because to implement this program, it needs some financial input, and we have to show them there is a return on investment, and we can reduce the mortality and also reduce the length of hospital stay, and then even our managers buys into this program, and it becomes easy for us.
Right. That's true. That's a wonderful topic. I think
all those three speakers gave a very excellent presentation. There are a few questions in the chat box. I would also like to ask Dr. Priyanka. Dr. Anil Parak has asked, what is your view about the use of desflurane during epilepsy surgery as the patient wake up early? Second question he has asked is, do you use BIS in all cases to know the depth of anesthesia while doing ECOG, and if how do you determine about the depth during that time? Would you like to take Dr. Priyanka?
Yes, sir. So first of all, I would like to thank the organizers for giving me this opportunity to speak at such a big forum. And regarding the question from Dr. Anil, the use of desflurane is definitely very advantageous. And as we know that both isoflurane and desflurane do not impact the electrocorticographic recordings, and it has minimal effect on the ECOG readings. So it can be very well used depending upon the availability. It can be used, and obviously it has a good recovery profile. So desflurane has a good role in epilepsy surgery because of its limited effects on the electrocorticographic recordings. And regarding the use of BIS, sir, we most often try to use BIS in all our cases in epilepsy surgery because it helps us to look at the depth of anesthesia and then to wean the anesthetic agent and then to reach a level where we can curtail the awareness and at the same time have minimal effects on ECOG. So we try to use BIS in all the patients. In case BIS is not available, then in that case, if inhalation agents are being used, then end-tidal anesthetic concentration of the agent can be used to monitor the depth. But yes, it will not be precise because the effect of other adjuvants that are being used like opioids and the dexmedetomidine or any other agent, or in case if propofol infusion is being used, then we might not be able to actually see precisely the depth of anesthesia.
Yeah, regarding your presentation, see, we actually in our center, we don't actually give something to give a pharmacostimulation routinely. So what we do, we use, we have also done a study long back. We put BIS and we found that if the BIS is around 40, then the number of spikes as well as the amplitude of the spikes is very low. Whereas if you keep, so generally our neurologist requests us to stop the anesthesia during ECOG recording. What we found that we compared the BIS between different BIS and the ECOG amplitude as well as the frequency. We noted that if you keep a BIS of around 70, so that is as very good. They get very good recording. They are all very happy. We don't need to give any pharmacostimulation related to that. At the same time, we are not bothered that BP will shoot up or a patient will become aware or awake like that. So you give around 70 is the target we generally keep during ECOG recording. In other times we keep around 50. So that's how BIS commonly we use. Second important thing I would advise is we don't stimulate any drugs which reduces the threshold of seizures or procedures like hyperventilation. Many times when you, in the children, when you use single breath technique of sevoflurane, you give around 7%, 6%. At the time of induction, they throw a lot of seizures and there is a risk of aspiration. So we generally will be very careful not to reduce the seizure threshold in these epilepsy. They are already refractory epilepsy patients. It is very difficult to control once the seizure forms. So that is one of the very important practical points you take home. And second thing is these are all very close to hypothalamus and limbic system. Cardiovascular ECG arrhythmias, bradycardia is quite common, including asystole. These are some of the practical points which you have to take home for that. That's a question for you, Dr. Ajay.
Yes, sir.
So this is which is the youngest patient you can use the TEE. I would also ask you to comment on about the use in different position, lateral position and prone. Sometimes we do for a pituitary case also TEE we have used. Can you give your experience on that?
Yes, sir. So the youngest, it's basically based on the probe size. So the adult probe can be used for any patient north of 25 kilograms. And we use the pediatric probe for any patients who are between 5 and 25. And there's a neonatal probe, which is used by my cardiac anesthesia colleagues in our institute, which is for less than 5 kilograms. It's even in syndromic children like meningomyelocele patients coming in for surgery with syndromic cardiac comorbidities. It's quite useful when we have a TE probe to pick up any cardiac anomalies. Yes, like we have used in lateral position park bench, especially in patients coming in for CP angle surgeries like vestibular schwannomas and also CP angle meningiomas. Prone position a few times, I think Sir has used in a couple of very complicated patients who came for, like, I think it was a cerebellar abscess who came for with congenital heart disease, who came in for decompression and abscess evacuation. So it's but the conventional knobology changes with the position. We do need to compensate for the conventional degree of angulation as well as the rotation when we are using a T probe. So it's always better to start using with the supine patient and then get the understanding of the 3D model of the heart so that it's easy for us to manipulate the probe in different positions. But yes, it can be used in all the positions, and it's very important that we inform the surgical team to use a L board or this one so that we have access to the oral cavity. Otherwise, if they keep the conventional Mayo stand over the patient, it's quite difficult to manipulate in such scenarios.
I think I did not find any other questions to other speakers. Can we wind up, Dr. Sujata and Dr. Indranil? Thank you, speakers, for all. Dr. Jayanta.
Thank you, everyone. Thank you, Chairperson.
Unmute yourself.
I thank all the chairpersons and all the speakers for this wonderful session. And with the end of this session, we now proceed to lunch, which we will be having all alone by ourselves till the situation improves and we can have physical meetings. And see you again at 2 o'clock for the PG symposium. Thank you.
Thank you. Thank you very much.
Thank you for the opportunity. Thank you so much, Dr. Indranil. Madam, everybody. Thank you.
Thank you, sir.
Good afternoon, everybody. And now we are about to start our PG symposium, our much awaited PG symposium. And this symposium will be chaired by 3 wonderful chairpersons, Dr. Priyanka Khurana, Dr. Joseph Monteiro, and Dr. Sonia Biswas. Next slide. Dr. Priyanka Khurana is already very known to us. She is the Associate Professor, Neuroanesthesia Unit, Department of Anesthesiology and Intensive Care, G.B. Pant Institute of Postgraduate Medical Education and Research, New Delhi. And her special interests are in neuromonitoring, epilepsy surgery, neurocritical care, and management of SAH. Next. Dr. Joseph Nascimento Monteiro, as you all know, is the consultant neuroanesthesiologist and the program director of DRNB Anesthesia and Critical Care Program, Scientific Research Committee member of PD Hinduja Hospital and Medical Research Center, Mumbai, India. He has received several awards and scholarships: Jane Tata Endowment Scholar, Hinduja Cambridge Trust Scholarship, Hinduja Foundation in UK, Jamshedji Tata Gift Scholarship, Cambridge Society Bombay Scholarship, and Ratan Tata Travel Fellowship. Next. And we have with us Dr. Sonia Biswas, who is a junior consultant of Institute of Neurosciences, Kolkata. She is graduated from Mumbai and her MD anesthesia is from KGMU, Lucknow. And she did her DM neuroanesthesia from Sri Chitra, Trivandrum. She is a postdoctoral fellowship of Hebrew University of Jerusalem, Israel. And we have with us the speakers now, Dr. Chaitanya Kutum. I would request Dr. Chaitanya Kutum to be introduced by our chairperson, please.
I'm glad to introduce Dr. Chainika Kutum. Dr. Chainika Kutum has done MBBS from Guwahati Medical College, Guwahati in 2014. She did her MD Anesthesiology from St. G.S. Medical College and KM Hospital, Mumbai in 2017. Thereafter, she pursued senior residency in anesthesia and critical care at HBT Medical College, Cooper Hospital, Mumbai. Dr. Chainika is currently pursuing DRNB Neuroanesthesia and Critical Care at our institute, GP Pant's Institute of Postgraduate Medical Education and Research, JIPMER, New Delhi. And her thesis topic is comparison of effects of dexmedetomidine isoflurane combination with dexmedetomidine propofol combination on ECOG in patients undergoing epilepsy surgery. So over to you, Dr. Chainika. All the best.
Hello everyone, I am Dr. Chainika Kutum, DRNB third year resident in Neuroanesthesia and Critical Care from GB Pant Institute of Postgraduate Medical Education and Research, GIPMER, New Delhi. My topic for the symposium is intraoperative electrocorticography and its anesthetic implications. My mentors are Dr. Priyanka ma'am and Dr. Pragati ma'am. Electrocorticography or ECOG is the recording of electrophysiological activity from the electrodes placed directly on the exposed surface of brain. Jasper and Penfield in 1930s were the first to do ECOG for localization of epileptogenic focus during epilepsy surgery. Good surgical outcome depends on complete resection of seizure foci without any damage to the eloquent brain. The effects of anesthetic agents on intra-op ECOG is the most important consideration for the anesthesiologist. However, limited information is available in the anesthesia literature on the effects of anesthetic drugs on ECOG. Focal epilepsy can be caused by MTS, common in adults, tumors like gangliogliomas and DNETs. Most common in children is the focal cortical dysplasia. Other causes can be vascular gliosis or encephalitis. Luder conceptual zone, that is the brain areas relevant for epilepsy surgery. The centermost part is the ictal onset zone. It is the region where seizures are initiated. Surrounding it is the epileptogenic lesion, which is the structural cause of seizure. Next is the epileptogenic zone. It is the region when resected results in abatement of seizures. Lastly is the irritative zone. It is the cortex that generates abnormal EEG discharges between seizures, also known as the interictal spikes. The neuronal activity produced in the brain is transferred as transmembrane currents, which generate potentials, which are measured in the extracellular medium. When the potentials are measured from the scalp, it is called as scalp EEG. When the potentials are measured directly from the cortex, it is known as electrocorticography, which is an invasive procedure and more accurate than scalp EEG. The types of electrodes. Firstly is the Medusa or Montreal frame, which is of historical importance. More commonly used electrodes now are the grid, strip, or depth electrodes for deeper structures, that is hippocampus and amygdala. These are the various electrodes used commonly, that is the grid, strip, and depth electrodes. The background ECOG recording represents basal cortical activity with large amplitudes. The epileptiform potentials are sharp and transient, and they stand out strikingly from the background activity. We must know that it is rare to capture a spontaneous seizure or ictal event during the ECOG recording. What we observe during intra-op ECOG is the interictal epileptiform activities, that is the IEAs, also known as interictal spikes. These are the EEG recordings obtained in the interval between the clinical seizures. They may present as spikes, polyspike, sharp waves, spikes and waves, sharp and slow wave complexes, and or any combination. Higher the amplitude of the IEAs, closer the recording site to the epileptogenic focus. So here is an ECOG recording. The first three channels show the background recording, which usually looks like this. In the fourth channel, we can see few striking spikes of high amplitude, which are the IEAs. So ECOG can be graded using the Martin grade. Here there are 5 scores. In score 4 to 5, we can usually find epileptiform abnormalities. As the score increases, we will find increased amplitude and decreased frequency. Grade 1 is considered normal, and grade 2 to 5 are considered abnormal. The main goal of ECOG is to identify regions suitable for surgical resection. Certain related procedures done are direct cortical stimulation and chronic monitoring. Advantages of ECOG. Recordings can be performed before and after each stage of resection. ECOG allows direct cortical stimulation so that eloquent areas may be spared. Limitations. The sampling time is limited. ECOG only record the IEAs. Seizures are rarely recorded. Recordings may be altered by anesthetic agents. It usually adds to the cost, personnel, equipment, and surgical time. Now, what is the status of ECOG in various surgical scenarios as per current literature available? First scenario is a temporal lobe epilepsy with MTS, that is mesial temporal sclerosis. The usefulness of intra-op ECOG in standard anteromesial resection is equivocal. However, more useful in guided tailored resections. Temporal lobe epilepsy without mesial temporal sclerosis. Intra-op ECOG may be useful to guide surgical resection or to predict which patients are more likely to be seizure-free after surgery. Next is the extratemporal epilepsy with structural lesion. Intra-op ECOG likely increases the resection of potentially epileptogenic cortex and improves seizure control. Last scenario is the extratemporal epilepsy without a structural lesion. A retrospective study of 102 pediatric patients without focal identifiable structural anomalies on imaging showed good and long-lasting seizure control after resectional surgery. However, role of acute ECOG still needs more evaluation in this area. A study done by Tripathi et al. To evaluate role of intra-op ECOG and lesional epilepsy concluded that pre and post-resection ECOG correlated very well with its severity grade and clinical outcome. The anesthetic agents are known to alter ECOG activity. Hence, awake craniotomy would be ideal. However, this regimen may not work for many patients like pediatrics, non-cooperative adults, or patients at risk of hypoventilation or difficult airway. So the role of anesthesiologist becomes very important to facilitate optimal waveform and to avoid awareness while keeping the influence of anesthetics to a minimum. Effect of anesthetics on EEG waveform. So we can see that as the depth of anesthesia increases, high frequency, low amplitude waves are gradually replaced by beta, alpha, and then theta, delta waves. So basically maintaining a stable low anesthetic depth is the most important thing to do during intra-op ECOG. Effects of anesthetic drugs on background ECOG and spontaneous IEAs, also known as spikes. Firstly, the IV anesthetic drugs. The effect on background ECOG is very similar to effect on EEG, whereas effect on the spikes, firstly, there's propofol. Propofol has variable responses at all dose ranges. It may either activate or suppress the spikes. So the conclusion or comment is that propofol can be used for induction and maintenance, preferably BIS-guided should be given, and the dose needs to be reduced to sedation range just prior to ECOG recording. Thiopental activation of spikes with bolus, but it can be used for induction. Etomidate causes activation of spikes, which may be non-specific, and it may also induce seizures. Etomidate is not used commonly in literature, is scarce. Ketamine, there is non-specific activation of IEAs, especially in the limbic structure, and usually ketamine is avoided for ECOG-guided surgeries. Dexmedetomidine has minimal effect on background interictal epileptiform discharges. There is no activation or suppression in most cases. It can be used for maintenance and it can be used throughout the recording. Regarding benzodiazepines, they cause marked reduction in IES and they sometimes cause difficulty in recording the ECOGs and is usually avoided for ECOG surgeries. Snyder et al. Studied the effects of propofol on ECOG in patients for video EEG, and they concluded that propofol is not contraindicated for patients with partial epilepsy. Another study by Bindra et al. Done in AIIMS Delhi, they found that optimal ECOG was recorded with both the use of either isoflurane or propofol. Second is the effect of inhaled drugs on the ECOG. There is burst suppression at concentration above surgical anesthesia, usually more than 1.5 MAC. Coming to individual inhaled agents, desflurane, they causes neither, there is no evidence of activation of spikes, and desflurane can be used at low MAC. Isoflurane, there is no evidence of activation of spikes. However, it may actually cause suppression of the spikes, especially when used with nitrous. However, it can be used, and both these agents should be used as BIS-guided agents. Halothane, that suppresses the spikes and usually avoided. Regarding sevoflurane, they cause dose-dependent non-specific activation of epileptiform discharges, and it is usually avoided for ECOG-guided surgeries. Enflurane causes non-specific spike activation, and also seizure is possible, especially when the patient is hypocarbic. It can be used for pharmacoactivation. Nitrous oxide at concentration of more than 50%, nitrous oxide suppresses the spikes. There is synergistic effect when used with other inhaled drugs. However, it can be used at 40 to 60% concentration. A study done by Fiol et al. To assess the effect of isoflurane on ECOG found that isoflurane concentration from 0.25 to 1.25% when combined with nitrous oxide has no significant effect on the spikes. Effect of opioids. Opioids causes no effect with either low dose bolus or continuous infusion. However, spike activation may be there with large bolus. Muscle relaxant, there is no effect on ECOG. It can be continued throughout and rather should be continued. The possible factors explaining these different responses of ECOG to different anesthetic drugs can be concomitant medications, susceptibility of the individual patient, and the different doses of the drug given. Now, a brief mention about dexmedetomidine, which is a promising adjunct for epilepsy surgery. The combination of favorable pharmacokinetic and pharmacodynamic profiles has made dexmedetomidine useful in epilepsy surgery, whether awake or GA. Multiple studies demonstrated that dexmedetomidine does not affect the IEAs. However, few studies demonstrated augmentation of spikes, which were non-deleterious. The additional advantages are hemodynamic stability, it prevents intra-op awareness, and there is smooth recovery with the use of dexmedetomidine. This study done by Oda et al., they found that dexmedetomidine did not affect the spikes when combined with sevoflurane. Another study concluded that dexmed enhances or does not alter the spikes and is useful during intra-op ECOG. Following is a study done in our institute as a part of my DRMB thesis. Here we compared the dexmed isoflurane combination with dexmedetomidine propofol combination for epilepsy surgery. In our study, we found that ECOG readings were minimally affected in both the isoflurane and propofol-based anesthesia regime. However, ECOG recordings were marginally enhanced in the isoflurane group. The time to emergence was higher in dexmed isoflurane combination. And also dexmedetomidine as anesthesia adjunct was effective in preventing intraop awareness and maintaining hemodynamic stability. Intraoperative pharmacoactivation. Pharmacoactivation may be required if there are no spontaneous IEAs. The basic principle is to selectively increase the cortical excitability, particularly of the irritative zone. Successful activation is quoted as either an increase in the frequency or increase in the spike distribution and/or both. This effectiveness of a pharmacoactivating drug is quantified by the percentage increase in activation. How well the induced area matches with the epileptogenic zone determines the specificity of a pharmacoactivating drug. Few precautions should be taken before performing iatrogenic activation because intra-op seizures may occur, so anti-epileptic drugs and sterile ice-cold saline should be available. Now the table shows various agents which can cause pharmacoactivation. L-fentanyl is the most well-studied, effective and specific agent for pharmacoactivation. It produces spike activation at wide clinical doses. Whereas regarding inhalation agents, they produces dose-dependent activation and has poor localizing value, so they are not used commonly. So now this is an ECOG reading which shows pharmacoactivation by L-fentanyl with increased spike rates seen. Now the possible complications during intra-op ECOG, there may be intra-op seizures, trauma or bleeding due to electrode malposition, infection, electrode migration. Now how to conduct anesthesia for intra-op ECOG guided epilepsy surgery? It can be done under either general anesthesia or awake craniotomy. Usually anti-epileptic drugs are taken on morning of surgery. ASA standard monitoring done with additional invasive BP monitoring. 2 wide-bore peripheral cannulas are sufficient. Firstly, general anesthesia. Under GA, we can broadly divide into 3 phases for our convenience, that is pre-ECOG, ECOG, and post-ECOG phase. During the pre-ECOG phase, avoid benzodiazepine for pre-medication or induction. Induction is done with fentanyl, propofol, or thiopentone and muscle relaxant. Maintenance is done with BIS-guided. Oxygen, air, or nitrous can be used. Propofol or isoflurane or desflurane can be used. Fentanyl infusion for anesthesia and intermediate acting muscle relaxant is given. Next is during the ECOG phase, slightly lighten the pain of anesthesia to a BIS of around 60 to 70. Reduce the dose of propofol or inhalational. Continue muscle relaxant or opioid. Can introduce dexmedetomidine as an adjunct. Pharmacoactivation might be needed in this phase. Now, after the ECOG recording, that is in the post-ECOG phase, again, we can deepen the plane of anesthesia closer and maintain BIS of around 40 to 60. Dexmedetomidine can be continued throughout the end for smooth recovery. Now, conduct of awake craniotomy. The pertinent points are that benzodiazepine should be avoided, scalp block, field block to be given, conscious sedation or an asleep-awake-asleep technique may be used with the following drugs: propofol, dexmedetomidine, opioids, and inhaled drugs for the asleep part. Avoid other drugs that cause sedation like antihistamines. Post-op considerations: delayed emergence is very common in these cases. Doses of anti-epileptic drugs should not be missed after surgery. Anti-epileptic drugs cause hepatic enzyme induction or inhibition, so the different interactions should be considered. Weaning of the anti-epileptics after resection surgery should be managed by an epileptologist or neurologist. So following is a case of right mesial temporal sclerosis. She is a 20-year-old female with history of seizures since childhood, and the frequency is 1 to 2 times per week. An MRI was done with a coronal T2 weighted image and FLAIR images. They showed right-sided volume loss and high signal in the hippocampus, that is gliosis, as seen with the arrows. Now ECOG grids with the electrodes in place is seen. This is the pre-resection ECOG with high incidence of interictal spikes. The next is the post-resection ECOG reading with diminution of the spike rate. So the take-home point is that ECOG is helpful to delineate the epileptogenic region during epilepsy surgery. Understanding of the principles of seizure localization and the effect of anesthetic drugs on ECOG are very essential for the proper use of anesthetic drugs, whether the patient is under GA or is having an awake craniotomy for surgical resection of the epileptogenic focus. Anesthetic agents have variable effect on the spikes, and the ideal anesthetic agent for epilepsy should thus be able to minimally affect the ECOG without requiring reduction in its dose. Thank you.
Thank you so much, Jainika. Thanks for an exhaustive presentation on electrocorticography and the anesthetic effects of on electrocorticography. Though preoperative evaluation is very important in epilepsy surgery, yet ECOG is a very important modality for guiding the resection, and it is the totality of resection which determines the success of epilepsy surgery. Thus, good knowledge of electrocorticography and effect of anesthetic agents is of utmost importance for the anesthesiologist, and we should be well versed with all these effects and thus pursue our anesthetic regime accordingly. I think we'll take up the questions after the session, sir.
Yes. So thank you very much for that, Dr. Kutum. And it is my pleasure to introduce the next speaker, Dr. Unmesh Bedekar. His topic is goal-directed fluid therapy in neurosurgery. Dr. Unmesh Bedekar is a first-year DRNB neuroanesthesia student in Hinduja Hospital, and he's qualified from Lokmanya Tilak Medical College and done his MD from Aurangabad. He has secured several prizes and presentations at many conferences. Ever since he has joined, he's very enthusiastic student, and he's already secured some publications in peer-reviewed index journals. So over to you, Dr. Unmesh.
The topic of my PG symposium is Goal-Directed Fluid Therapy in Neurosurgery. I am Dr. Unmesh Bedekar from PD Hinduja Hospital and Medical Research Center, Mumbai. So the goals of fluid management are maintenance of normovolemia, prevention of serum osmolarity reduction, prevent the brain damage by inadequate cerebral perfusion, and provide a good surgical environment with a good brain relaxation score. Positive fluid balance is a state of fluid overload resulting from fluid administration during resuscitation and subsequent therapies. Fluid overload is defined by a cutoff value of 10% of fluid accumulation, as this is associated with worst outcomes. The percentage of fluid accumulation can be defined by dividing the cumulative fluid balance in liters by the patient's baseline body weight and multiplying by 100%. What is goal-directed fluid therapy? GDFD is a recently emerging fluid regimen. It is a type of fluid administration that optimizes predefined targets based on directly measured hemodynamic parameters, which include stroke volume variation, systolic pressure variation, pulse pressure variation, and pleth variability index. What is liberal versus restrictive fluid therapy? There has been a gradual shift to the trend of using fluid restriction during surgery with the concept of zero balance. The temptation to keep the brain dry may lead to hypovolemia and its related complications like acute renal failure, myocardial injury, and cerebral ischemia. On the other hand, patients receiving too much fluid may develop complications associated with fluid overload, such as tissue edema, which may be responsible for prolonged mechanical ventilation and delayed wound healing. However, in the RELIEF trial, which compared restrictive fluid therapy while maintaining perioperative zero balance with liberal fluid therapy, patients in the restriction group had increased rates of surgical site infection and high rates of acute kidney injury. Fluid titration based on the measurements of advanced hemodynamic parameters such as cardiac output and dynamic predictors of fluid responsiveness have shown to be useful to improve the outcome of patients undergoing major abdominal, vascular, and orthopedic procedures. More studies in neuroanesthesia are needed. What is stroke volume variation? It is a naturally occurring phenomenon in which the arterial pulse pressure falls during inspiration and rises during expiration due to changes in intrathoracic pressure secondary to negative pressure ventilation seen in a spontaneously breathing patient. Variations over 10 mmHg have been referred to as pulsus paradoxus. The normal range of variation in spontaneously breathing patients has been reported between 5 to 10 mmHg. Reverse pulsus paradoxus is the same phenomenon with controlled mechanical ventilation, however seen in reverse. Arterial pressure rises during inspiration and falls during expiration due to changes in the intrathoracic pressure secondary to positive pressure ventilation. Other terminologies of this same thing are paradoxical pulsus, respiratory paradox, systolic pressure variation, and pulse pressure variation. Traditionally, SVV is calculated by taking the maximum and minimum values, the difference between them, upon the mean of it over a respiratory cycle. You should remember that every breath is a bolus. If respiratory variation is creating differences of systolic blood pressure such that the SPV is greater than 10 mmHg, in the right clinical context, this is suggestive that your patient is fluid responsive. But if the SPV is less than 10 mmHg, there could be other reasons causing differences in the pressures, and additional fluids are less likely to help. What are the limitations of other therapies on SVV? Mechanical ventilation. Currently, literature supports the use of SVV only on patients who are 100% mechanically controlled ventilated with tidal volumes of more than 8 ml per kg and fixed respiratory rates. Spontaneous ventilation. Currently, literature does not support the use of SVV with patients who are spontaneously breathing due to the irregular nature of rate and tidal volumes. Arrhythmias, they can dramatically affect the SVV values. Thus, the utility of SVV as a guide for volume resuscitation is greatest in the absence of arrhythmias. PEEP, increasing levels of positive and expiratory pressure may cause an increase in SVV, the effects of which may be corrected by additional volume resuscitation if warranted. Vascular tone. The effects of vasodilation therapy may increase SVV and should be considered before treatment with additional volume. This study by Liu et al. Studied the GDFD in brain surgery. It was a prospective trial in which there were two groups. Fluid maintenance was restricted to 3 ml per kg per hour of a crystallized solution. Colloid boluses were allowed only in case of hypotension associated with a low cardiac index and a high stroke volume variation. The primary outcome variable was ICU length of stay, and secondary outcomes were lactates at the end of surgery, post-operative complications, hospital length of stay, and mortality at day 30 and the costs involved. The use of high SVV target values around 18 to 20% has recently been proposed in patients undergoing liver resection to limit surgical bleeding as much as possible. Similar strategy was adopted in neurosurgical patients to minimize cerebral edema. The conclusion of this study was in the high-risk patients undergoing brain surgery, intraoperative GDFR was associated with a reduction in ICU length of stay and costs and a decrease in post-operative morbidity. This another study by Berkenstadt et al. Showed that SVV value of 9.5% was concluded as the optimal threshold for predicting a 5% increase in the stroke volume after 200 cc of colloid infusion. comparing the GDFT group managed by SVV with the control group managed fluid by the therapeutic decision of the attending anesthesiologist. The former group had less administered fluids, shorter length of ICU stay, lower ICU costs, and a lower lactate levels than the control group. This another study by Gloria et al. Studied velocity time integral versus the central venous pressure. Comparison of LVOT VTI measured by transesophageal echocardiography with central venous pressure guided therapy during aneurysm clipping patients was done. The sample size was 50. The primary outcome was intraoperative mean arterial pressure. Secondary outcomes included volume of fluid administered and several other intraoperative and postoperative variables, including neurological outcome at hospital discharge and at 30 and 90 days. There was no difference in the mean arterial pressure between the two groups. Systolic blood pressure was higher in the GDFT group at several intraoperative time points. Postoperative variables, including creatinine, duration of postoperative mechanical ventilation, length of intensive care unit and hospital stay, and incidence of acute kidney injury, pneumonitis, and vasospasm were also comparable between groups. There was no difference in neurological outcome at hospital discharge according to the modified Rankin scale and at 30 and 90 days, and the extended Glasgow outcome scale between the two groups. What are the prerequisites of a normal PPV recording? They are as follows. The patient should be in sinus rhythm. The patient should be mechanically ventilated. Patient should be under sedation without any spontaneous movements. There should be no evidence of right heart failure. There should be no significant heart valve disease. Tidal volume of 7 ml per kg according to the ideal body weight should be set on the ventilator, and the heart rate to respiratory rate ratio should be more than 3.6. This is how PPV is calculated. It is similar to how SVV is calculated, that is difference between the PP max and PP minimum upon the average of the two. This is the case done in our operation theatre, in which the prerequisite of calculating the pulse pressure variation were not met. The patient was having arrhythmias and therefore the PPV could not be recorded on the screen. As you can see, the ECG of the patient and the flat line in front of the PPV, although the trace of the arterial blood pressure is absolutely normal. This another study done by Sundaram et al. Was between CVP and the PPV. Between the CVP group, which maintained a CVP of 5 to 10 centimeter water, and the PPV group, which was maintained below 13%, in patients undergoing brain tumor surgery, the latter had better postoperative hemodynamic stability and less postoperative fluid requirements. The PPV guided group had a comparable brain relaxation scale, low serum lactate levels, more intraoperative fluids, and a higher urine output. This another method is the pleth variability index. It is a measure of changes in the perfusion index during a complete respiratory cycle and allows continuous assessment of respiratory variations in the plethysmographic waveform. PVI may reflect physiological factors such as vascular tone, circulating blood volume, and intrathoracic pressure excursions. It is useful in predicting fluid responsiveness in mechanically ventilated patients. With a threshold value of 14%, having 95% sensitivity and 81% specificity to predict fluid responsiveness. It is not reliable during pneumoperitoneum in predicting fluid responsiveness, and neither in cardiac surgical patients such as CABG, regardless of their ventilatory status. In summary, this is a useful non-invasive tool in assessing fluid responsiveness. However, caution needs to be taken when vascular tone is significantly changed. Rose's concept of fluid management is an emerging concept in neuroanesthesia and neurocritical care. It has 4 phases: resuscitation, optimization, stabilization, and evacuation. As you can see this graph on your screen, Rose's concept may be relevant in neurotrauma patients for resuscitation, especially following polytrauma. Rose's concept advocates restriction of fluids, which is consistent with the prevention of a tight brain in neurosurgery. However, it is conflicting with the aim of normovolemia and maintenance of adequate cerebral perfusion and oxygenation. Methods used to minimize intracranial interstitial water, however, may induce hypovolemia and electrolyte abnormalities and adversely affect cerebral as well as spinal cord perfusion. This is, in short, it is a busy slide, but it shows how the ROSE concept works with its 4 phases, including resuscitation, maintenance of fluid, replacement, and then de-escalation phase. These are some common myths of fluid therapy which should be known to every anesthesiologist. You should consider fluid as a drug and not merely volume which has to be given to the patient. So, just to remember and to summarize, not all septic patients are hypovolemic so that you should load them. Not all septic patients show signs of insensible losses. Not all patients who have a low preload should be given fluids. The fluids given should be monitored according to the dynamic parameters such as the PPV, SVV, which are nowadays available in most of the operation theaters. Not all surgical patients are hypovolemic, and loading them should be evidence-based based on the PPV seen on your screen. And not all the patients having edema should be treated with diuretics. These are my references. Thank you.
Thank you for that, Dr. Unmesh. And I hand over to Dr. Sonia Biswas to take it forward.
A warm good afternoon to all of you. First of all, I would take this opportunity to thank the ISNACC committee to give me a chance to participate in this prestigious conference. And now I'm pleased to introduce Dr. Upasana Naskar. She is a DNB student in Neuroanesthesia Department in Institute of Neurosciences, and she would be presenting on the effect of exposure to anesthesia on the growing and aged brain. So over to Upasana.
Good afternoon, respected senior and my dear colleagues. Good afternoon, respected senior and my dear colleagues. I am Dr. Upasana from Institute of Neurosciences, INK, and today I am going to present on the topic of effect of anesthesia on the growing and aged brain, a subject of increasing concern. I have no disclosures. Earlier, it was believed that the effect of general anesthesia was completely reversible, but current evidences suggest that exposure to commonly used anesthetic agents can induce long-term biochemical and morphological changes in the immature and aging neurons. I will be covering my presentation under 2 headings. In the first part, I will be discussing the effect of anesthesia on an immature growing brain, and on the second part, I will be covering the effects of anesthesia on the elderly brain. So let's start. Anesthesia-induced developmental neurotoxicity. The term anesthesia-induced developmental neurotoxicity is used to describe adverse neurological events occurring in pediatric patients who are exposed to general anesthesia during synaptogenesis in the brain. There have been various animal studies over the past 20 years trying to establish a connection between anesthetic agents and adverse outcomes in the developing brain. Economedo et al. In 1999 described a 15 to 40-fold increase in neuroapoptosis in multiple brain regions after exposure to ketamine in P7 postnatal day 7 neonatal rats. Chaudhury v. et al. Found that exposure of 7-day-old rats to a combination of midazolam, isoflurane, and nitrous oxide caused progressive deficit in spatial recognition tasks at 4 weeks and 4.5 months after anesthesia. It was this landmark study that sparked the interest of scientific community in AIDN. Coleman et al. And Raper and colleagues in their respective studies found that the infant rhesus macaques on exposure to volatile anesthetics exhibited motor reflex deficits and increased anxiety behavior at a later age. Based on this and similar other studies, it seems that the postnatal period is the most vulnerable age group. But to understand why this period has the maximum susceptibility, we need to look into the neurodevelopmental process and the effect of anesthesia during this period. Neurogenesis starts in the early weeks of gestation, followed by migration of the cells between 12 to 20 weeks. Neuroapoptosis or programmed cell death occurs at a high rate from 24 weeks gestation to 4 weeks after birth. Synaptogenesis, that is the process of proliferation of neuronal synapses, begins at 20 weeks of gestation and continues till 2 years of life. It is followed by pruning when some of these formed connections are lost. Synaptic plasticity continues even beyond 3 years of life and contributes to the learning and memory formation process. Another major process is myelination, which continues at a slower rate throughout childhood. Gamma aminobutyric acid and glutamate, neurotransmitter and receptor system play an important role in the neurodevelopment. Their activity is crucial in the process of synaptogenesis and pruning, which are required for neural network organization and thus neurocognitive development. In the prenatal period, GABA receptors are excitatory, and in the postnatal period only they become inhibitory. As we know, most of the commonly used anesthetic and sedative agents bind either to GABA or NMDA receptors. The GABA agonists include barbiturates, benzodiazepines, propofol, etomidate, and volatile anesthetics. The NMDA antagonists are ketamine and nitrous oxide. Binding to GABA and NMDA receptor blocks the normal neurotransmission in the GABA and glutamate systems. This results in synaptic deprivation, which leads to the activation of intrinsic neuroapoptotic cascade. Caspase-9 is released from mitochondria, which in turn increases caspase-3 production, which leads to apoptosis. Volatile anesthetics also directly trigger the inositol P3 calcium channels, which causes calcium leakage from endoplasmic reticulum. They also activate the buildup of reactive oxygen species. Excessive calcium and reactive oxygen species accumulation in mitochondria causes cytochrome C release and caspase-3 activation, which leads to apoptosis. Apoptosis is accelerated when anesthetics are applied during the prenatal period when the GABA receptor is excitatory. At a later stage of neuronal development, when the GABA receptor is inhibitory, it induces far less neurodegeneration, although the negative effects on learning and memory are still present. Long-term blockade of excitatory or activation of inhibitory neurotransmitters can cause changes in receptor expression, which might influence the excitability of the neurons and make them more susceptible to toxic substances. Anesthetics also affect the glial cells such as oligodendrocytes, which are responsible for myelination of the axon. They also reduce the production of N-nitric oxide synthesis in hippocampus, which might affect memory. Now, what are the factors contributing or increasing neurotoxicity? Late gestational and early postnatal period seems to be the most vulnerable period. Multiple and prolonged exposure to anesthetic could increase the risk, and increased risk of anesthetic dose was seen to increase the risk in the animal studies. Now, these animal studies have a few shortcomings. Metabolic factors were difficult to control or rather not taken care of. There was an interspecies difference in brain development, time of switch from excitatory to inhibitory GABA, and susceptibility to anesthetics, which was not factored in. Based on the various preclinical studies, the US FDA had issued a warning that repeated and prolonged use of anesthetic agents during surgeries or other procedure in children less than 3 years or in pregnant women in their 3rd trimester may affect the development of children's brain, and levels informing the same should be present on the drug boxes. Now let's have a look into a few important human trials. The Danish bird cohort study and the data from the Netherlands twin registry did not find any increased risk of AIDN to single exposure and or multiple exposures. But whereas the Mayo Clinic Olmsted County studies and the New York Medicaid studies reported a higher incidence of developmental and or behavioral abnormalities in children exposed to anesthesia at an early age. These are the few prospective studies which were done, important. The pediatric anesthesia neurodevelopmental assessment studies, popularly known as the PANDA trial, did not find any significant difference in neurocognitive outcomes at 8 to 15 years between exposed and unexposed sibling pairs. The exposed sibling had a single exposure to anesthesia before 36 months of age. General anesthesia or spinal trial, also known as the GAS trial, included infants less than 60 weeks of age posted for inguinal hernia surgery. They were randomly chosen to either receive awake regional or sevoflurane-based anesthesia. The study found that less than 1 hour of sevoflurane exposure did not alter the neurodevelopmental outcome at age of 2 and 5 years. The Mayo Anesthesia Safety in Kids study, or the MASS study, found that processing speed and fine motor abilities were decreased in multiply but not singly exposed children. It was a cohort study that compared IQ and neuropsychological development at 8 to 12 or 15 to 19 years in multiply versus single versus unexposed children to anesthesia at less than 3 years of age. The ongoing T-Rex or toxicity of remifentanil and dexmedetomidine, which is funded by the FDA, trial aims to determine the feasibility of an alternative anesthetic regimen for lower abdominal or extremity surgery in infants. The regimen consists of a combination of dexmedetomidine, remifentanil, and a regional nerve block such as Cordal. The results are awaited. The first UCSF human cohort study found that 28 infants less than 1 year of age exposed to volatile anesthetic for longer than 2 hours exhibited recognition memory deficits assessed between 6 to which is assessed again between 6 to 11 years. The second UCSF human trial, which is ongoing, will be comparing late versus early and prolonged versus short exposure to volatile anesthetic and assess the long-term neurocognitive outcome. In the FUMC neonatal study, 37 neonates had exposure to prenatal regional anesthesia, and then they underwent MRI brain without sedation. It was found that they had larger volumes in bilateral frontal and occipital lobes as compared to unexposed ones. Now, whether these changes correlate with neurocognitive deficits in the later age is not known. In a prospectively assessed neurodevelopmental outcome studies of anesthetic neurotoxicity in children, a systemic review and meta-analysis revealed increased parental complaint in behavior of children who are exposed to anesthesia at an early age, but no difference in IQ score was found in them. FDA, in collaboration with International Anesthesia Research Society, has started a task force named Smart Tots. Its aim is to coordinate and fund research to determine whether anesthetic drugs have detrimental effects on the developing brain. A similar initiative in Europe, Eurostar, is present. Since the exposure to anesthesia in infants is quite prevalent, are there any agents which might prevent AIDN? Few agents have been found to be neuroprotective in animal studies. Erythropoietin, nicotinamide, vitamin D3, vitamin C, melatonin, dexmedetomidine, lithium chloride. A special mention to dexmedetomidine. It activates the alpha-2 adrenergic receptor, which in turn decreases sympathetic activity and inhibits inflammation. It also activates the protective signaling molecules. So it does not. So it might not have any adverse effect on the neurons as it does not act via GABA or NMDA receptors. Rather, it might have a neuroprotective effect, as it has been shown in various animal studies. Based on the available information, the American College of Obstetrician and Gynecology is of the opinion that none of the anesthetic agents in current use has displayed any teratogenic effects at any gestational age, as long as standard doses and concentration are used. Medically necessary surgery should not be denied or delayed, regardless of trimester. Maternal cardiopulmonary physiology should be optimized. Premature onset of labor is to be watched for, and administration of steroids for fetal benefit is to be considered. No reliable data on neurodevelopmental effects after prolonged exposure are available. So to conclude, AIDN is still one of the most pressing questions at present in pediatric anesthesia today, especially with increasing number of fetal interventions. Special research emphasis should be given to patients undergoing prolonged procedure and in those with known neurodevelopmental anomaly. So now moving on to the second part of my talk, anesthetic effects on the aged brain. As Barbara Cartland had once said, don't have a general anesthetic once you are 50, it will wipe out a quarter of your brain. Cognitive disturbance is commonly observed in elderly patients following surgery and general anesthesia and is predictive of short and long-term outcomes. Cognitive disorders include postoperative delirium and postoperative cognitive dysfunction. Incidence of POD is 10 to 45% and that of POCD is 26%. Recently, the perioperative cognition nomenclature working group recommended that the term perioperative neurocognitive disorders should compromise the whole spectrum of cognitive impairment identified in the preoperative or the postoperative period. This includes any cognitive decline diagnosed before operation will be known as neurocognitive disorder. Any form of acute event postoperatively will be termed postoperative delirium. Cognitive decline diagnosed up to 30 days after the procedure will be known as delayed neurocognitive recovery. Any cognitive decline up to 12 months will be termed as postoperative neurocognitive disorder. POD, it is acute in onset. It can cause altered consciousness and disturbance in circadian rhythm. It can be hypoactive, hyperactive, or mixed. The known risk factors are type of surgery, advanced age, pre-existing medical conditions, pre-morbid CNS co-medications, environmental disturbances, substance withdrawal, and inadequate analgesia. It is defined using the ICD-10 and DSM-5 criteria and assessed using the confusion assessment method. POCD. It is the syndrome of prolonged impairment of cognitive function after surgery with limitations in memory, intellectual ability, and executive function that usually last for weeks or months. No single test can adequately measure cognitive function. Instead, a battery of neuropsychological tests are required. In the first international study of postoperative cognitive dysfunction, the diagnosis of POCD is made in the postoperative. It defined the diagnosis of POCD is made in the postoperative period when deficits are noted in one or more areas of the mental state, including attention, executive function, memory, concentration, psychomotor speed, and visuospatial ability. In this study, in non-cardiac patients more than 59 years old, the incidence of cognitive dysfunction 1 week after surgery was 22% higher than in age-matched controls, and it was 7% higher 3 months after surgery. Now we know that surgery and metabolic factors have been proposed to be contributing factors to POCD, but can anesthetics themselves cause cognitive dysfunction? There have been significant research efforts to uncover the cellular and molecular mechanism that could underline general anesthetics' potential neurotoxic effects, especially in the Alzheimer's brain. Majority of the studies shows anesthetics' ability to induce neuronal apoptosis and to potentiate Alzheimer's disease associated pathology, including defective amyloid protein pathway, tau protein hypophosphorylation, and neuroinflammation. Volatile anesthetics have been shown to induce increased cleaved caspase-3 activation, which in turn inactivates the Golgi-associated gram adaptin or the GGA3. This degrades the beta site APP cleaving enzyme known as BAS. The overall effect is stabilization of BAS and increased processing of amyloid progenitor protein and further accumulation of toxic A-beta aggregates. Volatile anesthetics, because of their small size, can also interact with critical amino acid residues and promote A-beta oligomerization. Potential role of calcium dysregulation and disrupted expression of extrasynaptic receptors by various anesthetic agents have also been postulated to contribute to neuroinflammation. Let's see if there is any evidence from the clinical studies on the incidence of POCD and anesthesia exposure. Rohan et al. Found that patients aged more than 65 years were posted for cystoscopy or hysteroscopy and received either propofol or sevoflurane anesthesia had higher incidence of POCD as compared to age-matched control subjects. Whereas Bowles et al., Sprung et al., and Kotekar et al. Did not find any association between anesthesia exposure and POCD. Is there any specific agent that is associated with increased risk of POCD? In the study by Zhang et al., use of isoflurane anesthesia with spinal block in lower abdominal or extremity surgeries was associated with significantly higher risk of POCD as compared to desflurane with spinal anesthesia or spinal anesthesia alone. The International Enigma 2 sub-study on postoperative cognitive disorder, ISEP, found that in patients undergoing non-cardiac surgery, receiving nitrous oxide had improved post-operative neurocognitive recovery compared with patients receiving air or oxygen. There was no significant difference in the number of patients with POD between the groups. The Pinocchio trial is ongoing and aims to compare the incidence of post-operative delirium between 3 hypnotic agents such as sevoflurane, desflurane, and propofol. The effect of ketamine on post-operative delirium remains unclear, but its administration may offer some neuroprotection towards POCD, as concluded in a recent meta-analysis. Thus, the depth of anesthesia matters in prevention of POCD. The cognitive dysfunction after anesthesia CODA trial of 21 elderly patients undergoing major non-cardiac surgery found that the patients with a median BIS of 53 experienced less delirium and had less POCD 3 months after surgery than control group, which maintained a BIS of 36. They concluded that maintaining a BIS of 40 to 60 for every 1,000 elderly would prevent POCD in 23 patients and delirium in 83 patients. EEG-guided anesthesia to alleviate geriatric syndrome or the ENGAGES trial did not find any significant difference in the incidence of POD between the patients receiving EEG-guided anesthesia and those receiving usual care. The 5th International Perioperative Neurotoxicity Working Group have recommended that elderly patients should be informed of the risk of postoperative delirium and perioperative neurocognitive disorder prior to their procedure. A baseline cognitive assessment should be done. And current literature is insufficient to define a specific anesthetic regimen to decrease risk of perioperative neurocognitive disorder. However, cautious use or avoidance of medications such as first-generation antihistamines, centrally acting anticholinergics, benzodiazepines, and meperidine is recommended. Avoid relative hypertension, maintain normothermia, use age-adjusted MAC, and use EEG to titrate the anesthetic delivery. Additional research is required to determine feasibility, efficacy, and cost-effectiveness of post-operative follow-up to assess cognitive outcomes. Apart from that, few targeted interventions can also be done to reduce the risk. Baseline preoperative functional status should be noted. Proper treatment and counseling of depression should be done. Adequate control of hypertension, sleep disorders, blood sugar level should be ensured. Ongoing medication should be reviewed and non-essential medication should be stopped. There should be early resumption of diet after surgery, and proper adequate control of pain should be ensured. Family and social support system should be available if required. So our take-home message from this is transient or profound disturbance of physiological parameters should be avoided in elderly. A balanced anesthetic technique should be devised. Clear indications for surgical or non-surgical procedures under anesthesia should be present. Try to limit the anesthesia duration. Minimize anesthetic depth and consider regional anesthesia with light or no sedation in elderly. These are my references. Thank you.
Thank you, Upasana, for the exhaustive presentation. And as we can see, as she has already emphasized, that long-term modulation of neurocognition in both extremes of age is still a pressing question, and evidence from animal studies has still not been corroborated significantly by human trials, and further research is still required. Meanwhile, we as an anesthetist should make sure that we should have clear indication for surgery, avoid deeper levels of anesthesia, and ensure adequate analgesia and control of physiological factors, and earlier resumption of normal activities after surgery. Thank you.
Thank you very much. And the session is now open to any discussions, and any questions can be taken up right now.
There are no questions yet in the chat box, but let me take this opportunity to congratulate all the three speakers for speaking very well. And I also thank the organizers for providing this platform for the PG students to present at a national level conference. Is a great initiative indeed. Any questions?
Yeah, Dr. Joseph.
Yeah, Dr. Parak has a question. Yes, Parak.
Yeah. Hi, Upasana. That's a very nice presentation. I just wanted to know, because there are a lot of can you hear me now?
Yes.
Yeah. There are a lot of literature which says the incidences of POD are same in general as well as the regional anesthesia. What is your comments about that?
So, as in a trial, recent trial known as the RAGA randomized trial, they compared the regional anesthesia and general anesthesia. They did not find in any difference between the incidence of POD according to the type of anesthesia.
That's right, I'm telling. Yeah. So why are you saying that's you should do more of regional? That's some.
Because the sedatives and volatile anesthetics that have been used in general anesthesia might cause post-operative dysfunction. So it is better to avoid. That's what I meant.
So Parak, I feel the important point here, what she has made in a slide, is that you have to maintain the physiological parameters. So if you're given regional anesthesia, so you must avoid hypotension or hypoxia, maintain the physiology. That is more important, because even if you give a regional anesthesia, But while giving a regional anesthesia, you're normally giving it to a high-risk patient. And if you have some disturbances in the physiology, then the incidence of POD will be there. So it doesn't matter whether you're giving general or regional, the risk is same, but the point is you should maintain the physiology. I also feel it's a very important step that we should now try to make depth of anesthesia monitoring a part of our routine monitors. It should not be available and preferable. So that way also you'll be able to judge how deep an anesthesia you tend to give. Correct. So I think I don't know how many people are routinely using depth of anesthesia monitors, but it is a good way forward. So we'll know a little objectively, at least with some number, how deep your anesthesia is. Because many studies have shown that too deep an anesthesia, which may lead to physiological disturbances, may cause POD. Right.
Especially in high-risk population, it is more important to use depth of anesthesia monitor. It may not be feasible to use it in all patients, but in all those patients who are at high risk, we should attempt to use depth of anesthesia monitor. That's very important. In fact, sir, I have a question for Dr. Unmesh. Dr. Unmesh, can you suggest the role of IVC collapsibility or IVC distensibility as a goal-directed measurement for fluid responsiveness? And have you used it? And because I could not find it in your presentation. So just wanted to know whether there is any evidence of use in neurosurgical population, especially of this.
Generally, USG directed IVC diameter collapsibility index is used in the ICU settings perioperatively. Intraoperatively, during a neurosurgery, it is cumbersome to get a USG and do it intraoperatively. So
I think it is easier to get it than a transesophageal echocardiography guided LVOT VTI, which is like little more cumbersome. It requires TE and insertion of a TE probe. So getting an ultrasound and doing it at the abdominal level, because we've been trying to do it and it is quite feasible, because in neurosurgical patients, the head and neck area is used by the surgeon. So the abdominal part is quite free. And you can definitely put in your hand there and use it. This parameter can be used to look for the fluid responsiveness.
Yeah, there are many ways to go forward. I think the point by Dr. Priyanka is very good. And today we heard Dr. Ajay Rishi also speaking of TE. So that is also another way which you can go forward. But Unmesh is incidentally doing his thesis on PPV. So probably that's why he has focused.
I agree, totally agree with Unmesh that PPV and stroke volume variations are more commonly used parameters. And because of the lung-heart relationship, we do get quite an accurate readings, and fluid responsiveness can be checked through those parameters. But I feel IVC can also be used in neurosurgical patients, especially because the IVC is available for you in this population.
Are there any more questions or comments?
Yeah, I just want to comment, because the new invention is Edward has come with the hypotensive index with the HI, which is based on their artificial intelligence, and it gives. I had done 3 cases. They have selected a global hospital as a role, just to experimental 3 cases I had done, so that if depending on the data like the PPV, SPV, and the cardiac output, it predicts the hypotensive probability. So if suppose your blood pressure target is like 65, like what you say, there are 70 mean arterial pressure. So that is 100% okay. When the this mean pressure goes down, it predicts what is the percentage of hypotension. So you can act before, when you get these data, you can act before it actually happens. So I had done 5 cases with this and 5 cases with routine cardiac output monitor, and I found this is better than your routine cardiac output monitor. So it gives a lot of data, but even I am learning on these. I had done only 2 or 3 cases, but that's a really good thing. You can predict the hypertension. What is the probability of getting hypertension in this patient? And like I just give one example. One patient has a severe bradyarrhythmia. So and the hypertensive index was around 80% when the brady, and the pressure has fallen down because of the heart rate. As soon as I gave atropine, it came to like heart rate picked up, cardiac output picked up, and the index has come to the normal. So there are certain things which we are learning. What we can start, we can predict what we should start, and we can do that.
Absolutely, sir. I agree with you. Recently, in fact, we also encountered one case where we were using LVOT VTI as the parameter for giving fluid response for checking for the fluid responsiveness. And during the procedure, we found that the VTI was higher. That means it was more than 15 throughout, 18, 20. That means the patient was not fluid responsive. But at the same time, we found that the PPV was also high. So that which meant that the patient was fluid responsive. There were two contradictory parameters which were going parallel. So just to check which one is better, we tried to give fluid, and when we gave fluid, we found that the tachycardia did not settle down, and though PPV came down, but the tachycardia did not settle down, and other parameters were at the same level. So what we think is that it's not just one thing that you can look into, it has to be multimodality. So goal directed just doesn't mean that only one goal, it has to be like, so that is why I think that is what you are trying to say, that artificial intelligence has a role in
So
that.
this is HPI, that is
looks into all the parameters.
So this is HPI, hypotensive prediction index. So that will predict what is the incidences of hypertension in this patient. So you can come across early intervention, you can do and prevent that. Like particularly neurosurgery, where you know a lot of literature as everybody knows that a single episode of hypertension has a poor outcome for like head injury or anything like. So I think
Thanks for that, Anil. But there's a question from Dr. Monica Tandon to Unmesh. What is the role of PPV and stroke volume in low cardiac output states? Unmesh?
So there are various prerequisites which have to be fulfilled before you take the PPV value as a correct value. So in those, there should be no heart valve lesions, there should be no arrhythmia. So patients with low cardiac output states or fixed valve lesions may not give you a accurate PPV. So other methods have to be used to guide your fluids.
Dr. Monica, I hope that answers your question.
That was my basic this thing, that is when you need these indices the most.
Yes.
You need them in low cardiac output states. And if they are not useful at that point of time, then they probably don't serve the purpose.
So probably in that case, I think we have to look forward to either using a TEE or we have to move on to something different. This only helps you to objectify and give you some working number. But as Dr. Priyanka has said, we'll have to move to multimodality. At least now we are trying to objectively assess how we are giving our fluids rather than just going by the mean arterial pressure. And in the previous days, we used to go with CVP in some cases. Are there any more questions?
Yeah, Dr. Monica, I agree with you. When you require these data, it doesn't give the perfect answer. Like a lot of propagation about the non-invasive cardiac output monitor. It's like a pulse oximeter. You just attach that and see. But when there is a hypotension and the cardiac output, it really doesn't detect. So when it is not detecting, we don't know what exactly, but you know it is low. That's all. The same like NIBP, where many times when the blood pressure is unable to record. So that is the time when you require and unable to record. So that's all things are something which technical problems.
Yeah, absolutely.
Thank you very much. Thank you, Joseph, and Dr. Priyanka, Dr. Sonia, Upasana, Umesh, and Dr. Sujata, and Chandranika. Thank you.
If there are no more comments, I'll hand over to the organizers. Thank you very much.
Unmute, please. Unmute, madam. Dr. Sujata, unmute, please.
Ma'am, you are still muted.
Madam, you are muted. Yes.
It was a wonderful session, and I deeply thank all the chairpersons and all the lovely speakers. They are our young ones and about to carry the torch further ahead. Thank you so much. And with the end of this session, we will soon move on to our valedictory session at 3:15. Thank you so much.
Thank you, Dr. Thank you all.
Thank you, ma'am.
This topic said the health and neuroanesthesia, both budding neuroanesthesia and refresh the minds of the experienced neuroanesthesia. The next very important point was that it was in time. And all the 3 Ds with adequate time given for another session. I am thankful from core of my heart to the members of the ISNACC Society to give me the opportunities to serve the field of research as president, especially thank my colleagues.
Good afternoon, everybody.
Good afternoon, Indranil.
Yeah, good afternoon, madam. Good afternoon.
Good afternoon, everyone.
Good afternoon.
Bibu madam, can we start the valedictory session? I think everybody's here, so.
So we can start, yes.
Yeah. Good afternoon, everybody. So we have come to the end of the 23rd edition of the annual conference of Indian Society of Neuroanesthesiology and Critical Care. And I feel very happy that I have been able, or with the help of our organizing committee members, been able to pull it off amidst this raging pandemic outside. And I thank, first of all the chairpersons, the delegates, the postgraduate students who had joined us in making this conference a successful one. That is for you to decide. But whenever I had called the name, they had very happily agreed to join. They had taken all the trouble to make their recordings, their deliberations, and it was so difficult in the background of this raging pandemic. A lot of us, we fell ill. Fortunately, I did not get COVID so far, so I don't know. And but a lot of our central office bearers and my colleagues in my organizing committee, they fell ill not only once but twice. And a lot of them are still suffering. My friend Dr. Abhijit Raha from Bhubaneswar, Ranadhir, a lot of them are still suffering from what is known as a long COVID, the sequelae of COVID. But anyway, I think when the going gets tough, the tough gets going. So all of us managed to pull out and pull off our socks, and probably we, with the help of everybody, we could complete this conference. So first of all, I will start by announcing the winners of the competitions. Could you please show the slides? The first category was the Professor V.K. Grover Memorial Award presentation, and the winners are. Can I show the slides? The names? Yes. So the first prize goes to Dr. Gopalakrishnan K.N., the second to Dr. Pramod Kalguri, and third to Dr. Mauli Sharan S. So a big applause to all the winners. They will be, their prizes and certificates will reach them in due time. The second was the free paper category.
Dr. Indranil, can you just mention about the institutes, because they are representing certain institute? It will be good to hear about. Okay,
Since
no
we
problem.
had not given the name of the institutes when they were presenting, I don't remember exactly. But when their certificate will be at the name of the institutes, definitely. The free paper presentation.
All the three are from NIMANS.
Okay. The free paper category, the first prize went to Dr. Jiva George. The second to Dr. Prachi Sharma. Dr. Jiva George is from Chitra. Prachi Sharma is from AIMS Bhubaneswar. And Dr. Ashwani Reddy. And in the case report,
she is from PGA. Ashwini
PGA. PGS. And the outstanding case report, the judges decided to award Dr. Sindhu Priya Muthakalai. I think she is from MGM hospitals. Yeah. So a big congratulations to all the winners. So I'll just, before I hand over the mic to my organizing chairperson, Professor Bibhu Kalani Das, I would like to thank everybody, particularly our trade partners who had helped us in these difficult times. And a special thanks to the team, the Cubics team of Shangamitra Datta and Ambarish. This is a huge technological game. The virtual conference is a huge technological game, and without partners like Cubics, it's very difficult to win this game. So a very, very big thanks to them. And saying this, I hand over the microphone to Professor Bibhu Kalani Das for our words. Bibhu Madam, please.
Yes, good evening to all of you. So we are now at the end of this conference. This is not a very happy moment. It's a sad moment for us because all 3 days, though virtually, we were together. We talked, we discussed, we are seeing each other on the virtual platform. So it was very happy. These 3 days we spent very happily, but now we are leaving. So this is not a very happy moment. But anyway, I don't know whether it has been well organized or not. Any of the lapses that will go to me, and any good things will go to my organizing team. There's starting from the first, I'll again appreciate and thank the central body and this governing body and the general body for giving us this opportunity once again. And at the outset, I'll say that we are very fortunate to have Professor Agna Goswami, our beloved Didi, to guide us. She was our advisor. She was always there to guide us, to say what to do, what not to do, everything. So that is why we organize whatever it is like that. I don't find any words to say to appreciate the work of Indranil, the hard work he has done, along with his associates, ably doing as good as him. Overall, they were also having their work. They are not taken any leave. They are heading all the departments everywhere. So along with their work, they also did very hard to make this conference success. So they are, to name them, Sucharita, Jayati, then Sarbari, Sujata, and above all, Polash, the scientific secretary, because this virtual platform is only dependent, it is the success depends upon the scientific forum, so scientific program. And I believe that all of you have cherished that scientific feast, because we don't have anything to give you, and only the scientific. It was prolonged once because there is nothing, no lunch, no dinner, no sightseeing, nothing. So we have to depend on the scientific feast. And I'm very thankful to all the orators, all the speakers, the chairpersons, and our previous presidents, all senior members. They participated so well to make this event successful, as I think. So thank you all for that. Then at the end, it never ends that these cubic people, They were very supportive, and they have toiled hard to make this a success. So we are very thankful to them, and I thank them from the core of my heart, and the Sanghamitra and her team. They have done very good work. And along with that, the people at my INK, the IT consultant, Mr. Subhadeep, and the academic secretary, Mr. Sudeep, they also helped me a lot for the whole 2 years we have taken like that. And the support from the governing body, from the now the governing body also supported every time. The secretariat of ISNACC, they guided us. So I'm so thankful to all of you. And then the houses, our pharmacy people, they also very few, because of it is a virtual platform, so nobody came out with I mean, they are restricted for this virtual events. They won't subsidize this. So a few of them, they helped, and I'm very thankful to them. So thank you very much once again to be here with us. And apart from your busy schedule, you gave time to us. So thank you all. And the moderators of the sessions, most of them are my students. They are also now the head of the departments of all the hospitals. They are also with their work. They have come and they moderated the sessions. And the workshops also by the neurologists, by the neuroradiologists, the workshops were very good. And you have also appreciate those things. So thank you very much once again. I don't think I'll see this conference again in my lifetime, once again at Calcutta. So thank you so much.
May I congratulate Bibhu, Indranil, and the whole team for really doing a wonderful work. In fact, I attended the lectures and presentation more than a physical meet. And your programs were excellent. The speakers were very good. It could not have been better. So congratulations, you are well rewarded.
Thank you, sir. Thank you so much. Thank you so much.
Thank you very much.
Good afternoon, ma'am.
Good afternoon.
Ma'am, I must congratulate the organizers of the 23rd annual conference of ISNACC for a very successful and informative conference. It was really an academic feast, which included various fields of neuroanesthesia and neurocritical care, including neurohabilitation, rehabilitation to chronic pain management, fertility to echo and other monitoring, and all other important topics relevant to the neuroanesthesiologist. I'm sure that most of us are benefited by this conference. It is very nice for the budding neuroanesthesiologist, and it refreshes the topics for all the experienced neuroanesthesiologists. And the most important thing is it was in time. And after every session, there was you have given time for discussion, and discussion was very healthy. So it was a very nice, very successful conference. Thanks a lot.
I thank personally our president for the very smooth conduction of the session, our inaugural session. Thank you very much. Very smoothly it was conducted and very nicely. Thank you so much.
Thank you. Thank you.
So I take this opportunity to thank you, Amna Madam, Dr. Vibhu Kalyani Madam, Indranil and his team, particularly Dr. Sujata, Jayanti, and all the people, the team. I know when you organize a conference, how much team you require to conduct a successful conference. So I know it's not only the other few faces which are there, and I'm congratulate them, but more the core hardcore workers who are on the ground, but we can't thank them. But from all the participants and the faculty, I thank you all for the wonderful meeting. It was really nice, and the most important thing which I was like they had dedicated DM students, and there were a lot of activities which were pertaining to the students and the DM, which even I learned a lot of good things which from their interaction. So, and timing, scientific matter, and the international faculty, even the national, the new budding, as Dr. Nidhi has pointed out, they were very good. So that's, I think in next 5 years, our ISNACC will be very well, means it will be grown like an international level. And in last 3 years, when Dr. Punaiya and Bitkar has taken a charge of this, there are a lot of new budding neuroanesthetists come. That I must appreciate, because they have given a chance to new people. So like 5 years, a lot of senior people were telling the repetitions of the topics and everything were there. But in the last 3 years, the Punaiya and Bitkar has changed the scenario of our ISNACC. So I hope that this will continue with the further the new team which is coming, and I wish you all the best, and thank you very much from core of my heart, and congratulate you all again. Thank you very much. But I miss the physical presence. That's the last time what we had at the board dinner and everything. My wife was also saying this time I'll go to Calcutta after 10 years, but unfortunately we could not. But see you in Hyderabad.
Thank you, sir. Now I'll move on to Dr. Prasanna Bitkar, our treasurer, to say a few words.
Yeah. Thank you, Dr. Indranil. At the outset, let me take this opportunity to thank Bibu Madam and Indranil for pulling out such a successful conference. It was wonderfully organized and such a good coordination, and to see, heartening to see all of you working so much for the conference. And it was a really very well scientific feast, and I was fortunate to be on isolation for 3 days. So I could attend most of the sessions though with some discomfort, but I could attend from my home and from my room. So big congratulations to you, madam. And with the conclusion of this conference, the tenure of our secretariat ends, and me and Punaiya will be relieved, and the whole new leadership will take over for the ISNACC. So I wish all of them all the best. Unfortunately, because of the logistical issues and other things, we could not conduct the GB meeting, which I hope in near future with the new team taking over, we'll work it out to make sure. As far as the finances of the ISNACC are concerned, they are very well and they are very healthy, thanks to the generous contribution of 46 lakhs from the ISNACC 2020 organizers and another 8 lakhs from the ISNACC 2021 organizers. So both coming from Chennai. So we are into a 1 crore club. So having reached there, so our responsibility increases. The way we spend also has to improve in a nice way. So I really appreciate everybody, coordination and the cooperation of everyone in this regard, right from the senior brass to the junior most level of all the DM residents. And there may be some hiccups which might have happened because of COVID, and we were also busy with our COVID duties. There might be some communication issues to some of the members. We highly regret that, and we wish the ISNACC a great success under the new leadership group. Thank you once again.
Now we move on to our National Secretary.
We are very, very grateful to the office bearers, especially Punya and Prasanna, all the time with us, interacting with us, what to do, what not to do. And you guided us. Thank you so much. And your tenure was so successful tenure to bring this. I really agree with Anil that this now we are sumptuous with our fund.
Thank you, ma'am.
Thank you. Thank you.
Dr. Punaiya.
Just I want to say something, that the two most successful things are that Punaiya and Prasanna, with their dynamic effort and all, they have started Neurocritical Society of India.
Yes.
And ANC course. These two are waited for a long time, but their enormous efforts, they have started these two things. So big applause to them.
Thank you.
Dr. Punaiya, may I request you to say?
In spite of a lot of pressure, And Puneya and Prasanna, hearty congratulations. You have changed the track, and I hope you will be on the speedboat from now onwards.
I think Dr. Indranil is trying to cut everybody, sir. He wants the agenda to flow and at last everybody to congratulate.
No,
That
no,
is
no,
like his
no.
interview.
No, no. He is
No, no.
only doing what
We want to know, sir.
people deserve.
That's the right thing to do, madam.
That is the right thing, and what people deserve. He's doing that. He's doing
Yes.
that.
Yes. And respected President, dear Bibu Madam, Indranil, our friend and senior, and all the GC members and the newly elected GC members. I'm very thankful to everybody. So, first of all, let me congratulate the ISNACC 2022 team. Because at times I was a bit hard and firm on them when they first pulled out from doing the 2021 conference. I was the one who was saying that no, at least virtually you have to do, and then we did it in Chennai. And then unfortunately, Madam's wish of conducting a physical conference could not be met even during this year, and this has to be resorted virtually. And whenever we discussed, it was very firm and hard, and ultimately it was for a healthy outcome and a wonderful experience. That is why it is, and we enjoyed that thoroughly. And the way the conference went and the way the speakers are coming in, the new speakers, the new talents whom we are coming in, it is opening up a wide plethora for opportunity and a field where many people feel that this is the way that we have to go forward. Without we need to instill new faces and energies. And during the time we took over as secretary and treasurer, I told this, that people should raise their hands up and say that I'm here for the society. They should not shy away saying that no, he's my senior, no, he's my teacher, so I cannot come inside, how can I talk like that? This is a democratic society. You should put up your hand and say that I'm willing to work. If you have the talent, you have to write. You should not feel shy. You have to write to the secretariat saying that I have this capability and I just want to showcase this. I want to involve in this committee, and I want to involve in classroom. I want to involve in ANC. So this is how you should put your hand, and then that is why new talents will be found. There is no need for somebody to push you. You yourself can put up your hand, and definitely if you have talent, it will be recognized, and even in the future also. So congratulations once again, Madam Bibu Madam and Dr. Indranil, and it was an excellent conference. And I hope you'll also submit a very heavy check after the conference to the society. And
let's hope so.
Right. And coming to the governing council, so our term of 3 years, which was extended to 1 more year, unfortunately, due to the COVID pandemic, is coming to an end. I fondly remember the first meeting of Mumbai, where we took over as a secretary, and at that time I was so immature that I was not even aware of this valedictory function, that I need to go to the valedictory function, take over. Actually, I skipped the valedictory function on my secretariat when I just took over as a secretary. So I felt very, I didn't feel good after that. So I wrote a big letter to the members, saying how we are, what are our plans and how we want to take the society over. And from that time, if I look backward, there are so many instances where we and myself and Prasanna had a lot of discussions on how to instill new things, how to create new ventures where we can dive in. And really we should be thinking ourselves very high, and only when we aim high we can work accordingly. If we just set our targets less, then we cannot reach there. And ISNACC 2020 was one such project. We took it as a challenge. It's not a very easy task, but I would say I have passed about 70% of ISNACC 2020, even though the amount is so huge, and it's almost 20-25 times than the previous revenue. I felt that with little bit of more support, I would have gone to 100%, but it was not possible single-handedly with Prasanna sitting in Pondicherry. So that is one thing. Always we need to retrospect ourselves on what we have done. So as a secretary, to be honest with you, the first 2 years, if I say I would have done my job to 7 to 8 out of 10, and the second 2 years, I would rate only myself to 4 to 5 out of 10. Because of the COVID and the physical conferences which are not happening, there was a little bit less enthusiasm and the energy was a bit less when we compare with the previous 2 years. So that is how honestly I would like to rate me. And but whatever said and done, we always stood firmly. We never get back on what we said, and whatever we thought that this is the truth and this has to be done, we stood for it, because we believe the truth is the only authority and authority is not the truth. So having said that, Dr. Virender, it's Dr. Indranil, if you can permit, I can introduce the next office bearers. I can present that, and then following which Madam President can give their talk and the new President can take over. Yeah, okay.
Yeah, please. Go
Yeah,
ahead.
Yes,
so
yes,
just
Manu,
allow me to share my screen. Yeah.
Go ahead. Yeah.
Yeah,
Is
able to
there?
see the screen?
Yeah, able to see.
Let me go full screen also. So big thanks for the past President, Dr. H.K. Venkatesh, who will be leaving the Governing Council, and Madam Dr. Nidhi Panda, who will be finishing her President tenure, and Dr. Rajshri Madam, who will be finishing as the President-elect, and Dr. Virender, who will be completing his term as Vice President. Dr. Vijay Ramesh and Dr. Radha Krishnan, who are part of a governing council as a past secretary and treasurer, will be finishing their term and they'll be exiting the governing council. And myself and Prasanna will be signing out as treasurer and secretary. And we have served for 4 years, which is an extended 1 year after the pandemic. And I thank all the GC members who worked with me, including Dr. Ratan Chalani, Dr. Arvind, Dr. Jnanendra, Dr. Sonia, Dr. Mitra, and in the past, Dr. Arvind and Dr. Hemangani Karnik, everybody. A big thanks for everybody who has contributed from the ISNACC Executive Committee. And I thank all my committee members, the Education and Research Committee, which is chaired by Dr. Pandya and Dr. Pragati Kanju Madam, Dr. Vijay Ramesh, Dr. Ajay, Devendra Gupta, the Constitutional Committee headed by Dr. Parameshwar Rao, Dr. Vijay Ramesh and others, Financial Committee by Prasanna Bitkar, Smita Madam, Radha and Saurabh, International Relations Committee by Dr. Shobhana Rajan, Dr. Sri Ganesh, Dr. Hemant and Dr. Deepak Sharma, Legal Advice Committee by Arvind Arya, and Website and Social Media by Dr. Girija Rath, Dr. Rahul and Dr. Mitra. So the new office will be the President of 2022 will be Dr. Rajshri Diopichari from Mumbai. Congratulations, Madam, and under your leadership, I think ISNACC will achieve greater heights.
Thank you.
And Dr. Nidhi Panda will be the past President for the year 2020-22.
Thank you.
Dr. Virender Jain will be the President-elect for the year 2022. And Dr. Indranil will be the Vice President of the year 2022.
Thank you.
And Dr. Pramod Bittal, Professor Pramod Bittal will continue as the Editor-in-Chief till his term of September 2023. And under his leadership, the journal is achieving greater heights, but still there are a lot of milestones which need to be achieved with the journal. And our new secretary and treasurer will be Dr. Girija Rath and Dr. Jnanendra. And their term will be for 2022 to 2024.
Sorry, Punya,
yes, sir.
your slides are not moving. Whether you are not, you are saying and not showing the slides?
No, I'm moving only, Madam.
No, here.
We can't see.
It is only ISNACC
Only
showing there.
track. Yes.
Is that so?
Yes, slides are not moving.
Just move the page, no? It's not, you get again share. Stop it and share again. Have you put all the photos? Now it is come. Secretary.
Now it's showing.
Here now?
Yeah. Now it has come.
Okay.
You want to start again?
Should we start again?
From president you start. From here you start.
Prepare the slides, at least I'll show that.
Yeah. Okay.
So myself and Prasanna want to be relieved from the vice president post. So Dr. Indranil becomes the vice president for the year 2022. Dr. Pramod will be the editor-in-chief, and Dr. Girija and Dr. Jnanendra will be the secretary and treasurer who will be running the office. And these are our new EC members, and we have a mix of experience as well as very dynamic youngsters here. The youngsters being Dr. Ankur Kandelwal and what's his name? Abhijit, na? Subhajit. Yeah, from Subhajit will be representing the East Zone. Ankur will be representing the Central Zone. And we have experience with Dr. Hemant Bhagat from representing the North Zone, Dr. Rahul Yadav from the West Zone, Dr. C. Ganesh from the South Zone, and a most important member, the New Delhi member, Dr. Keshav Goyal, who is responsible for handling the bylaws. He'll be from the New Delhi Zone. So this is a very elite and experienced, and youngsters both are here. Yeah. So this makes a very strong EC, and I hope this will this will create new ideas and new ventures to go through for ISNACC, and ISNACC will become more stronger and stronger in the international arena. So I congratulate the secretary ISNACC 2022 for his wonderful contribution. And the secretary of ISNACC 2023 will be Dr. Padmaja Durga of Hyderabad. So the next conference 2023 will be the physical one, which will be happening at Hyderabad.
Yes.
Sorry, madam, just now send the photo. Dr. Pragati Ganju, madam of Delhi, will be the organizing secretary of ISNACC 2024. And that will be a most important moment in the history of ISNACC, because that is the 25th annual conference of the ISNACC. So it will be a...
just a minute, Dr. Panaya, there's a correction.
Yes, madam.
I'm Dr. Pragati, and the correction is that Dr. Monica and Dr. Girija will be the organizing secretaries. I'm the organizing chairperson of the conference.
Oh, okay.
So yeah, we are doing a pan-Delhi conference. It will be organized by all Delhi hospitals. So we have two organizing secretaries. That is Dr. Monica Tandon and Dr. Girija Rath. I'm the chairperson.
Yeah, sure. Thank you.
Okay.
Madam.
Yeah.
So the 2025 conference is allotted to Thiruvananthapuram, and the organizing secretary of the conference will be Dr. Ajay. So this is a 2023 conference in Hyderabad, and it will happen between 20th to 22nd, Friday, Saturday, Sunday, January 2023 at the AIG Hospitals Auditorium, Gachibowli, Hyderabad. The workshop, the pre-conference workshop, will be on the 19th January 2023. So with this, I thank all the GC members who have contributed immensely to ISNACC and who are finishing their office. And I welcome and congratulate and give the best wishes for the new office bearers, especially the secretary and treasurer, to take ISNACC to greater heights. Thank you.
Thank you, Punaya. So,
thank you,
may I
Dr.
now invite our president, Professor Nidhi Panda, to say something.
Hello.
Hello,
sir.
Hello.
Sir.
Yes, sir. Can I speak ahead of Nidhi Panda? Because once Nidhi Panda tells, then I may not be able to tell something.
Okay, sir.
You can always say at any time, sir.
Yes, sir.
You can always say at any time. They won't say anything.
Thank you very much. I think I want to give full credit to Prasanna and Puneya for paving the way and showing the way how the webinar is conducted. I think we must give full credit to Prasanna and Puneya because last year they organized the conference in a very extraordinary way. I think that is this is one. And number two, I am very happy because we all of us are introspecting. That is a very good thing for our society. And third thing, I think the Bengalis, they become very emotional. Of course, Madam Bibhu Kalyani Das has become totally Bengali, though he is an Odia, because whenever Dasara comes, they become emotional. Dasara means Visarjan. So similarly, all the Bengalis friend of mine, they have become emotional. So don't be emotional. Any good things, whatever good things come in our life, it has to end. But it is, it is ending with a big thank you to all of you. Thank you very much.
Thank you, sir. Thank you.
No attachment.
Can I just speak a few words?
I agree fully with Dr. Das. We should, Uddaya and Prasanna should be given a standing ovation for the work they have done recently.
Yes, standing ovation. Yes.
Thank you, sir.
Venkat sir want to speak. Venkat sir, please.
Yeah, I'd just like to say a couple of things. One, I should congratulate first is the organizing team of 2022 for their excellent conduct of the scientific program and the conference. And second most important is that Panaya and the team did an excellent job for the last 4 years. And I see that everyone has been telling the same thing, but I'm just repeating it again and again that they have done an excellent job. And I'm sure that whatever they have set standards, I think Girija and also will be taking it forward from there. And I thank all the members and ISNACC for giving me opportunity to be part of the governing council for almost close from 2003, apart from a couple of years in between. I've been in the governing council one way or the other, because first I was there for 9 years, later on as organizing secretary, and later on from vice president, and 2 years of extension of past president. And I thank all the members during this whole tenure for, and I had a good interaction with all of them, and I thank everyone for all this. And of course, all the members, and I congratulate the new EC members, the governing council as a whole, and I look forward to be part of it at any point of time to help and be together for the society. Thank you so much, everyone.
Thank you,
Good
sir.
af- Thank you.
Now, please, Nidhi madam, please continue.
Yeah, good afternoon, everyone. Again, I congratulate the organizer of 23rd Annual Conference of ISNACC. A big applause for Bibhu ma'am and their team. And I am thankful from the core of my heart to the members of the ISNACC to give me opportunity to serve as president of the society. And I'm especially thankful to my colleague, Dr. Ponia, Dr. Prasanna, and all the GC members. And as I have already said, that I appreciated their unending effort to start NCSI, Neurocritical Care Society of India, and starting ANC course. That was really a big thing, and without their effort, I was not very sure that we could have started. So thanks a lot. They are always very enthusiastic, very dynamic. So we all have to learn from them these qualities. I also thank all the GC members for their constant support at the time of need and for smooth functioning of the society. Especially, I thank Dr. Venkatesh, Dr. Radha, Dr. Ramesh, because many times we used to take advice from them. and they are always there to give us good advice. My special thanks to Professor Vittal, who has shown us the right path as a founder member of ISNACC, and always he is there to help all of us. I regret that during my tenure we could not conduct governing body meeting because of the COVID and all. But I request the new office bearer to do it as soon as possible. I welcome the new office bearer of the society and wish them all the best to carry the society to a greater height. I ensure the new office bearer and all the members of the ISNACC society that my constant support will be there, and whenever any help or anything is required from me, I am always there for them. All the best. Long live ISNACC. Thank you.
3 cheers for Nidhi Panda. 3 cheers.
Thank you. Thank you. Thank you.
Madam, you may please invite Rajshri Madam and hand over the presidentship and let her give the appreciation, let her give acceptance talk, Madam.
Yeah.
Thank you.
Just 1 minute, just 1 minute. I will show that.
Yes. Thank you.
Madam, I will be sending this to you.
Madam President, may I request you something? Because after you say something, nobody is going to speak. So I will just have a couple of words.
Please go ahead.
Just I wanted to congratulate the organizers
Your video is
as well
not
as
on.
the ISNACC Secretariat for conducting yet another successful virtual conference for the ISNACC, because last year also it was virtual and this year again it is virtual. If you ask me personally, I could hear it fully because most of the lectures I heard, except today because I am having some internet issues. Otherwise, I heard most of the lectures like last time when Prasanna was organizing. So a big thank you to all of you. I also, I would like to join with Dr. Gyanendra Pal Singh, my colleague, to thank the Governing Council of the ISNACC as well as members, and particularly to Pune and Prasanna. Means there are many words to say about them. Just I want to mention here that I'm very proud of them. They were my students. The way they led the ISNACC is amazing, and the way they conducted the ISNACC 2020 and 2021, they made our society by 500 crore, which is quite wonderful. Means our society is quite rich if you think in ISNACC standards. The first one was 26 lakhs from AIMS Delhi. That was in 2011. And after that, yes, there are so many contributions from every organizer. We are hoping also the same thing from Bibhu Madam and Indranil. But then it was huge, 2020, I think. So even it was a virtual conference. In 2021, it was around 7 lakh rupees, which is again amazing. So thank you very much for that. And I also congratulate the newly installed office bearers. And I'm sure together with the ISNACC members, office bearers, and the secretariat, as Pune has mentioned already, that we'll take ISNACC to greater heights with our academics, scientific research, and everything. Thank you very much. Over to you, madam.
Sir, if the president's acceptance speech will be the last, can other office bearers introduce themselves, because it's a virtual mode? So let them introduce. Otherwise, you can introduce the office bearers, the new governing council.
Can I just take 1 minute to invite everyone to ISNACC 2023?
Please. Yes, madam. Yeah, everything will complete that. Yeah.
Yeah. So should I invite everyone right now? Means one by one.
Yes, sir. So that let them introduce themselves, because no people must not.
Can we? Can I? Okay, carry on, please.
Maybe your acceptance speech will be the last, and we'll close.
Yeah. So right.
Okay. So starting with President-elect Dr. Birendra Jain.
You can say a few words.
Yeah. Good afternoon, everyone. It is an immense opportunity which has been given to me by the society and the governing council, and I'll try my best to fulfill all the expectations from me. Thank you.
Dr. Gyanendra. Oh, so Vice President, sorry, Vice President Dr. Indranil Ghosh.
Yeah, thank you for giving me this opportunity to be a part of the Secretariat of ISNACC, and I ensure full cooperation from my side. Thank you all.
Dr. Gyanendra Pal Singh, Treasurer.
Respected seniors and eminent members of the society, my teachers, colleagues, and dear friends, good afternoon to you all. Well, first of all, I would like to thank the organizers of ISNACC 2022 for this grand academic event over the last 3 days, of which we all have been witness to. And I'm sure we all have thoroughly enjoyed this event from the comfort of our home and workplace. It's indeed a tough job, I understand, which require long and untiring efforts to organize such a big event. And the present pandemic has made it even more challenging, I know. Despite all the adversities, I appreciate the present organizing team of ISNACC 2022 that has made it happen, not only to our expectation, but I would say much beyond it. I can congratulate the entire team under the able leadership of Dr. Amna Madam, Dr. Bihu Madam, Dr. Indranil Ghosh, and all others who have contributed to this mega event. I can say this owing to my previous experiences of organizing such event, which need both an able leadership and an efficient team for a successful organization. Once again, congratulations to the entire team. Then I am very thankful to the society for giving me the chance to serve as executive committee member for the last 4 years. Over these 4 years, I contributed for the upliftment of the society in whatever way I could. And I hope I met the expectation of all. Thank you again for giving me this opportunity. And lastly, I am thankful to all the members of this vibrant society for their support and selecting me as a treasurer of this society for the next term. I understand it's a great responsibility you have endured, and we will require will require time and extra effort. But I assure you all that I will be committed to the work given to me, and will try my level best to do to take the society to the greater height, following the path of our predecessors, Dr. Prasanna, Dr. Purnaya, which I think everyone has just said. I endorse the same thing. I'm sure the guidance and blessings of our seniors and good wishes from all of you will help us meet our goal. I pray the Almighty to help me and my team to meet the expectations of the members of this society and to keep the trust bestowed on us by you all. Thank you. Thank you, everyone. Thank you.
Thank you, Dr. Gyanendra. Next is North Zone Representative, Dr. Hemant Bhagat. Dr. Hemant, are you there?
Yeah. Good afternoon, everybody. It's a great pleasure to join ISNACC as an office bearer. And at the outset, I would first like to thank and congratulate the organizing team, Dr. Bibhu Kalyandas, Indranil, and the entire team for such an excellent conduct of a national conference and for the excellent scientific conference. And with the mantle which has been given and started by the founders of ISNACC, and then subsequently the flag was very well carried on by the subsequent members of as an office bearer of ISNACC, I will also strive my best to put on the best to bring about the growth of the society, especially in terms of research and academics. So we hope to have a vibrant society and to take it to the greater heights. Thank you, everybody.
Thank you.
Thank you, Dr. Hemant. South Zone Representative, Dr. Sriganesh Kamath.
Yeah, good afternoon, everyone, and thank you for this opportunity. At the outset, let me again congratulate team ISNACC 2022 led by Dr. Bibhu Madam and Dr. Indranil for a wonderful conference that we enjoyed in the last 3 days. I also take this opportunity to thank the Governing Council of ISNACC led by our President and Secretary, Treasurer, and entire GC, especially Dr. Prasanna and Dr. Purnaya for the efforts, the commitment, the enthusiasm, and the initiative to incorporate new members and widen the teaching faculty for the conferences and academic programs. I also congratulate all the incoming office bearers of ISNACC who will be with whom I will be sharing the next 2 years of my tenure. And I wish the organizing team led by Padmaja Madam a grand success for the next conference to be held at Hyderabad. And I also thank Ajay Rishi who withdrew in my favor for the South Zone. So hope we will take the initiatives of ISNACC further, and I personally and as a team seek the guidance of all the seniors and the members of ISNACC. Thank you.
Thank you, Dr. Sriganesh. The West Zone representative, Dr. Rahul Yadav, please.
Good afternoon, respected teachers, eminent neuroanesthetists, and dear friends. Indeed, a singular honor and privilege to be a part of the governing council as a West Zone executive member. At the outset, I would like to thank Dr. Vibhu Kalani Das and Dr. Indranil for an academic feast over the last 3 days, which we all were enthralled by. And the outgoing executive committee, especially Dr. Punaya and my dear friends Punaya and Prasanna, have done a yeoman job, and I would try my best to lend my helping hand, my best possible efforts to the incoming committee as a governing council member. Thank you, sirs and madams.
Thank you, Dr. Rahul. The Central Zone member, Dr. Ankur Khandelwal. Dr. Ankur.
Good afternoon, everyone. Good afternoon, all the teachers. At the outset, I would like to thank the organizing committee of ISNACC 2022 for this wonderful academic feast. And secondly, I would always be very thankful to the Department of Neuroanesthesiology and Critical Care, AIIMS, Delhi, where I spent almost 5 years, and they never denied to send me to any conferences. That is how I made relations with every faculties, and now I'm fortunate that I'm recognizing everyone in this on the screen. And I'm thankful for giving me this opportunity. I am young and I want to work. That is why I applied for this post. I'm very keen to work, and I want ISNACC to exploit me to the best of their capabilities, to take out my capabilities for the benefit of the society. Thank you very much.
Thank you, Dr. Ankur. Next is Dr. Subhajit. He is from East Zone. Dr. Subhajit, please.
Good afternoon to my respected teachers, seniors, and everyone. I am really grateful to the Governing Council of ISNACC, to all the members of ISNACC, to my teacher, Professor Vibhu Kalani Das Madam, Professor Amna Goswami Madam, Dr. Indranil Ghosh Sir, for keeping faith on me and giving me this opportunity. I will try my best to contribute to my best of my abilities. Long live ISNACC.
Thank you.
Thank you, Dr. Subhajit. Now over to you, Madam. Madam Rajashree Devpujari.
Sir, I will.
Keshav Goyam. Keshav.
Yeah, Keshav.
I'm so sorry. I'm sorry. New Delhi representative, Dr. Keshav Goyal.
Thank you, sir. Thank you, and congratulations for the wonderful conference we had for last these 3 days. And at this outset, I would like to thank all the seniors and the office bearers for giving me this opportunity for being an executive member. I've been working associated closely with Dr. Punia and Prasanna in these last, especially in the ANC, and we'd like to keep it further, and we'll take it to the greater heights. And whatever responsibility has been given to me, I'll try to fulfill with the best of my ability. And one more thing I would like to all the members that in October, we are having a conference, national NCSI, third NCSI. So I invite you all and want all your favor and everything that support and read to conduct this. And hope so we are having lunch and dinner together in that conference. So hope it is a physical one. Thank you.
Thank you. Thank you, Dr.
Padmaja Madam can invite. Padmaja Madam can invite, and then
Dr. Girija sir, on behalf of the editor-in-chief, you can say a few words about the journal, then Dr. Padmaja Madam, then few of the seniors if they want to wish, followed by president handover and acceptance.
Yeah.
Okay. Thank you. Regarding the
Give me a
journal,
minute.
so can I say something?
Yes, sir. Go ahead.
Yeah. So because Dr. Bittal is not here, just I'm representing him. Journal, this is 9th year of our journal, and it is running successfully. And as you know, it is now indexed with 2-3 indexing agencies, which is being recognized by the MCI. Like initially it was Index Copernicus, but Index Copernicus is no more acceptable. So it is DOAJ in the initial stage, and now it is Scopus. Scopus is a big thing to happen. Usually it follows PubMed indexing, but Scopus happened earlier than PubMed indexing. In between we asked for PubMed indexing, but we got rejected. So this year we are again planning to apply for indexing with PubMed Central. So this is what the indexing status is. And as far as the financial status is concerned, I think that we can discuss in the GBM, not here. But we are being supported by the society fully, and society obviously it continued to support the journal, and that is how the source of survival for the journal at present, because we are not getting a good number of sponsors. So this is all about the journal. Now I will invite
Sir, also, if you can announce that this will be the official journal of the NCSA also.
Yes. I would like to mention here that last year we decided that this is the official journal of Neurocritical Care Society of India. And it has been mentioned in the hard copies of the journal, although we are not sending the hard copies right now. Subsequently, means after this pandemic episode is over, we'll start again resending all those hard copies. So it is already there that it is the official publication of both ISNACC and NCSI. That is what the status of the journal right now.
Okay.
So now I invite Dr. Indranil Ghosh and Bibhu Madam and all other seniors who want to speak about the new team, and if you want to congratulate them before we go ahead with the closing speech of the our president.
Yes,
I have one sentence to say.
Yeah.
I have one word to say. I think we all should realize that our strength is a dignified way of working. Dignity is our watchword, so we should maintain, and here this is being honored. Dignity represents ISNACC. Thank you.
Thank you, sir.
I want to also add.
Hi, madam. Shobha, madam.
Shobha, madam.
Yeah. Hi, Punaya and Prasanna. I congratulate for your beautiful tenure. I'm really fond of you, Prasanna. It was nice. And अब जो आए हैं ये भी मेरे बहुत अच्छे हैं, and I know they will bring the society to a big height.
Thank you.
So I must congratulate the new office bearer, and I have special attachment to Dr. Nidhi and Madam Dev Pujari, because Nidhi I took over, and at Madam's conference I inaugurated the 2019. So I congratulate both of you and best wishes to Madam Dev Pujari. I know the next society will gain good heights, more and more. अच्छा आएगा, बहुत अच्छा रहेगा tenure.
With the GC I have. With the GC I have, yes, definitely.
नहीं मैडम, I love our society. अभी जैसे चौधरी सर ने कहा कि it is dignified, I really say our society is really decent and dignified. All credit goes to our senior founder of the society, like Das sir, Madam Mary Ibrahim ma'am, Amna ma'am, Chaudhury sir, Vibhu Kalyani ma'am. All the our teachers are very respected, and they have given a good path to us. And I must congratulate Vibhu ma'am, Indranil, and it was nice to see them, though it was virtual. Amna ma'am ko bhi dekha, it was really nice. बहुत अच्छा लगा, and this time I saw so new faces. delivering the lectures for the first time. It was really good. So again, I congratulate all of you and best wishes to the new office bearers.
Thank you.
you.
Thank you, Shobha, for those kind words regarding our organization. So, and also the organizing committee. Thank you. And I heartily congratulate all the office bearers, incoming office bearers, and also outgoing office bearers with very, I'm thankful. We are so thankful that they have done excellent job during their tenure. Again, another 1 year they have extended, and they have done so many things. So, and Nidhi is so close to me. She is very near and dear. And Rajshri is one of my friends. So we are from before ISNACC, we are friends. Yes. Because Shekhar is is a close friend of mine. So anyway, so I congratulate all of you, all the office bearers, and including Indranil and my Subhajit. So very nice to see them. And
thank you, madam. We are also yours.
Thank you so much. Thank you so much. Yes, all of you are my. So
thank you.
Anyway,
I'll just say a few words.
But Puneya and Prasanna, both of you are in the Neurocritical Society of India. So now you devote more time there, and also bring it up like you have brought ISNACC. Okay, so that is my wish to all of you.
We will try, madam.
Thank you.
I'll just say a few words.
Yes,
yes. Yeah. Congratulations, madam, and Dr. Indranil for the wonderful conference. And as outgoing EC members, I just want to say I was very impressed by the hard work, dedication, and professionalism of the Dr. Prasanna and Dr. Punya. And they have brought the glory to the ISNACC and brought to the new heights. And I'm sure the new office bearers will further make it more greater heights. And best wishes from us. And thank you very much for giving me opportunity to work with you all. Thank you.
Thank you.
Thank you, Dr. Chitra.
Dr. Girija, I just want to thank Dr. Outgoing President, Madam, Dr. Nidhi, Mr. Devpujari, Dr. Punaya, and Dr. Prasanna Bidkar, and all the selection committee who has nominated me for the Distinguished Professional Service Award, which were really, I thank you all from my core of the heart. You given that.
Sir, you deserved it. Sir, you deserved it.
Thank you very much.
So much work in the West.
Thank you very much for whatever you had trusted me and everything. And I wish you all the best for the new governing council. Thank you very much.
Thank you, sir. Anyone else?
Padmaja madam can invite everybody for the.
Padmaja madam.
Yes.
Yeah. On first of all, congratulations to the team ISNACC 2022 for a wonderful conference, and best wishes to the new governing council members. On behalf of the organizing team of ISNACC 2023, which will be held in Hyderabad, I welcome you all to Hyderabad and hope we'll be able to shake hands and have our food together in Hyderabad. As you all know, Hyderabad is, this conference venue would be in Hyderabad, part of the Hyderabad. That is the newer part of conference, Hyderabad. So we will be able to at least show you the developments in the Hyderabad, and also hope that we will be able to showcase the developments in neuroanesthesia as well. I think every year the bar of the conference keeps getting raised, and we hope that we will be able to maintain this quality of the conference. And with the best wishes and blessings from you all, I hope we will be able to hold this conference at Hyderabad physically.
Okay, thank you, madam. Pragati madam, Monica madam. Are they there?
Pragati madam is there.
Yeah, Monica's not here. I don't know if she's here, but 2024 is a bit far away. I think let's concentrate on 23 and next year we'll talk about 24. Yeah.
Okay, madam. Thank you.
Okay.
Thank you. So, Dr. Devpujari?
First, I will.
No, first
I will request.
Madam officially hand over, madam.
Yeah. First of all, again, I want to give my best wishes to Dr. Padmaja Durga to arrange a good conference.
Thank you.
And I'm sure under her able leadership, it will be very good again. And she will again raise the bar of all the conferences. So all the best to Dr. Padmaja. And now I request Madam Rajeshri Devpujari to take the charge of President ISNACC. I want to virtually hand over.
Thank you.
I will send it to you, ma'am.
Yeah. Somebody please take a photograph.
Already.
Thank you. Thank you very much.
And I'm sure under your leadership, ISNACC will rise to great heights. So, congratulations to the new office bearers. Thank you.
Thank you.
Can the backend team pin the past president and the current president in the screen?
Same, together. Only two of them.
Indranil, can somebody do that? Yeah, backend team. Yeah.
I'm not able to do that. I'm in a mobile.
No, sir. The event manager.
Sir, the event manager will do.
Event manager.
Cubics team has to do.
It's okay.
All right.
No, it is not okay. It is not okay for us.
Cubics team, are you there?
They are also tired and.
Yes, they are there. I'm
they are
just
there. They will
asking
do it.
them.
Yeah. Can
Asking
they do that
them to
one?
do that. Okay. Just a minute.
Sorry, Panna, I didn't get what
Yeah.
you.
They pinned it.
Nice,
Very good. Yes.
Nice. Really looking good. Yeah.
Thank you.
Very good. দুজনের একসঙ্গে।
Okay.
Very good.
Madam.
Thank you, Dr.
Madam,
Nidhi.
your acceptance speech. Yeah.
Thank you, Dr. Nidhi. Please bear with me, everyone, for 2 or 3 minutes. I just thank Dr. Nidhi and our secretariat, previous secretariat of Dr. Punaya and Dr. Prasanna for doing a wonderful job for all these years. Now, this is a great honor bestowed on me to take up the responsibility as President of India, President of the Indian Society of Neuroanesthesia and Neurocritical Care. Let us reminisce. ISNACC started in the 1990 period. A small group of neuroanesthesiologists headed by Dr. Dash in Delhi took up the challenge to start this big society, ISNACC. This was a great initiative to celebrate the decade of the brain. Now, in its 23 years of existence, ISNACC has scaled great heights of professional and academic excellence. I thank and congratulate all the stalwarts of our society who have worked hard and spared no efforts to make it one of the best and the leading neuroanesthesia and neurocritical societies in the world. However, recently, we've had a very uncertain 2 years of COVID-19 pandemic, which made the whole medical world change their set norms of practice and face unforeseen challenges. So did the neuroanesthetist and the intensivist. Overnight, we had to change our set patterns of patient management care. And as COVID-19 disease rapidly evolved and is still evolving, we needed to change our set patterns. Not only did COVID-19 pose a threat to all persons all over the world, but it posed more challenges to the neurologically impaired patient who were more vulnerable with worse outcomes. It also posed many challenges of safety for the neuroanesthetist and the intensivist. Our society, ISNACC, rose to these challenges. Luminaries of our society got together and with their expertise quickly published the NCSI and the ISNACC joint position statement and advisory on the practice of neurocritical care during COVID-19 pandemic. And the other one was the ISNACC position statement and advisory for the practice of neuroanesthesia during COVID-19. This was endorsed by the ISA. Both these consensus statements were published by July 2020 in JNAC and widely circulated. These guidelines benefited many of us and us safe. Our secretariat did not stop with that. They went ahead with all the scheduled academics projects, exams, conference. Teaching online with classroom was a big savior for the students all over the nation. Exams were conducted on schedule. All teachers, students quickly adapted to the virtual and teaching sessions. Research went ahead, DM, DNB, PDF in neuroanesthesia, neurocritical care, stuck to their timetables and went ahead with ease. And it is a no-brainer to say that this was the big effort of our secretariat under the able hand of Dr. Punaya and Dr. Prasanna. Our secretariat also went ahead with online conferences, the ISNACC 2021, the NCSI 2021, both were held virtually and great success. Our acute neurocare program was also held recently and was again a big success. Such is the society I inherit, such is the society I have to lead. I accept this responsibility. I thank our past president, Dr. Nidhi Panda, and as also our secretariat, Dr. Punaya, and our treasurers. Dr. Bibu and Dr. Anil have vocalized very well what the secretariat has done for us. And so have all the others. And it was a very popular and a very successful time for ISNACC, those 3 crucial years. The secretariat increased the membership, organized excellent physical and virtual conferences quite efficiently. They generally raised the bar for a society, not only academically, but also financially made a society very viable. I will do all in my powers to achieve the goals set by ISNACC. Now, in my tenure, we will try to increase the membership of the society. There's another thing that neurosurgery practice is increasing, and many of the surgeons have started working in smaller cities, towns, and the requirement for trained neuroanesthetists and intensivists is increasing. Our society will encourage the training courses to evolve and involve more anesthesiologists and intensivists. ISNACC will not only encourage collaborative academic activity and research activity internationally, as we saw in the just a few minutes ago when we had a webinar on ICP&T. Dr. Dash made his ideas clear, and he also said one very important thing, that we have to raise our standards, and ISNACC by itself can do a lot for the national institutes. There are wonderful institutes in this country with very great academic skills, and they can do a lot for smaller institutes, mentor many people, mentor many anesthetists. They are already doing a very good job, and I would, with my GC, continue this wonderful job. We have very good GC members. Now, as the uncertain medical challenges of the pandemic continue evolving, we will also continue to evolve, change our standards, put in guidelines as and when we can do that. ISNACC has taken important programs on their plate with evolving guidelines for preoperative care and other things. So we can continue with that. I welcome the new GC members. I welcome and introduce Dr. Girja, our secretary, Dr. Gyanendra, our treasurer, and the different GC people from different zones of our country. Dr. Birendra Jain, elected president-elect, Dr. Hemant Bhagat, Dr. Rahul, Dr. Ankur Khandelwal, Dr. Sri Ganesh, Dr. Keshav Goyal, Dr. Shubhajit, and Dr. Indranil. I couldn't have asked for a better GC. I feel one of the, I mean, each one is a stalwart in their own institute, as well as in the country and internationally renowned. So welcome, and I hope that we will take this responsibility which is given to me ahead with us. There is another thing that due to emergent constraints of COVID-19, we have not been able to hold the GBM for 2 consecutive years. I urge the Secretariat to arrange a GBM early and on a virtual platform as deemed necessary. Last but not the least, I would like to thank the organizers of this esteemed conference, the virtual conference, Kolkata 2022, ISNACC Kolkata 2022. A wonderful conference, a wonderful, I mean, experience for all encompassing not only the seniors, it was also a big pleasure to see many new faces, many juniors delivering and deliberating so excellently. I thank Dr. Bibhu Kalyanidas, I thank Dr. Indranil, and I thank the whole team, Jayati, and the others. I thank you very much. Jai Hind and Jai ISNACC.
Now you can adjourn the meeting, madam. Pune, is it all right?
Yes, sir.
Yeah, please stand by for the national anthem.
National anthem and then adjourn.
जनगण मन अधिनायक जय हे भारत भाग्य विधाता पंजाब सिंध गुजरात मराठा कावेरी उत्कल गंगा हिमाचल यमुना जल तव शुभ नामे तव शुभ जन भारत भाग्य विधाता जय 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 जय
Yes.
Thank you all. So I think many thanks for joining us for this meet, and see you all of you physically at Hyderabad.
Thank you.
Thank you, madam.
Thank you. And Sekha. Congratulations.
Congratulations,
both
madam.
of you.
Thank you.
You are the backbone.
Thank you.
Welcome all of you to Hyderabad.
Yeah.
And I just
Congratulations.
I think the recording can stop. The
Yeah.
recording team, if somebody is to continue discussion, they can do. Yeah. Conference is officially over.
Thank you.
Thank you, everyone.
Thank you, Prasanna. Take care.
Thank you, madam.
Thank you.
Thank you,
Thank you, madam. Thank you, sir. Venkat, sir.
Thank you.
Thank you. Bye.
Bye, sir. Bye.
you.
Bye.
Bye.
All the best, Padmaja.
Thank you, Nidhi. Thanks a lot.
Thank you, Girija sir and Gyanendra. Thank you.
Madam,
Thank
Padmaja
you.
madam, please take care of the registration fees because it's a bit looking very odd, madam. The 2,000 rupees increase.
Okay, sure. I'll
Only, yeah, because it's more than the 10%.
Otherwise, 9,000 and 9,500 seems very odd number. So I just put it at 10. Maybe I'll revise it and send it.
Yeah.
1,000 is fine.
Thank you, everyone. Take care and be safe. Let us not go beyond Omicron.
Hopefully.
Prasanna, you are all right now?
Yes, sir. Yes, sir. Absolutely fine. Absolutely fine.
Dr. Punia, what is coming out of your head? Some
Light.
Light.
Enlightenment.
Enlightenment. Like
That,
Lord,
that's true, Goda. That's true.
yeah, Hindu
Buddha?
gods used to have that.
Enlightened
Halo,
beings.
halo.
Yeah.
Have you noticed that?
Halo, halo.
Enlightened beings.
You are spreading light.
Yeah.
Spreading light.
No, sir,
Nothing
that is
great.
the background glass, I think. Sun.
But that's looking nice. Right? You can put it in a DP.
Okay, thank you, sir. Thank you.
Thank you, sir, Professor
Thank you.
Chaudhury.
Thank you, everyone.
Thank you, ma'am.
Chaudhury.
Yeah,
Thank you, madam.
sir.
Thank you.
Thank you.
Nidhi, thank you.
Thank you.
Bye-bye.
Thank you.
Bibi,
Okay,
ma'am, the last time we held a conference, you told me like this is a shagun for me. So, I hope those
Yeah.
blessings
You
continue.
are the head of
Oh,
the
no.
team. You were the head of the team.
Yeah. Thank you.
Well done. Well done.
Yeah.
Bye.
Yeah, Padmaja, any help, you can just give me a call.
Thank you.
Okay.
Padmaja, all the best.
Thank you, ma'am.
Padmaja,
I'm
even
also
we-
there. I'm also there. Anything,
Yeah.
I
anything
can
you
count on all of you.
Yeah, Viswanath is a neurodm working in Yashoda.
Yeah, sure.
He's a nice boy. So you can fill him also. Okay.
Okay,
Thank you.
bye-bye,
Thank you.
bye-bye,
Bye.
bye-bye.
Bye.
Thank you.
Thank you.
Bye.